Hi friends, myself Dr. Ayush and I am your surgery faculty at Global Academy of Medical Education. So now for the next 3 days we shall be discussing the important core topics for the Inicet. So how I've structured your course for the next 3 days is, for day 1 we are going to discuss mainly focusing on trauma and general surgery. Then for your day 2 we have your GIT discussion, and for your day 3 we have mainly your urology, then you have your endocrinology and your miscellaneous topics. So you would be asking me why such a division. So let me tell you, trauma and general surgery usually gives you 5 to 6 question, GIT alone gives you 7 to 8 question. The remaining questions come from uro, endocrine and with the miscellaneous, which would include your plastic, neuro and the other topics. So today being the day 1, we shall be mainly focusing on the trauma and the general surgery. So the discussion of our surgery series would include your previous year questions specifically asked in your last 2 to 3 sessions. So we'll be focusing on those important topics, the questions that have been asked and that can be asked again in your upcoming exam by focusing on the some core addition topics associated with it. So now without wasting any further time, let's begin our discussion. So we'll begin our discussion with trauma. Be it any exam, it's very important, and when it comes down to INI exam, trust me, trauma is a very important topic. The questions can come as straightforward, simple questions, or it could be some tricky questions. So the first question that we have is, you are on floor duty doctor in trauma triage. So which is correctly matched with respect to the triage. Now AIIMS have this tendency to ask you questions which are based on your clinical scenarios that you come in your day-to-day life. So being an intern, you must have come across this situation. So your options are red being urgent, yellow being non-urgent, C both, D none. So before answering this question, let's understand the important concept, right? So what is triage? Triage means to sort, and it is the cornerstone of the management of your mass casualties. So the main aim of the triage is to identify patients who will benefit most by being treated earliest. So there are 4 categories of triage. The first category, you have your red color. Now what does red mean? It means you have your immediate medical need. So the clinical status of such patient is critical, but they would survive if your treatment is given early. So what would be your examples? The examples would include like severe facial trauma, tension pneumothorax, profuse external bleeding, hemothorax, then you have your flail chest, major intra-abdominal bleed and your extradural hematoma. So these are your red categories where the patient is critical, but then they are likely to survive if the treatment is given early. Then your second category comes down to be yellow. Yellow means urgent. So what is urgent? They are critical and they are likely to survive even if the treatment is given within hours. For example, compound fractures, degloving injuries, ruptured abdominal viscers, pelvic fractures and spinal injuries, right? So over here in yellow, the patient can still wait for hours, whereas in case of red, you need to give your immediate treatment. Then we have your third category, which is your green, that is your non-urgent. So this is stable, likely to survive even if treatment is delayed for hours to days, like simple fractures, sprains and minor lacerations. Then we have the last category, which is your black. Now these are your unsalvageable, that is there is no breathing, pulselessness, so severely injured that no medical care is likely going to help the patient. Now what are the examples of this? You have your severe brain damage, very extensive burn, major disruption, loss of chest or abdominal wall structures, right? So coming back to the question, red urgent, no, red is your immediate. Yellow non-urgent, no, it is urgent. Then non-urgent is your green. So the answer over here is none, right? So this was the question that was asked. So now what are the various questions that can be formed from this? You could be asked regarding your examples for it. Say the severe facial trauma belongs to which category? It belongs to the red color coded. Now as we told, we'll be going a step ahead. So there is this triage tags. I would want you all to remember these images. This could be asked as your image based question, where you have this particular tag, which is your American Civil Defense System, and then you have your disaster management system tag, which is this particular image, right? So these are your triage tags that are often used in your trauma center. So this is all about your first question. Now moving down to the next question, we have, what is the first step in the management of your RTA? Right, now this is a basic question, but still we'll solve this because many of your students had made mistake in this question when they had discussed this. So the options given you are IV line, cervical spine, damage control surgery, intubation. Right, damage control surgery itself is a very important topic which we shall be discussing in one of our questions. So now coming down to this question, please remember the basic principles of your trauma is your C, A, B, C, D, E. Right, this is what we follow, the ATLS guideline. There is no deviation out from it. Now what is your CABCD? C is your control of massive external hemorrhage. A is your airway with cervical spine protection. B is your breathing and ventilation. C is your circulation and hemorrhage control. We apply a pelvic binder and do not remove until a pelvic fracture is excluded. D is your disability and E is your exposure. So now on the basis of this particular knowledge, your previous this question can be solved. So your first step would come definitely the cervical spine. Had there been an exaggerating hemorrhage, then yes, we would have marked the answer as exaggerating hemorrhage. So coming back to the CABCD of trauma care, now this is a very important topic. So let's discuss in details regarding your CABCD of the trauma. So first we have your exaggerating external hemorrhage. So now this needs to be controlled even before the airway is managed. How can we achieve it? By application of packs. Then we can have pressure, hemostatic dressing, which alters the coagulation, and tourniquet application. But when we apply the tourniquet, we need to remember that it has to be time controlled because it causes a risk of ischemia. Then coming down to the airway with cervical spine control, the cervical spine needs to be immobilized. Then the compromised airway has to be cleared with the stepwise progression. That first it has to be clearing the airway from your secretions or any blood. Then we have some simple airway maneuvers. Now please remember this image, as this images can be asked to you directly in your exam. So first is your jaw thrust, and then you have your chin lift. Right. If the airway is not cleared with the help of this maneuvers, then we go with the use of your oropharyngeal and the nasopharyngeal airway. On that failure, we go for your advanced airway maneuvers. Now this is using a curved endotracheal tube and may require anesthetic with a rapid sequence intubation or the surgical airway in form of a tracheostomy or a cricothyroidotomy. Now coming down to the next component, which is your breathing and ventilation. We have your high flow oxygen, and we need to do the diagnosis and the management of the life threatening pathologies. Now this life threatening pathologies are very important. We shall be discussing them under the deadly dozer. So I have a question placed for you in term, I think from thoracic trauma. So we shall be discussing the life threatening pathologies over there. Then we come down to the circulation and hemorrhage control. Now it has to be done with the IV access with 2 large bore IV cannula. Please remember each and every important line, because they may just frame a question like how many large bore IV cannula would be required. So you need 2 large bore IV cannula, blood for cross match and lab assessment, and the assessment of hemodynamic status. How will you achieve this hemodynamic status assessment? By seeing the skin, which may be cool or clammy, low BP, and pulse rate may be raised. Then all hemodynamically unstable patient must receive a pelvic binder. Again, a very important true and false statement. All hemodynamic patient should receive a pelvic binder. That each hypotensive trauma patient should be treated as a hypovolumic shock unless proven otherwise. Again, under one important one-liner which can be asked you as a true or false statement. A hypovolumic shock, hypotensive trauma unless proven otherwise. Now, the priority is simultaneous fluid resuscitation and identify the site of hemorrhage. Now, the initial aim is your blood supply to the vital organs. Now comes the next question, what is your target blood pressure? The target blood pressure is your 70 to 90 mm of Hg. However, if you are suspecting a traumatic brain injury, then you have your target blood pressure more than 90 mm of Hg. Then another question that is asked to you is regarding your massive transfusion protocol. Now it includes your one portion of pancreatic cell, one portion of FFP, and one portion of your platelet. So please remember 1:1:1. This is your massive transfusion protocol. Then regarding the use of excess of IV fluid, the answer is no. Why? Because we need to avoid the hemodilution, to avoid the dilutional coagulopathy, and to prevent your respiratory distress. Then we have an important drug which is your tranexamic acid. Now this is an antifibrinolytic drug. Why do we need to use it? Because it decreases your risk of mortality and your morbidity. Now when it should be given? Within 3 hours of trauma. Another important MCQ. Now which patients are your candidates for receiving tranexamic acid? Please remember, it is when the patient has a systolic blood pressure less than 110, heart rate more than 110 per minute. These are your patients where you would be giving your tranexamic acid. Now that brings us to the next question, what is your dose of tranexamic acid? Now it is given 1 gram IV over 10 minutes followed by your 1 gram dose over 8 hours. An important additional point that I would like to talk with you guys is regarding your crash trial. So crash trial is associated with the use of tranexamic acid in your trauma. Then we have your disability assessment. Now this GCS. Now GCS is very important, where you can expect at least a question coming every alternate session from GCS. So GCS is your Glasgow Coma scale. Now we'll be discussing regarding your Glasgow Coma scale when we'll be discussing your traumatic brain injury. Then it would also include your pupil assessment and your AVPU, AFPU. So what is AFPU? Alert, response to verbal command, response to pain, and unresponsive. Then you have your exposure, which is an exposure in your control environment to prevent hypothermia, and examination for any other injuries. So these are your some of the basic points and important concepts from your C, A, B, C, D, E. Any trauma question basics, we should not make a mistake. So these are your some important one-liners that can be framed, or they can frame a lot of concept based question by just putting you as the frontline doctor in a trauma care center, asking you what would be done next, right? So this is all about this question. Now moving down to the next question, which is your life-threatening injury identified during your breathing component, right? So this is a question from your thoracic trauma. Now before coming down to this question, I'll again take the next question, which is again on your thoracic trauma. That is, patient presents to you with RTA. On examination, chest movements are reduced on the right side, tracheal deviation on the left, distended neck veins. What is your next step, right? So we'll discuss these two questions after discussing a few important points on your thoracic trauma. we begin a discussion on this thoracic trauma with this deadly dozen. Now, in your recent edition of Bailey and Love, this deadly dozen is divided into two groups. One is your immediately life-threatening and another is your potentially life-threatening. Now, in your immediately life-threatening, they have put your airway obstruction, tension pneumothorax, pericardial tamponade, open pneumothorax, massive hemothorax and flail chest. Now, potentially life-threatening includes aortic injuries, tracheobronchial injuries, myocardial contusion, rupture of the diaphragm, esophageal injuries and your pulmonary contusion. Now, whereas in your ATLS 10th edition, the main confusion comes in your tracheobronchial injuries, which they have put in your immediately life-threatening injuries, and your flail chest, which they have put in your potentially life-threatening injury. Now comes the big confusion. Which one should you go for? Bailey and Love 20th edition or ATLS 10th edition? As far as AIIMS is concerned, they usually follow the ATLS guideline. So I would suggest you all to stick with the ATLS 10th edition guideline. Right. Regarding your immediately life-threatening injuries, where you should include your tracheobronchial injuries in your immediately life-threatening injuries and your flail chest in your potentially life-threatening injuries. Now, coming down to the specific discussion of few of the thoracic trauma, we'll have the first discussion on the tension pneumothorax. It is a very important topic. Now, what happens over here? One way valve air leak through the lung or the pleural wall, which causes your air force into the pleural space, as a result of which there is no escape route, leading to the collapsing of the affected lung. Now, the mediastinum is displaced to opposite side, decreasing your venous return and compressing your opposite lung. So, if you look at this particular description, this will help you to solve the clinical scenario which was given to you. Right. Now, then the shock, the most common shock is your obstructive shock over here, and the most common cause of tension pneumothorax is your mechanical positive pressure ventilation in patients with your visceral pleural injury. Now, it is a clinical diagnosis and hence there should not be delay in your radiological examination. Now, how would be the manifestation? In a case of mechanically ventilated patient, they may present to you with a hemodynamic collapse, whereas in case of your spontaneous breathing, they may present with your tachypnea and air hunger. Now, other clinical features which are going to give you a clinical clue in clinching your diagnosis include chest pain, air hunger, tachypnea, respiratory distress, tachycardia, hypotension, unilateral absence of breath sounds, neck wind distension and cyanosis. So, if you imagine the clinical picture out there which was given you in the question, they all fall into this particular category, which is of your tension pneumothorax. Now, we have this image over here. Please remember this image. So, they may give you a clinical based scenario or they may give you a clinical based image asking you to solve it. So, this is your radiological appearance of a tension pneumothorax. Now, what would be your treatment? Now, the treatment would include your immediate needle decompression at your 5th intercostal space, followed by your tube thoracostomy, which is again at the 5th intercostal space. Now, another important question that is asked over here is regarding your triangle of safety. Now, where would you put this chest drain? So, it is done at your triangle of safety. Now, what are your boundaries of triangle of safety? So, if you look at this image, this is your triangle of safety, which is bounded posteriorly by your latimus dorsi, anteriorly by your lateral border of pectoralis major, and inferiorly it is bordered by your line perpendicular to the nipple going to the back and just anterior to your mid axillary line. So, this is a few important points regarding your tension pneumothorax. Now, another important point that I would like to discuss is regarding your tracheobronchial injury. So, where does it occur? It occurs within the 1 inch, that is 2 to 4 centimeter of carina. It is severe and majority patients die at the scene. Now the clinical features would include your hemoptysis, cervical subcutaneous emphysema, tension pneumothorax, cyanosis, and your incomplete expansion of the lung and continued air leak even after placement of the chest tube. So there might be requirement of the placement of more than one chest tube. So these are your clinical clues in clinching your diagnosis to your tracheobronchial injury. Then how do you form the diagnosis? With the help of a bronchoscopy, and the treatment would be your definitive airway, which would include your fiber optic assisted endotracheal intubation. Now next important concept is regarding your open pneumothorax, which is also known as your sucking chest wound. Now it is the equilibrium between the atmospheric pressure and your pleural pressure. So the opening in the chest wall must be more than 2/3 diameter of the trachea. So air passes preferentially through the chest wall defect with each inspiration. Now the defect size is more than 3 centimeter, and the treatment is closure of the wound on your 3 sides, right? So please remember, as I have mentioned over here, no forceps, because it will eventually lead to your tension pneumothorax, right? So this is a dressing for the treatment of open pneumothorax, where you usually put it on your 3 sides. Now the next important topic in your thoracic trauma is your differentiation of your tension pneumothorax with your massive hemothorax. So these are your criteria. In case of breath sound, it might be decreased in both. Percussion, a tension pneumothorax would be hyper resonant, whereas it would be dull in case of massive hemothorax. Then the tracheal position would be deviated in your tension pneumothorax. The neck veins would be distended in your tension pneumothorax, whereas it may be collapsed in your massive hemothorax, and your chest movement would be expanded, immobile in case of your tension pneumothorax, and in case of massive hemothorax it would be mobile. Now management of a massive hemothorax would include your restoring blood volume and decompressing chest cavity, whereas thoracotomy would be required if there is more than 1500 ml loss of blood, or there is more than 200 ml loss for 3 hours. Please remember that there is no role of clamping. Now regarding cardiac tamponade, now this is the compression of the heart because of the accumulation of the fluid in the pericardial sac. Now the most common cause is your penetrating trauma. Now the clinical triad is your Beck's triad. Now this is again asked as an important MCQ, which includes your muffled heart sound, hypotension, and distended neck veins. Now associated with Kussmaul sign, which is rise in the venous pressure when the breathing spontaneously. Now important differentiation between your tension pneumothorax and your cardiac tamponade is hyperresonance on percussion and presence of bilateral breath sound in case of cardiac tamponade. Please remember that currently there is no role of pericardiocentesis, and the treatment is your operative by your sternotomy or your left anterolateral thoracotomy. Now a few important points regarding your emergency department thoracotomy. The main aim is your internal cardiac massage in your cardiovascular refulpation, control of hemorrhage from injury to heart or lung, control of massive air leak, clamping of thoracic aorta to preserve the blood supply to heart and brain, then cutting off the arterial supply distally in moribund patient with major distal penetrating injury. So this particular point could come as your all of the following statements are true, except, or they might be asking you all of the above, right? Now another important point with respect to your emergency department thoracotomy is when it is considered to be futile. So it is CPR for more than 15 minutes in presence of penetrating thoracic trauma, for more than 10 minutes in case of blunt, and blunt trauma when there have been no signs of life, right? Now we have this important diagram for traumatic circulatory arrest, but then I'll not discuss this in detail. Rather, I would like to discuss the flail chest. So the flail chest, now all my discussion regarding the thoracic trauma have been centered around your ATLS guidelines from the current edition, which is your 10th edition. So if you find any discrepancy between this and your Bayesian love, I would still suggest you to stick to your 10th edition ATLS guideline. Now regarding your flail chest, now what is a flail chest? So if you see, it is the fracture of 2 or more adjacent ribs in 2 or more places. Now it can also occur in your costochondral separation of a single rib from thorax. Now this itself forms an important one-liner. They might give you a question, which of the following is true, except, and you might think this to be the answer no. So please remember, this is also included in the definition of your flail chest. Now regarding the paradoxal respiration, so what happened? Flail's chest segment lie loose from the chest wall, as a result of which what happens is, during inspiration, flail segment will not move out with the rest of the chest wall, instead drawn in due to negative intrathoracic pressure, whereas in case of expiration, as the chest recoils because of the positive intrathoracic pressure, the segment is pushed out. Now this is your paradoxical respiration, which prevents the gaseous exchange, causing your hypoxemia. Now the treatment would include your administration of humidified oxygen, ventilation, fluid resuscitation, and your analgesia. So now coming back to the questions. So in this question, if you look over here, if we go as per the latest guideline, laryngotracheal and tension pneumothorax. So these are your 2 life-threatening injury. So you would be saying both are your correct answers, but no, you need to read the entire question carefully. Please look over here, breathing component. So when they have mentioned the breathing component, the answer is your tension pneumothorax, right? So this was a very confusing question. Please just do not jump seeing the life-threatening injury. Laryngotracheal injury is also a life-threatening injury as per the ATLS 10 guidelines. So guys, why is this not? Because you will be looking this at the airway component, right? But now you are looking at the breathing component. For breathing component, we have your tension pneumothorax. So please remember your deadly dozen. Now moving down to the next question that we had, RTA, chest movements reduced on the right side, tracheal deviation, another important clue, distended neck veins, again important clue. What are you forming? You are forming a diagnosis of, yes, tension pneumothorax. Are we going to perform X-ray immediately? No, it is a clinical diagnosis. We will not wait for our radiological evaluation. Will perform a thoracotomy? Not now, it is not needed. Now ICD placement or needle thoracocentesis. Please remember, look at the question, they are not asking you for the best. Next step, you know it is a tension pneumothorax, so you will go for immediately for your needle thoracocentesis. Where will you go? Please remember, it will be at the 5th intercostal space. The classical teaching of the 2nd intercostal space is gone, and the current editions mentioned the 5th intercostal space. So your answer is your needle thoracocentesis over here, and we have your tension pneumothorax as the answer over here, right? So this is with respect to your thoracic trauma. Now moving down to the next question that we have is, a 78-year-old lady has a history of fall and developed headache and neurological symptom few days later. What is your diagnosis? Right, EDH, SDH, contusion and DAI. So each of these following options are very important, right? Now before going into it, the proper head trauma, let's discuss few important concepts and then we shift our discussion into EDH, SDH, contusion, DI. So in head trauma, the few important basics, which are the one-liners that are asked to you regarding your normal cerebral blood flow. Now what is the normal cerebral blood flow? It is 55 ml per minute per 100 gram of brain tissue. When would ischemia occur? The value is less than 20 ml. Now remember that the flow depends upon the cerebral perfusion pressure. Now what is the normal value of your cerebral perfusion pressure? It is 75 to 105 mm of Hg. Now the difference between your mean arterial pressure and your intracranial pressure is your CPP. So please remember this equation. Now this has been asked multiple times in your exam and it can be repeated. Now they can ask you the various values, or they might again ask you the same question in respect to your equation for your cerebral perfusion pressure. Now regarding your cerebral autoregulation, a constant cerebral blood flow is maintained across the range of your MAP, which is your 50 to 150 mm of Hg. Now regarding your Monro-Kelly doctrine, now this is a cranium rigid box which is nearly incompressible brain. So it states that the cranium is a rigid box where we have a nearly incompressible brain, and any expansion in the contents, be it a hematoma or a brain swelling, it is accommodated by the exclusion of your fluid components, venous blood and CSF. Now because of the further rise, there would be an exponential rise in your intracranial pressure, leading to your cerebral herniation. So if you look at this particular image, there would be a point of decompensation, after which there would be your brain herniation. Now please remember this particular doctrine, so they can directly ask you. Monro-Kelly doctrine is used for traumatic brain injuries. Right, now this is your further important diagram regarding your brain herniation. So please remember, you have yours first is your sulfalcine herniation, then and you can see in your second where you have your prominent midline shift, then we have your uncal herniation over here. Now what happens in your uncal herniation? You have your pupillary abnormalities. Then we have your cerebral tonsillar herniation, which is your through foramen magnum, which causes the compression of the vasomotor respiratory center. Now this leads to the Cushing triad. Now this again itself is a very important question. Now the Cushing triad is your hypertension, bradycardia and your irregular respiration. So coming down to the head trauma proper. So be it any case of head trauma, one important thing that you guys cannot forget is regarding your Glasgow Coma scale. So if you look at this revised Glasgow Coma scale, which is taken from your AT-Liston edition, we have your eye opening. So a score of 4 is given for a spontaneous eye opening, to sound is 3, to pressure is 2 and none is 1, and non-testable, that is been added in your new scale, which is denoted by your NT. Then we have your purple response. So we have oriented, which is 5. If the patient is confused, then it is 4. If the patient is able to say words, then it is 3. If the patient is making some sounds, it is 2. And if the patient is not able to say anything, then it is 1. And again, non-testable would be NT. Then you have your best motor response. Now, why we say the best motor response? Because if in one limb we have a localizing and in the other limb we have a normal flexion, we would be taking the best motor response. So the best motor response includes the obey's command, that is 6, localizing 5, normal flexion 4, abnormal flexion 3, extension 2, none 1, and non-testable would be NT. So the minimum GCS score that is possible is 3 and max that is possible is 15. So please remember this important concepts, as they can be asked again as one-liners. Now the recent Paleo of Love has given you this pediatric Glasgow Coma scale score. So please expect that now the clinical scenarios can be asked you using your child presenting to you with trauma. The eye opening would be essentially same. The verbal response would be coos or babbles, a score of 5, irritable cries, a score of 4, cries in response to pain, a score of 3, moans in response to pain, a score of 2, and no response will be given a score of 1. In case of motor response, purposeful or spontaneous movement 6, withdraws to touch 5, withdraws to pain 4, flexes to pain 3, extensive to pain 2, and no response is 1. So this is all about your pediatric glaucoma scale score. Now another important question that is asked is regarding your severity of head injury, which is your clinical classification. A minor injury, it is GCS 15 with no loss of consciousness, a mild, which is GCS 14 to 15 with loss of consciousness, and moderate, which is GCS 9 to 13 with or without loss of consciousness, and severe is GCS of 3 to 8. Now another important question that is asked is regarding your indications of CD within 1 hour. So this has been taken from your Bailey and Love table, which is GCS less than 30 at any point, GCS less than 15 at 2 hours, a focal neurological deficit, suspected open, depressed and basal skull fracture, more than 1 episode of vomiting, and post-traumatic seizures, right? So they could be a question being framed, which of the following are the indications of the CD within 1 hour, except or ask you give you a lot of ABC options, and D being all of the above. So you need to please remember the commonly made mistakes over here are at this point GCS less than 13 at any point, at 2 hours is GCS less than 15, and more than 1 episode of vomiting. Now indications of CT imaging within 8 hours would be age more than 65 years, coagulopathy, dangerous mechanism of injury, and retrograde amnesia more than 30 minutes. Please again remember the retrograde. These are your most important options, which they confuse by adding your antegrade amnesia. So now coming down to the proper discussion of the brain trauma. First we have your skull wall fracture, which could be your closed linear, which can be managed conservatively, or open or comminuted fracture, which will require debridement and your prophylactic antibiotics. Then your depressed skull fracture would be your inward displacement of your bone fragment, where you have your high chances of infection leading to neurological deficit and your late onset epilepsy. Now exploration and elevation would be required because of the intracranial air, which is pointing to breach in your dura mater. So if you look over here, a right frontal comminuted depressed skull fracture with a linear undisplaced fracture of the right parietal bone. Now we have your few important questions regarding your skull base fracture. Now it is the bleeding or the CSF leak from the ears or the nose. Now please remember this important sign, which is your battle sign, which is your bruising behind the ear. Then you have your bruising around the eyes, which is your panda sign. Now the CSF leak usually resolves spontaneously. Now if there are persistent leak, then your meningitis may occur and it would require repair. Now CSF leak, the most important test that I would want you all to remember is your beta 2 transferrin. Now and another point is your blind nasogastric tube insertion is contraindicated. Please remember beta 2. In options they might confuse by giving beta 1 transferrin. No, the answer would remain beta 2 transferrin. Now some important specific traumas which we come across in our questions. Now extradural hematoma. So if you look over here, it is the linear skull fracture, tear of dural vessels, arterial bleed. Then the most common is your anterior branch of your middle meningeal artery, the most common location being your temporoparietal. On CT you would have a biconvex image. Now please remember this image. This has been asked multiple number of times and it can be still repeated in your upcoming exam. Now there are various ways to frame this question. One would be a direct framing. Second would be a clinical scenario, where they would be giving you a clinical scenario where a patient has presented to you with a road traffic accident and you have a lucid interval and a linear skull fracture. What is your diagnosis on the basis of CT image, right? Or there could be an anatomical correlation, which I have put in my test over here. So right, the conservative treatment for this EDH would be less than 30 ml, less than 5 mm thick clot, less than 5 midline shift, GCS more than 8. Now it would usually have your contralateral hemiparesis and ipsilateral pupillary dilation. Now the surgery involved would be your craniotomy. Now if you look over here, the subdural hematoma, acute presence at 3 days, subacute presence at 4 to 21 days, and chronic for more than 21 days. It is also known as your pachymeningitis hemorrhagica interna. So if you look over here, this is your acute bleed, and the blue image is showing your chronic bleed. Now the important lines which are going to distinguish your SDH with your EDH include that they are going to cross suture line, they are the tear of the bridging veins, they occur over your cerebral convexities, and they usually are your concavo-convex. Now the treatment would include, if it is acute, a surgical evacuation, and in case of old age it would require a conservative treatment. Now in case of your chronic, a small bleed would be requiring a conservative, whereas your burr hole drainage would be required in case of your major bleeds. Now why have we discussed over here all these points? Please remember, SDH could be again asked as a clinical scenario, or they could be asked as the question that we were discussing right now. After a long time, that is your chronic, more than 21 days, it would be your chronic SDH. So we'll come back to the questions after completing our overview discussion of your brain trauma. Now next we have your diffuse axonal injury. 80% are usually non-hemorrhagic, also known as stretch hemorrhage, and a better diagnosis over here would be with the help of your MRI. Then we have your contusions, which include your mixed density lesions, the most common location being your temporal, and any lesion which is more than 50 ml would be requiring surgery, and your frontal and your temporal more than 20 ml collection would be needing surgery. Right. So this were the few important points with respect to the major brain trauma that you come across. They could be asked, you could be asked a question from your EDH, SDH, contusions, or DI. Now another important point is regarding your key parameters that need to be monitored. So I have taken this table from your Bailey and Love. PaCO2 should be 4.5 to 5 kilopascal, PaO2 should be more than 11 kilopascal, MAP should be more than equal to 80 to 90 mm of Hg, ICP less than 20. So if you need to remember of all one value, it has to be ICP less than 20 mm of Hg. Then your CPP is more than 60, sodium more than 40, and potassium more than 4 millimole per liter. Now regarding your Glasgow outcome score, now it is 5, said to be a good recovery, 1 is said to be dead. Now they could just put you a match the following, which of the following is correctly matched, or they could just put you 5, 4, 3, 2, 1 on one side, and good recovery, moderate disability, severe disability, persistent vegetative state, dead on one side, and ask you which of the following is correctly matched. So I put such sort of questions in one in terms of biopsy and the frozen section, which you would be coming across in the further question of the test. So please be prepared for such questions, and Glasgow outcome scale is a very important topic which can form a question out from there. Right. Now the last over here is your regarding your UK National Institute for Health and Care excellence criteria for computed tomography scan in children following head injury. So that includes your suspicious of NAI. What is NAI? NAI is your non-accidental injury for seizure, GCS less than 14 or 15 in under 1, less than 15, 2 hours post injury, signs of fracture of base of skull, focal neurological deficit, bruise or swelling or laceration more than 5 cm in under 1, and more than one of the following: loss of consciousness, abnormal drowsiness, 4 or more episodes of vomiting, dangerous mechanism, and amnesia more than 5 minutes. Please remember, the values actually differ in case of children and in case of adult. Now you need to make sure that you see that you read the question carefully. In case of children, it is more than 4 episodes of vomiting, whereas in case of adults, it is more than 1 episode of vomiting. Right. Now we have this excellence of discharge criteria in minor and mild head injury. So what are those discharge criteria? You have GCS less 15 by 15 with no focal deficits, normal CT brain if indicated, patient not under the influence of alcohol or any drugs, patient accompanied by a responsible adult. Then you have your verbal and written head injury, advise and seek medical attention if there is a persistent vomiting, drowsiness, visual disturbance, limb weakness, and persistent worsening headache despite analgesia. So these are your few important core topics which I do not want you all to miss before you all go for your I9 exam. So now coming back to the questions that we were discussing. A 78-year-old lady, look at the old age as clinical too. History of fall, there is a history of trauma, developed headache and neurological symptoms few days later. Now what are we dealing with? Few days later is a very important clue. Now this is dealing with your SDH, usually your chronic SDH when it occurs more than 21 days. So answer is SDH. So if you see, as you are reading your question, you are giving getting your clinical clues to your answer. The next, which of the following is true for pterion? Now if remember, while I was discussing your EDH, I would say how could the question be formed? It could be formed as an anatomical correlation. Now this is over here the anatomical correlation. Now this connects the parietal, temporal, sphenoidal and the maxillary bone, and your middle meningeal artery is damaged. So we are basically looking at your EDH. So answer over here is both. Now coming down to the next question, we have a 43-year-old woman who was brought to the AIMS emergency following a, so this is your AIMS emergency RTA. She was hemodynamically stable, right? Her GCS score was 3, that is your minimum score. She was intubated and sent for NCCT, which was found to be normal. Now EDH, SDH and cerebral contusions, we have seen the image of SDH, how it is going to be. It is going to be crescent, so this cannot be the answer. In case of EDH, you can see it is a concave shape, so even this cannot be the answer. Cerebral contusion, there would be a contusion, so even this cannot be the answer. The answer over here would be diffuse axonal injury, and we had discussed that 80% are usually non-hemorrhagic and we usually need MRI for a diagnosis, right? So this were your 3 important questions from your brain trauma that have been asked previously, and with the discussion of a brain trauma, we have also covered the various other questions that can be potentially asked in your trauma section from the brain injury. Now moving down to the next question we have. Now a patient with your grade 3 splenic trauma was admitted to your ICU and managed conservatively. Which of the following signs on day 2 will tell you that a patient needs laparotomy? So options are hemoglobin fall, air in gallbladder, extraperitoneal rupture. Please remember, it is extraperitoneal rupture, or pneumoperitoneum, that is air in peritoneum. So if you are seeing air in your peritoneum, this would mandate a need for a laparotomy, right? Your answer is pneumoperitoneum. So abdominal trauma. Now abdominal trauma is also a very important part. So I have just put one question from your abdominal trauma, but we shall discuss in nutshell a few important concepts regarding your blunt trauma and your penetrating trauma, the basic guidelines which are going to help you to manage any sort of abdominal trauma. Now in abdominal trauma, the hottest topic is regarding your focused abdominal sonography for trauma. Now what does it do is it assesses the torso in presence of free fluid in the abdomen. Now we have an extended FAST, which is when extended into your thoracic cavities. So if you look over here, this is your general trauma FAST examination, which includes your cardiac subxiphoid window, right upper quadrant hepatorenal, splenorenal and suprapubic views, and being the extended FAST when it is extended into the thoracic cavities, that is your right anterior chest and your left anterior chest. Now a few important points regarding your FAST which can be actually asked as your one-liners are: they do not reliably detect less than 100 ml of free blood, they do not directly identify the injury to hollow viscus, and they cannot reliably exclude your penetrating injury, and they are unreliable for assessment of your retroperitoneum. So please remember this important one-liners with respect to FAST in your abdominal trauma. Now the next important concept is regarding your diagnostic peritoneal lavage. So now this is specifically used in your resource limited setting. So in grid setups like your AIMS trauma care center, they usually do not do your diagnostic peritoneal lavage, but still it is being followed in your resource limited setting. So just let's look at a few important points for this. They assess the presence of blood or contaminants in the abdomen. The nasogastric tube is placed in the empty stomach and urinary catheter inserted into drain the bladder. So a positive DPL is when there is presence of bile, a mile is present, more than 500 white cells and more than 1 lakh red cells per microliter. So they can actually frame questions in true or false, where they might just put a line from diagnostic peritoneal lavage that positive DPL is when you have more than 250 red cells and or say 500 red cells. No, it is more than 1 lakh red cells and more than 500 white cells. Now this is a very important table from your ATLS 10 guideline, where they comparing your DPL, FAST and your CT scan. So I'll be focusing mainly on the CT scan. Now the advantages of CT scan is anatomic diagnosis, non-invasive, repeatable, visualize the retroperitoneal structure, which is a drawback of FAST, and then visualizes bony and soft tissue structures and the extraluminal air. Now the disadvantages include your higher cost and longer time, radiation and IV contrast. It can actually miss diaphragm injuries, it can also miss some bowel and pancreatic injuries, and it requires your transportation from your resuscitation area. So the normal hemodynamics in blunt or penetrating abdominal trauma and penetrating back flank trauma without other indications for immediate laparotomy are your indications for your CECT whole abdomen. Please importantly remember the normal hemodynamics. Now this is the clinical clue when you need to get a CT scan whole abdomen done. Now in case of abnormal hemodynamics, what are you going to do? You are going to do EFAST. Now if it is a resource limiting condition, then yes, you would be needing to do your diagnostic peritoneal lavage. Now a general overview regarding the management of your blunt abdominal trauma. So you have your abdominal examination including your FAST. Now if there is peritonitis, then yes, we will go for an exploratory laparotomy. Now if there is no peritonitis and the patient is hemodynamically stable, I will do a abdominal CT scan. Now in abdominal CT scan, if I see a hollow viscous injury, then I will again go for an exploratory laparotomy. But now if there is no hollow viscous injury, then you look for your solid organ injury. Now in solid organ injury, if there is grade 4 or grade 5, usually for that we would be requiring your exploratory laparotomy. However, if the patient is hemodynamically stable, we still can go for NOM, which is your non-operative management, and if it is grade 1, 2, 3 and the patient is hemodynamically stable, we would go for a non-operative management. Now if you actually do not find even a solid organ injury, then you just check for the free intra-abdominal fluid. Now if there is free intra-abdominal fluid, now check if it is a large amount of fluid, seat belt sign, abdominal stent or abdominal vital, then you go for a laparotomy. If the answer is no, then you go for your serial examination. And if there is no free intra-abdominal fluid, then just go for your conservative management. So these are your few important points with respect to your blunt trauma abdomen. Now moving on to the next variant of the abdominal trauma, which is your penetrating trauma. Now in penetrating trauma, you will look for presence of shock, peritonitis, evisceration. If the answer to any of them is yes, then we go for a laparotomy. Now if the answer is no, then you will go for a local wound exploration. If it is negative, then you will discharge the patient. However, if it is positive, you will admit the patient for observation and assess for the instability. If the patient is unstable, you go for a laparotomy. Now if there is instability is not there and there is a significant decrease in hemoglobin or leukocytosis, then you would go for a CT scan, a diagnostic peritoneal lavage or an exploratory laparotomy. If not, then you go for initiating diet and discharge home. So these are your few important concepts from the abdominal trauma. So moving back to the question that we had. So over here, which of the following signs on day 2 would be needing a laparotomy? It would be the presence of pneumoperitoneum, right? So this is all about your abdominal trauma. Now moving down to the next question that we have is, a 30-year-old male with a pelvic fracture following blunt abdominal trauma. No blood is seen at the meatus. Catheterization does not produce significant urine output. Then you have your radiological image, which is given below. So what is the next step in the management? So I have not added the image out over here, but then let's look at the question over here. The pelvic fracture, catheterization does not produce any significant urine output. You have your diagnosis, which is made over here as your urethral rupture, right, or your bladder rupture. So what would be your answer in this question? So now I have purposely not put the image over here, because when this question was put over here, many said it to be a urethral trauma and many said it to be a bladder rupture. So there was a section of students who had put forward this as your bladder rupture and saying it that it was an intraperitoneal bladder rupture. So in that case, the answer would have been a laparotomy. Whereas there was a few section of the students who were saying that there was no radiological image given, but then they were telling you regarding that it was a rupture of the urethra. So in that case, the answer would have been SPC. So we still do not know what the question was asked in AIIMS, but if it was an intraperitoneal bladder rupture, the answer would have been your laparotomy, and if it was a urethral rupture, it would have been an SPC. Now seeing about the urethral rupture, it is of two types, your membranous urethral rupture and your bulbar urethral rupture. So let's look at the important points of your urethral rupture. So now this is regarding your urethral trauma. So we have your two forms of urethral trauma. One is your bulbar and another is your membranous. Now membranous is your associated with your fractured pelvis, prolonged labor, there is extravasation of urine into deep pelvis and your floating prostate, and you have your bulbar, which is your fall astride injury, a blow to your perineum causing your retention of urine, blood in external meatus and perineal hematoma. Now in your bulbar urethral rupture, you have your extravasation of urine confined to the mid-perineal point by attachment of Colles fascia to your triangular ligament and Scarpa fascia just below the inguinal ligament. So these are your few important differentiating features between your bulbar and your membranous urethra. Now you would require a RGU, retrograde ureterogram, in case of your bulbar urethra, and a gentle attempt to catheterize. If it fails, then you go for an SPC, and in case of your membranous urethra, you would require a resuscitation, hemodynamic instability, stabilization for the hemodynamic instability, the injury diagnosis by your CT scan of FAST, and you confirm your diagnosis by your RGU. So if there was an image of RGU, so yes, you might need to know RGU image for that question. I doubt. If you would have used your basic clinical knowledge, you would be able to solve this question. Now if the question had an image showing an intraperitoneal rupture, that is, there is something rupturing into the abdomen. So going with the basic protocol of abdominal trauma, there is a foreign body in your abdomen which has ruptured over their blood, so you would be requiring a laparotomy. If it was not there and they are discussing outside the abdomen of urethra, then it would have been a membranous urethra, where you would be requiring to do your suprapubic cystotomy. Right, now this is an image of your suprapubic cystotomy by your percutaneous puncture of bladder with the guide wire, followed by the dilation of tract over the guide wire, allowing the placement of catheter into the bladder. Now having said this, regarding your catheterization, AIIMS has this knack of asking you basic steps of catheterization or various other processes. So let's look at some of the basic steps of your catheterization. So firstly, this could come as an image based question. The types of urethral catheter: this is a single lumen catheter shown in A. Your B is your standard urethral catheter with an inflatable balloon retention mechanism. Type C is your three-way catheter with an extra channel for irrigation, and type D is your coupe tip catheter. So the steps for urethral catheterization, I have just taken this exact steps from your Bayesian law where they might be asking a question from. So your first step, so they might be just giving you the options and ask you to arrange the correct sequence. So you have your aseptic technique, hand washing, sterile gloves, sterile catheter pack, clean urethral meatus with antiseptic solution, instill lidocaine gel into urethra and hold for 2 to 3 minutes. In men, the penis should be held perpendicular and taut. Then in women, the labia should be held apart to provide adequate exposure of your urethral meatus. Now, the catheter should be inserted as far as the hilt of the catheter and should pass freely, and the type of catheter is dependent upon the indication. If there is any resistant catheterization should be stopped and assistance sought. Now, the patient may require a caudate tip catheter if the obstruction is thought to be a large prostate, cystoscopy, or to negotiate a false passage or stricture. Following this, your next step would include your position in the bladder is confirmed with the drainage of clear urine. The balloon should be inflated with your 10 ml of sterile water, and the catheter bag should then be attached. Now, the details regarding the type and size of catheter residual volume should be clearly recorded. So this is your sequence of catheterization. Please make sure that you read this. Now they might ask you similarly a sequence of your nasogastric tube placement or a catheter. So I've discussed catheter. You may just take a look at the steps of the NG tube insertion. Now with this I would also discuss regarding your suprapubic catheterization. So you have your infiltration of local anesthesia to the skin and fascia of suprapubic region, 2 finger breadths above the pubic symphysis in the middle, a palpable bladder, and then you have your Seldinger technique, which is the safest for the percutaneous insertion. So how do you do it? A long needle is inserted in a perpendicular direction into the bladder, and aspiration of clear urine confirms the correct entry. Then a guide wire is placed through the needle and the needle removed. Then a small skin incision at the side of the guide wire allow a trocar to pass over the guide wire and into the bladder, thereby dilating the tract. Now through this trocar, a 16 FR catheter is placed and the balloon inflated. Now the trocar is removed and the catheter bag is attached. Now the bladder cannot be confidently identified, or in those with extensive abdominal or pelvic surgery, an open cystotomy should be performed to safely enter the bladder and ensure that there is no bowel in the path of catheter. Now this is again an important image of your suprapubic Seldinger catheter, okay, where you have your 18G hypodermic needle which is 12 centimeter long. Then you have your 3-stage guide wire, a dilator and a pillable sheath, and a low profile silicone Foley catheter. Right, so this were the few important steps for your catheterization, which could be a potential MCQ topic that can be asked in your upcoming AIMS exam. So moving back to the questions. So in this question, let's consider it was a urethra image of your RGO, then the answer would have been SPC, and if it was an intraperitoneal rupture of bladder, then your answer would have been laparotomy. Right, so this is with respect to your bladder trauma or your urethral trauma. Now moving down to the next question, we have which of the following is not part of DCS. Now what is DCS? DCS is your damage control surgery. Option A, hemorrhage control. Yes, it is a part of DCS. Vascular anastomosis, no, the entire concept of damage control surgery is that you do the least and vascular do the least. So the vascular anastomosis would be requiring a lot of time. So this is not a part of DCS. Decontamination is part and resuscitation is part. So your answer would have been over here a vascular anastomosis. Right. So regarding your damage control surgery, it is a very important concept for your upcoming exam. So let's discuss a few important points with respect to your damage control surgery. Now in damage control surgery, the first important concept that you guys need to remember is your lethal triad. Now what is a lethal triad? It is acidosis. Now what happens in acidosis? There is decreased function of the coagulation factor, as a result of which it leads to coagulopathy and hemorrhage. Now similarly, another important component is your coagulation, that is there is bleeding plus RBC resuscitation, as a result of which there is your dilution of coagulation factors leading to dilutional coagulopathy. Now hypothermia, so there is decreased blood supply to the muscles, which leads to the underperfusion of the muscle, as a result of which it is unable to generate heat. So these are your few important concepts of your lethal triad. Now regarding your damage control surgery, the entire idea is to blunt the physiological response to the prolonged shock and hemorrhage. So the various criteria for damage control surgery include your hypothermia less than 34 degrees Celsius, acidosis pH less than 7.2, serum lactate level more than 5 millimole per liter, dilutional coagulopathy, blood pressure less than 70 mm of HG, transfusion approaching more than 50 units, and injury severity score of more than 36. Now regarding your stages of DCS, you have patient selection, operative control of hemorrhage, ICU resuscitation, definitive surgery, and your abdominal closure. Now when it comes down to your phases of DCS, you have abbreviated laparotomy, ICU resuscitation, and your definitive surgery. Now the stages and the phases are almost the same, but then some books mention stages and some books mention the phase. So please remember, if it is asked stage, then you have your ICU resuscitation in your stage 3, and if it is asked phase of DCS, then it is in the stage 2 of your stage 2 phase is your ICU resuscitation. Now the last important concept associated with your damage control surgery is your damage control resuscitation, where we anticipate and treat traumatic coagulopathy, permissive hypotension until the hemorrhage control. Then you have your limit crystalloid and colloid infusion to avoid your dilutional coagulopathy, and then we have your damage control surgery, which role is to control hemorrhage and to preserve the physiology. So these were the few important points with respect to your damage control surgery. Now in this session, we move our shift our topic of discussion to the general surgery. So this 10 questions of trauma would more or less cover almost all the questions that could have been asked or that can be asked in your AIIMS examination. Now coming down to the general surgery, now general surgery is varied, right? So the few important questions that are asked from your general surgery include from your shock. So you have your question 11 and your question 12 of shock. So let's solve those two questions, and then we come back to the discussion of shock as a whole and what other questions that can be asked from shock. So the first question that we have from your general surgery is, which of the following is not true regarding hemorrhagic shock? Peripheral vasoconstriction, the answer is yes. Then anaerobic respiration produces CO2, the answer is true. Then the base deficit increases, the answer is true. And then you have your renal perfusion maintained till last stage. No, the renal perfusion is not maintained till your last stage. So the answer over here would have been renal perfusion. Now moving down to the next question that we have is, which of the following is seen in your neurogenic shock? So there is an unopposed vagal tone which is going to cause your hypotension and bradycardia. So the answer over here would have been hypertension and bradycardia. So now let's discuss a few other important points that can be asked from this chapter of shock. So a few important points regarding your shock. So the first important point that you need to remember is that it is your most common cause of death in your surgery patient. It is a systemic state of low tissue perfusion which causes your inadequate normal cellular respiration, which is insufficient for delivery of oxygen and glucose to the cell, as a result of which the cell switch from your aerobic to the anaerobic metabolism, and if your perfusion is not restored, the cell that ensues. Now, the product of anaerobic metabolism is your lactic acid, which if accumulates in underperfused tissue results in your metabolic acidosis. Now, this anaerobic metabolism also produces your CO2. Now, in your question that we had discussed, the best answer over here would have been your renal perfusion is maintained in the late stages. Why? We would be eventually coming down to that. Now, also there is failure of sodium potassium pump in the cell membrane and the intracellular organ. Now, the changes that occur at the microvascular level includes your hypoxia and acidosis, which causes your activation of your complement and your primary leukocytes. Now, as a result of which there is generation of free radicals, oxygen, release of cytokines. Now, this causes the injury of capillary endothelial cells, which causes the activation of the immune and the coagulation system, and also the endothelial cells become leaky, the fluids leak out, the tissue edema occurs, and which exacerbates your cellular hypoxia. Now, in your cardiovascular changes, the preload and the afterload decrease causes the compensatory baroreceptor response, which causes your increased sympathetic activity, as a result of which there is release of catecholamines into circulation, causing your tachycardia and your vasoconstriction. Now, in case of respiratory system, what happens is there is metabolic acidosis as well as increased sympathetic response. Because of this, what happens is there is increased respiratory rate and increased minute ventilation, causing increased excretion of carbon dioxide. Now, please remember this changes, because in AIIMS they have this knack again of asking this basic questions. You might be reading some hi-fi questions, but then this is what is important. Now, the renal system. Now, there is a decreased perfusion in the kidney, as a result of which what happens is that there is reduced filtration at the glomerulus and a decreased urine output. Now, the RAS system is activated, causing vasoconstriction, as a result of which there is increased sodium and water reabsorption by the kidney. Now, in case of your endocrine system, you have cortisol, which causes your sodium and water reabsorption, sensitizing cells to the catecholamines. Now, the most common form of shock is your hypovolemic shock. Now, regarding your cardiogenic shock, the causes include your myocardial infarction, cardiac dysarrhythmias, valvular heart disease, blunt myocardial injuries, and cardiomyopathy. Now, there is a primary failure of heart to pump the blood to the tissues in case of your cardiogenic shock. Now, in case of obstructive shock, there is reduction in preload, mechanical obstruction of your cardiac filling, cardiac tamponade, tension pneumothorax. So, if you guys remember the question where we had discussed regarding your tension pneumothorax, one of the most important points that we had discussed in your tension pneumothorax was the type of shock in tension pneumothorax was your obstructive shock. Now, regarding your distributive shock, you have your septic shock, anaphylaxis, spinal cord injury. So, what happens is there is vasodilation. Now, vasodilation in case of anaphylaxis is because of your histamine release, in case of spinal cord injury is because of the failure of sympathetic outflow, and in case of sepsis is because of your endotoxins. Now, the endocrine shock is because of your adrenal insufficiency, hypo or hyperthyroidism, and thyrotoxicosis, which may also cause your high output cardiac failure. Now, this is a very important table for you guys to remember. One question definitely comes out from this, right? So, this is your various classification of your hypovolemic, cardiogenic, obstructive, and distributic. What I want you all to focus over here is regarding your mixed venous saturation and base deficit, which is high in your distributive shock, right? Also, at the same time, your systemic vascular resistance, which is low in distributive shock and high in almost rest, and the cardiac output, which is high in your distributive shock. Now, then a few points regarding your ischemia reperfusion. Now, this is a systemic hypoperfusion which is causing your tissue hypoxia and local activation of the inflammation, which eventually leads to your cellular and organ damage. Now, this acid and potassium load will cause myocardial depression, vascular dilation and hypertension, whereas your molecules form interior of the cell, releasing to the circulation, activates your leukocytes. Now, this along with the cellular and the humoral elements are actually flushed back into the systemic circulation, which is leading to your ischemia and reperfusion syndrome. Now, another important point is regarding your clinical features of shock. So, it could be either in case of a compensated or an uncompensated. Now, lactic acidosis is much more common in your severe type of shock. Blood pressure is severe hypotension in severe shock. Pulse rate is increased, respiratory rate is labored, conscious level is comatose in case of uncompensated severe, moderate is your drowsy, and mild anxiety in case of mild. Then urine output is anuric in severe and reduced in moderate. So, there could be a clinical scenario where you are giving this following variables of lactic acidosis, urine output, conscious level, respiratory rate and pulse rate and blood pressure, and asked to whether it is a case of a mild shock, moderate shock or a severe shock. Then regarding the monitoring in shock, you have your basic and the minimum monitoring, which includes the ECG, pulse oximetry, blood pressure and urine output, and then you have your additional modalities that include your central venous pressure, invasive blood pressure, cardiac output, base deficit and serum lactate. Now, another important one-liner is patients with base deficit of more than 6 millimole per liter have a higher morbidity and mortality. And with respect to your mixed venous saturation, a potential one-liner MCQ that can be asked, that the normal level is 50 to 70%, less than 50% is hypovolumic cardiogenic shock, and more than 70% is your sepsis. Now, the next important table is your monitors for organ and systemic perfusion. So, if you have your systemic perfusion, the investigation in base deficit, lactate and mixed venous saturation. The organ perfusion, for your muscle you have your near infrared spectroscopy and tissue oxygen electrode. Now, for gut you have your sublingual capnometry, gut mucosal pH and your laser Doppler flowmetry. For kidney you have your urine output, and brain you have your conscious level, tissue oxygen electrodes and near infrared spectroscopy. Now, in case of your occult hypoperfusion, which is more than 12 hours, what happens is that it increases your 2 to 3 times chances of mortality. Again, important one-liner. Now, this important one-liner is have been asked, that is best measure of organ perfusion and best monitor for adequacy of shot therapy is your urine output. Now, the importance of this table cannot be under specified or undermined. It is a very important table regarding your classes of hemorrhage. So, you have your class 1, approximate blood loss 15, heart rate is usually normal, blood pressure is normal, pulse rate is normal, respiratory rate is normal, urine output is again normal, GCS is again normal, base deficit 0.2, need for blood products would to be monitored. Then class 2, you have your heart rate, which could be either normal or increased, blood pressure is usually normal, pulse pressure is decreased. Then you have your respiratory rate, which is again normal, urine output normal, GCS normal, -2 to -6, and the need for blood products would be possible. Then you have your class 3. Now, class 3 you have 30 to 40, heart rate is increased. Now, you see over here the blood pressure starts to fall. Then you have your pulse pressure falling, respiratory rate increasing. Then you again see the urine output is again falling over here. Glasgow Coma scale falls, -6 to -10 is your base deficit, and there would be need for your blood product. In case of class 4, that is a severe, you look more than 40% is your blood loss, heart rate is increased, blood pressure is falling, pulse pressure is falling, respiratory rate is falling, urine output has significantly decreased, so has the Glasgow Coma scale score, and the base deficit has is minus 10 milliequivalent or less, and they would be read of your massive transfusion protocol. Now we had read about the massive transfusion protocol today itself. Please remember it is 1:1:1, right? So these are your few important points regarding your hemorrhagic shock. Now ending your shock discussion on these two important points, important formula: shock index, which is your heart rate by systolic blood pressure, and modified shock index, which is heart rate by your mean arterial pressure. So this have been asked. Please read the question carefully, whether they are asking you regarding your shock index or they are asking you regarding your modified shock index. So now let's move down to the next question. Now the next question that is asked from your general surgery is regarding your SIRS. So which of the following is not a criteria of SIRS? Option A, heart rate less than 70, respiratory rate more than 20, WBC more than 12,000, temperature more than 38 degrees. So this is a true statement, this is a true statement. Respiratory rate is true and heart rate has to be more than 90, right? So the answer is heart rate less than 70. Now systemic inflammatory response syndrome is a very important topic, so we'll discuss this in details. So the definition of systemic inflammatory response syndrome and sepsis, the SIRS is when you have presence of two of three of the following, which is hyperthermia, that is more than 38 degrees centigrade, or hypothermia, which is less than 36 degrees Celsius. Then you have your tachycardia, which is more than 90 per minute and no beta blockers, or tachypnea more than 20 per minute. Please remember this important value of 20, because another important score that we have to discuss is your Q-SOFA score, and in Q-SOFA score you have your respiratory rate more than 22. Then you have your white cell count, which is more than 12 into 10 to the power 9 liters, or less than 4 into the 10 to the power 9 liters. Then what is sepsis? Now sepsis is your SIRS with a documented source of infection. Now another important definition is regarding your severe sepsis or sepsis syndrome. So it is sepsis with evidence of failure of one or more organ, respiratory acute respiratory distress syndrome. In case of cardiovascular, it would be a septic shock which follows compromise of the cardiac function and fall in the peripheral vascular resistance. Then you have your renal, which is usually acute tubular necrosis, and hepatic blood coagulation system or the central nervous system. So these are your few important definitions that you need to remember. So they might be forming a clinical scenario over here where they could say a patient is presenting to you with tachycardia and a white cell count of around 15,000, more than 15 to 10 to the power 9 per liter, with a documented source of infection. So which of the following is true? It is a case of SIRS, it is a case of sepsis, it is a case of severe sepsis. So if you see, what I had mentioned was two of the three criteria, that is SIRS and a documented source of infection. So the answer would over here be sepsis, or they could just ask you one-liners from here. Now another important concept that we need to know is regarding your sepsis bundle. Now this is the resuscitation bundle, which is based on the evidence based objectives which are completed within your 6 hours. Now for patients presenting with severe sepsis, septic shock and lactate more than 4 millimole per liter. So this is the important concept of sepsis bundle, where you need to remember the duration, which is your 6 hours. Then you have your sepsis 6. So sepsis 6 is give 3 to the patient and take 3 from the patient. So give 3 to the patient includes your IV fluids channel, IV antibiotics and your oxygen and monitoring of urine output. Now taking 3 from the patient would include your blood culture, full blood count and lactate. So this sepsis is a new concept that has been added in your recent edition of Bailey and Love. So you can anticipate a question coming from here in your upcoming AIIMS exam. Now I would also discuss an important score, which is your Q-SOFA score. Now the Q-SOFA score is your respiratory rate more than 22 per minute, Then you have your systolic blood pressure less than 100 mm of Hg and your altered mental status. Now the importance of the Q-SOFA score is that it has been recently asked in your FMG 2022. Then they repeated the same question in a different format in your NEET PG also. So please do remember reading out this Q-SOFA score, and over here the respiratory rate is more than 22 per minute, and in SIRS we had read it to be respiratory rate more than 20 per minute. Now when we are talking about this Q-SOFA score and the SIRS score, I would like to introduce to two more important concepts, that is your NEWS and your Clevin-Dindo classification. So NEWS is your National Early Warning Score and Response. Now it includes your 6 parameter, which is your respiratory rate, oxygen saturation, systolic blood pressure, pulse rate, level of consciousness or new onset of confusion, and temperature. So this is your NEWS chart, right? So please remember this diagram, and they can just directly ask you this flow chart and asking what is the score. So the score is your National Early Warning Score and Response, right? So this is on the basis of your new score. If it is a score of 0 to 4, you categorize as a low risk and it would be a ward based response. Now if it is a red score, that is a score of 3 in any individual parameter, then it would be low to medium and it would be an urgent ward based response. Then if you have an aggregate score of 5 to 6, that is a clinical risk of medium, so it would be a key threshold for your urgent response. And aggregate score 7 or more, this would be a high clinical risk and this would be an urgent or emergency response. So on the basis of your new score, you would be able to decide the response that you need to give to the patient. Now another important classification that has been recently added in your Bayesian law, though it has been used traditionally in your surgical wards, is your Clevin-Dindo classification, which is for your post-operative complications. So in this you have an objectively and a reproducibly measured impact of the surgical complications on outcome of procedure. So if you look at this Clevin-Dindo classification of the post-operative complications, you have the grade 1. In grade 1, if there is any deviation from the normal post-operative course without the need for pharmacological treatment or surgical, endoscopic or radiological intervention. Now another definition is your acceptable therapeutic regimens are your drugs such as antiemetics, antipyretics, analgesics, diuretics and electrolytes, and physiotherapy. The grade also include wound infections open at the bedside. So you could be given a clinical scenario which consists of all of this following situation, and they might just ask you the grade of the Clevin-Dindo classification. Then you have your grade 2. Now what is your grade 2? Now they require pharmacological treatment with drugs other than such allowed for grade 1 complication. The blood transfusion and the total parenteral nutrition are also included. So TPN is included in your grade 2. Then you have your grade 3, which is requiring surgical, endoscopic or radiological intervention. Now 3A is intervention not under general anesthesia and 3B is intervention under general anesthesia. Now grade 4 is your life-threatening complication, including your CNS complication like your brain hemorrhage, but excluding your transient ischemic attacks, now which require your ICU management. So 4A is your single organ dysfunction and 4B is your multi-organ dysfunction, and grade 5 would be your death of a patient. So this is with respect to your Clevin-Dindo classification of your post-operative complications. So now moving down to the next question. So this is now the recent trend of pattern of questions that are placed in your aim, so where you need to be solid in your concepts, right? So they match the following. You have your options A, B, C, D, and then you have your 1, 2, 3, 4. So let's match them. Now let's try to solve with the limited knowledge that we have. So the first thing that we see over here is a solitary thyroid nodule. So this is one very important topic that we always recite. So for a solitary thyroid nodule, what will you do? You will always do a USG guided FNA, So that is D1. So now if you look over here, among all the options, you have actually able to exclude option A and B, because you would be needing to do a USG guided FNA in case of your solitary thyroid nodule. Now if you look at your lymph node, now what do you do for a lymph node? You do for a lymph node an excision biopsy. So the C2, so actually the answer over here would be C2. Then we have read about the soft tissue sarcoma, where we would be requiring a core biopsy, right? A core biopsy in case of soft tissue sarcoma. So A would be 4. And marginal ulcer, right, where you always see have a risk of a carcinoma, you always do a wedge biopsy, right? So B3. So the answer over here would have been option D, which is A4, B3, C2, D1. Now this sort of questions might be looking confusing to you, but please remember, if you follow your basic concept, there is no way that you would get these questions wrong, as these questions are very simple if you apply your basics, right? So this is the current trend of questions that can be asked. So specifically with respect to your daycare surgery, where they can ask you definitions, or they can put a lot of definitions as A, B, C, D, 1, 2, 3, 4 and ask to you to match the following, right? Now moving down to the next question. Now the next question is based on your sutures. So again the similar concept of match the following. So which of the following is your correct match? Option A, polypropylene, polygalactine, nylon, PDS, and it is matched with hernia, bowel anastomosis, tendon repair and your abdominal closure. So let's try to analyze what is used for what. Now if you look over here, nylon is used for your tendon repair, polypropylene is used for your mesh fixation in hernia. So you already have your A1 and C3. So if you look over here, A1, C3, C3, so automatically your answer becomes the option A, right? Now this is how you solve by exclusion, but now we would definitely look at the other options also. Now for polygalactylene is used for your bowel anastomosis, and you have your PDS, which is used in your abdominal closure. So now the interns who have gone to your surgical ward posting, these are your common sutures that you have always used in your clinical practice, right, in your internship. So AIIMS has the knack of focusing on your clinical practice, and this is from where your questions are formed. Now having said this, sutures also form a very important topic where they can ask you a lot of questions. So let's look at some of the important points from the sutures. Now firstly, the suture material characteristic. Now they should be easy to handle, predictable behavior in tissues, predictable tensile strength, sterile, glides through the tissue easily. Then the secure knotting ability, they should be inexpensive, minimal tissue reaction, non-capillary, non-allergic and non-carcinogenic. Now regarding the physical structure, it can be monofilament, that is smooth, tends to slide, difficult to knot. Multifilament, which is easier to knot, surface area around 1000 times, having a capillary action which interstices, as a result of which the bacteria can lodge. Now on the basis of strength, now they have the constituent material, thickness and response to tissue. Now they are absorbable, that is decay of strength with time. Now non-absorbable could be either synthetic, that is polypropylene, which is retaining strength, and biological, which lose strength with time. Now vascular anastomosis, you have your smooth, non-absorbable, non-elastic, whereas in your biliary anastomosis you have your absorbable. Now bowel anastomosis, you have your polygalactine, PDS or polypropylene. So obviously all three can be used, but then if you would look at that option, hence if you go for the concept based answers, the best answer over there would have been polygalactine. Now moving down to the needles that we use. So if you look over here, these are your various types of needle that So this can be asked as an image based question itself, like what it is a 1/4 of a circle, 3/8 of a circle, half of a circle, 5/8 of a circle, compound curve, half curve, or a J needle. Right. Now round bounded needles are for peritoneum muscles and fat, needles used for suturing abdominal wall, and cutting needles are for your aponeurosis. Now these are your needles which are used for suturing the bowel, and the threads are swaged into the needle. So these are your just simple image based questions that can be asked from your needle, asking you what is the value. So this is a 1/4, this is a 3/8, this is a half, this is a 5/8 of a circle, this is a half curve, and this is a J needle. Now regarding your suture technique, so if you look over here, this is an interrupted suture technique. Now this is your continuous or a mattress suture technique, and then this is your continuous suture technique. So these are your images from your Bailey and Love. So you can just be getting again the match the following to match. So please remember, these are your interrupted suture technique, then this is your mattress suture technique, and this is your continuous suture technique. Now this is a subcuticular suture technique. Now something about knots. So if you look over here, there are three important types of knot that we need to know, that is your square knot, granny knot, and the surgeon's knot. So if you look at the important differentiating feature between the square knot and the granny knot, in case of square knot, if you look over here, this is in this direction and this is over here, so they are in opposite direction, whereas in case of your granny knot, they are in your same direction, right? And this would be your surgeon's knot. Now a few important lines regarding your abdominal wall closure. Now regarding, it could be a layered versus a mass closure, a continuous versus an interrupted closure, and the suture that we use is your delayed absorbable monofilament material, which is your PDS, and the distance between the sutures, another important liner, is your 0.5 centimeter, right? And then, so these are your few important points regarding your sutures. So if we again go back to the question of the sutures, now we know PDS is used for your abdominal closure, right? Polypropylene is used for your hernia repair, and you have your nylon, which is used for your tendon repair. So answer over here for polygalactylene would be your bowel anastomosis. So if you look at A1, B2, C3, D4, the answer would have been A. Now the next question is on your IV cannula. So again, this is a very important repeated question. So this could be an overlapping question which might be taught to you in pediatrics as well as in your anesthesia, but we'll cover it over here and discuss the important points of the various cannulas so that we don't miss such easy questions, right? So a patient was received in casualty following RTA. Now his BP was 90/60 and his pulse rate was 120 per minute. The ER physician was to replace fluid loss in the patient. What is the maximum flow rate of fluid with this green IV cannula? So it is a clinical scenario based, but then they are asking you the exact and the specific question, which is your IV fluid flow rate by the green cannula, where your answer would have been 86 milliliter per minute. So let's look at the various sizes of the cannula and the various flow rate associated with it. So these are your cannula sizes. A size 14 would be orange in color with a flow rate of 240 ml per minute. A size 16 would be grey and it would have a flow rate of 180 ml per minute. A size 18 would be green, where your flow rate would be 90 ml per minute. A size of 20 would be pink, which would be around 60 ml per minute. A size of 22 would be a blue cannula, which would be a flow rate of 45 ml per minute. A size of 24, that is a yellow, would be of 26 ml per minute, and a size of 26 would be violet in color and the flow rate would be 13 ml per minute. So this are your few important sizes of cannula and the flow rate. This question has been repeated almost in last 4 sessions around twice or thrice, hence the importance of this particular question. Now the various ways that they can frame this question is that they might actually give you a picture of a cannula. So the picture of cannula, just look at the color. If it is orange, they might ask you the size. or the flow rate. If it is gray, it is size 16, flow rate is 180. If it is green, size is 18 and flow rate is 90. Pink 20, 60 is the flow rate. Blue, the size is 22 and your flow rate is 45. Yellow, it is 24 and 26 is the flow rate, and violet, you have your 26 is the size and 13 is the flow rate. So this were the few important points with respect to your cannula. Now moving down to the next question. So over here we have a patient underwent mastectomy and a drain was inserted beneath the flap. So what type of drain is it? The answer would be a closed drain. So let's understand the few important concepts associated with your drains that are used in surgery. So over here you can look that these are your few of the important examples of your drains that are seen. So this over here is a corrugated rubber drain. Then you have your closed drain, which is a suction drain, and this is an example of a closed non-suction drain. So what is the current role of drain placement in your GI surgery? Now it is said that avoid routine drain placement in your thyroid surgery, breast lumpectomy and inguinal hernia repair. Now consider routine drain placement in your radical and modified radical neck dissection, parotid surgery, axillary dissection with or without mastectomy, inguinal lymphadenectomy and ventral hernia repair in obese patients. Now in case of your GI surgeries, you need to avoid the routine drain placement in your colonic surgery, small bowel resection, hepatic resection and cholecystectomy. Now you should consider the routine drain placement in esophageal surgery, major pancreatic resection and the selective use of drains following your rectal surgery and your gastric resections. So these are your current recommendations for the use of drain. So please remember the image of the drains also, as they can be asked. This is your Romovac drain, right? So these are your closed suction drain and your closed non-suction drain. So now moving down to the next question. So this question is on the blood products. So which of the following is true with respect to the blood products? Now if you look at the trend in your AIIMS, now the questions that they ask are much more based on your clinical exposure that you have during your internship. So hence I have tried to put in this paper one the questions that you come across in your clinical practice, so that you are much better prepared for your AIIMS exam. So over here if you see this question, which of the following is true? Platelets have a shelf life of 15 days. Cryoprecipitate first line therapy in coagulopathic hemorrhage. FFP used in factor 8 deficiency, none. So what we'll do is, first let's discuss the important points regarding your various blood products and then come back to this question. So the first component that we discuss is regarding your whole blood. So these are coagulation factor rich, they are fresh, metabolic active and they must be transfused within 24 hours. Then regarding your packed red blood cells, this is around 330 ml, hematocrit value having around 50 to 70%, stored in your SCGM, which is a saline adenine glucose mannitol solution, and your shelf life is increased to 5 weeks at 2 to 6 degrees Celsius. Then you have your platelets, which are stored at 20 to 24 degrees Celsius. Each and every line that I am seeing you right now is a potential MCQ that have been asked or can be asked, and it has a shelf life of 5 days. Then you have your fresh frozen plasma, which is rich in coagulation factors. They are stored at -40 to -50 degrees Celsius, 2-year shelf life, and it is a first line treatment of coagulopathy. Then you have your prothrombin concentrates, which is your 2, 9 and 10. 7 may be included or produced separately, and they are used for your emergency reversal of coagulant in your uncontrolled hemorrhage. Then you have your cryoprecipitate, which is your fresh frozen plasma plus your factor 8 and fibrinogen. These are stored at -30 degrees Celsius and a 2-year of shelf life. So these are your various important points with respect to your blood components. Now perioperative RBC transfusion criteria include less than 6, that is probably will benefit, 6 to 8 will unlikely to benefit in absence of bleeding or impending surgery, and more than 8 there is no indication of transfusion in absence of risk factors. Then the complications would include a massive complication and your single unit complication. The massive complications includes your coagulopathy, hypocalcemia, hyperkalemia, and hypothermia, whereas single unit complications include incompatibility, febrile, allergic, infection, air embolism, thrombus, and transfusion related acute lung injury, which is more commonly seen with your FFP. And the most common complication is your febrile non-hemolytic reaction. And then you have your autologous blood, which is your 3 weeks before surgery, and then you have your full cross matching, which takes around 45 minutes, and you have your type specific blood, which takes around 10 to 15 minutes. So moving on to the question that we had. So the platelet have a shelf life of 15 days. No, it is 5 days. Cryoprecipitate first line of coagulopathic hemorrhage. The answer is no. The FFP used in factor VIII deficiency, again the answer is no, it is usually your cryoprecipitate. So the answer over here would have been none, right? So you need to know this important one-liners, which is going to help you in solve such sort of questions. Now moving on to the next question. Now in this question we have a 53-year-old man who has undergone internal fixation intermediary nail of the right tibia after sustaining a comminuted fracture of the tibia in a road traffic accident. So the first line of this question is saying you that the patient has undergone intramedullary nailing. Now 24 hours after surgery, he complains of severe pain in right leg. Hint 1. Examination reveals a blood pressure of 122/82 and a heart rate of 84. His right calf is swollen, mildly tender, and his foot pulses are present. Now there is some altered sensation over the dorsum of the foot, and pace inversum when the foot is actively dorsiflexed. Now this is your key hint in the question. Which of the following option is likely to improve the patient's outcome? So the first step for you guys is to form a diagnosis. If you form the diagnosis, you are able to solve this question. Now this is your clinching point to diagnose your compartment syndrome. So yes, we are dealing with a case of compartment syndrome, and when we are seeing a compartment syndrome, the answer is your fasciotomy, right? So let's discuss the important points with respect to fasciotomy and compartment syndrome. So the compartment syndrome, it is the increased pressure in the osteophyseal compartment to a level that would comprise the microvascular perfusion. So what is the most common cause? The most common cause is fracture. Look back at the question, it was given a fracture, the first hint actually. Now it is common cause and it is usually present in around 70% of the cases. Then we have your soft tissue contusions, burns, which is your 3rd degree, bleeding disorder, post ischemic swelling, tight cast dressing, extravasation of IV infusion. So these are your few other important causes of your compartment syndrome, but if asked regarding your most common cause, that would be your fracture. Then you have your pathogenesis. So increased tissue pressure. Now what is the value of this increased tissue pressure? So if it is an absolute pressure that is more than 30 mm of Hg and a diastolic compartmental minus compartment pressure less than 30 mm of Hg. So these are your diagnostic values. So if there is this increased tissue perfusion, what happens is that there is reduced microperfusion, as a result of which there would be a tissue ischemia and cellular anoxia, as a result of which it would cause irreversible muscle damage. Now it is a clinical diagnosis where you will have this pain out of proportion, pain on passive stretch, paralysis, paresthesia and pallor, which are your late sign, and an extremely late sign is your pulselessness. So in that question where you had the pulse was present, that is not going to exclude your compartment syndrome. Please remember that the pulselessness is your extremely late sign in case of your compartment syndrome. Now another important point to remember which is actually a potential question, is that it can also occur with an open wound. If the wound does not extend into the affected compartment, then it may lead to a compartment syndrome. So this is a particular important one-liner which can come up in your AIIMS exam. Then the treatment is fasciotomy. Now the clinching point or the one-liner that is asked regarding fasciotomy is that we incise the deep fascia, right? So this is a very important point. Now we have a medial longitudinal incision which is 1 to 2 centimeter posterior to medial border of tibia, which is going to decompress your superficial and the deep compartments. And then we have one lateral longitudinal incision which is 2 centimeter lateral to the anterior tibial border, which is going to decompress your anterior and perineal compartments. Now apart from that, the other treatment usually includes your removal of splints and elevation of legs. Now the crush injuries that present several days after the event. Now fasciotomy in that case can actually be dangerous, so be prepared to get a one-liner from here, right, or a true or false statement from here, because the dead muscle is going to produce myoglobin. Now this myoglobin sudden release is going to cause a myoglobinuria, which is going to lead to glomerular blockage and your renal failure. So these are your some additional points which you need to remember in your compartment syndrome. Now apart from this, a few important lines of regarding your crush syndrome. Now the crush syndrome is associated with your rhabdomyolysis, crush injury and your acute kidney injury. Now these are usually seen in your earthquakes, mining accident survivors and battlefield casualties. Now the cause for the crush syndrome is said to be a reperfusion injury. So what is the pathophysiology? Now there is a prolonged crushing of muscle which leads to the reperfusion injury, causes the release of myoglobin vasoactive mediators into the circulation and sequestration of fluids and reduction of intravascular volume, as a result of which it is going to cause renal vasoconstriction, ischemia and tubular obstruction, leading to your renal failure, right? So the treatment would be your aggressive volume loading, then you have your saline infusion of your 1000 to 1500 ml, then you have your until myoglobin is no longer detectable in urine. So how long will you infuse the saline? Until there is no longer myoglobin detect. Then you will go for a mannitol administration, and after the flow of urine is observed, that is your mannitol alkaline diuresis, which is usually 8 liter per day and a urinary pH of more than 6.5. Fasciotomy if it is less than 12 hours. Now if it comes after the 12 hours and if you do a fasciotomy, there would be a risk of myoglobinuria, right? So these are your few important points with respect to your compartment syndrome. So now coming down to the last question for this session is on your wound healing. So this is a very important topic which you should not miss, because AIIMS again asks from the basics. Now regarding the wound healing, so the question that has been asked to you is, which of the following is true for your wound healing? Option A, there is proliferation begins 2 to 3 weeks after injury. Option B, open cardiac massage is your class 4 wound. Option C, compound fractures are tetanus prone wounds. Option D, all of the above, right? I know many of you had marked all of the above, but let me tell you, the answer is not all of the above. So let's first discuss this each option separately and then we again come back to this question. So firstly, a few important points regarding your wound healing. The stages of wound healing would include your hemostasis. So what happened in hemostasis? So now this is a flow chart where I will just rush through the wound healing part, right? The injury causes the disruption of the endothelium, which causes a vasoconstriction and exposure of your subendothelium and the extracellular matrix, which causes the platelets to activate, adhere and aggregate, causing the platelet plug and limits the blood loss. Now each of this can actually be a potential MCQ. Then you have your coagulation cascade, which causes a thrombin formation leading to fibrin generation, which stabilize the platelet plug and forming the scaffold for the infiltrating cells. Now the platelet adhesion actually results in their activation, which causes the release of granules and aggregation of platelets. Now the alpha granules contain the proteins, growth factors, transforming growth factor beta, platelet digrowth factor and mesothelium endothelial growth factor, which causes the deposition of the ECM, chemotaxis, epithelialization and angiogenesis. Now the next phase is your inflammation, which is your early occurring in day 1 and day 2, late occurring day 2 to 3, and then you have your platelet activation, which causes the influx of your inflammatory cells. The most important cell is your neutrophils, and also you have the role of polymorphonuclear leukocytes, and then they also release vasoactive amines, which are histamine and serotonin. Now this increases the vascular permeability and aiding the infiltration of your inflammatory cells. Now the late inflammation phase includes your day 2 to 3, monocytes appear, then you have differentiating into the macrophages. Now these macrophages are your phagocytic cells and the proteolytic enzyme, which lead to the debridement of the wound. Now the producer of cytokine and the growth factor is also the macrophages, which causes your fibroblast proliferation and your angiogenesis. Then so we have this particular image showing your inflammatory phase. Now then you have your proliferation phase. Now this starts at the day 3. So recall your option 1, it starts at day 3 and lasts for day 2 to 4 weeks, and it is mainly of your fibroblast activity. Now there is a production of your ground substances, which includes your proteoglycans and glycosaminoglycans, which includes collagen, angiogenesis and reepithelialization. Now wound form in early phase is your granulation tissue, and the later part there is increase in the tensile strength and increased collagen synthesis by the fibroblast. Now some fibroblasts actually become myofibroblast myepithelium, which leads to the important role in contraction of bringing the edges together. So if you look over here, this is a particular example of showing your proliferation. Then the last phase of your wound healing is your remodeling. So in remodeling you have around 2 to 3 weeks, which lasts for 1 year. Maturation of collagen. Over here what happens is your type 3 collagen is replaced by type 1 collagen, until a ratio, if you see over here, of 4:1 is achieved, 4 of type 1 and 1 of type 3. Now the maximum tensile strength is achieved 12 weeks later, and it represents 80% of uninjured skin strength. So this is a particular image showing your remodeling. Now another form of question that can be framed over here from the image based is, they might give you the 3 particular diagrams and ask you to match, which is your inflammatory phase, which is your proliferative phase, and which is your remodeling phase. Right. Now regarding your tetanus prone wounds, so this is a recent addition in your Bailey and Love. Tetanus prone wound includes your puncture type injuries in a contaminated environment, bites, compound fractures containing foreign bodies, wound or burn with systemic sepsis. And your high risk tetanus prone would include your any tetanus prone wound with heavy contamination, wound requiring surgery with more than 6-hour delay, and extensive devitalized tissue. Now another important question that we should be prepared for is regarding your principles of wound management. So this is again a table taken from your Bailey and Love. So it would include the preparation, that is antibiotic prophylaxis, tetanus prophylaxis, adequate analgesia and wound irrigation. Now wound, you would require early debridement, exploration, repair structures and hemostasis. Closure would be with the skin closure. Consider reconstruction techniques, suture choices and drains and optimal dressing, and your follow-up would include your removal of sutures, physiotherapy, monitoring for complications and your scar management. And another very important table regarding your surgical wound classification. So we have your clean wounds. Now what are your clean wounds? These are an uninfected operative wound into which there is no inflammation encountered and the respiratory, alimentary, genital or the uninfected urinary tract are not entered. So in this, clean wounds are primarily closed and if necessary drained with closed drainage. Now, the operative incisional wounds that follow no penetrating trauma should be included in this category if they meet the criteria. Then we have your clean contaminated. Now, your clean contaminated is an operative wound in which the respiratory, alimentary, genital, or urinary tract are entered under control condition without unusual contamination. Now, specifically, the operations involving the biliary tract, appendix, vagina, oropharynx are included in this category, provided no evidence of infection or major break of technique is encountered. So, I had given you in one option open cardiac massage is type 4 wound, right? So, we'll just come across that. What I want to emphasize over here is that you guys need to know this particular table, as there could be various clinical scenarios that can be from this. Then you have your contaminated, which is your open, fresh, accidental wounds. In addition, operations with major breaks in sterile technique, example open cardiac massage, or gross spillage from the GI tract and the incisions in which acute no purulent inflammation are encountered are included in this category. So, the important point that we need to remember is your open cardiac massage, which is your class 3, that is your contaminated. Then you have your dirty infected, which is your old traumatic wounds with retained devitalized tissue, and those that involve the existing clinical infection or the perforated viscera. This definition suggests that organisms causing your post-operative infection were present in the operative field before the operation. So, now if we come back to the question that we were discussing, the proliferation phase begins 2 to 3 weeks after injury. This is a false statement. It does not begin 2 to 3 weeks, it begins from day 3. Open cardiac massage is class 4. No, it is class 3. So, definitely we do not have all of the above the answers, and the compound fractures are your tetanus prone wound. So, this is what we have in your general surgery and your trauma discussion for day 1. So, let me know if you have any doubts. You can email your doubts to me at this particular ID, right, and I'll be happy to solve them if you have any. And at the same time, I'll be trying to come up in YouTube along with some other questions covering your general surgery and trauma if required. So, this is it for the day 1. Now, we'll be meeting tomorrow session where we'll be discussing mainly the gastrointestinal tract. So, keep studying, keep revising, and if you have any doubt, please drop an email in this email ID, or you may also drop in ayushkeshav99@gmail.com. Also, at the same time, I would want to tell you, please follow the game YouTube channel where we are sharing a lot of one-liner contents and high yield series. At the same time, you can also follow my YouTube channel, which is your AK Surgery, and the Instagram channel at your.surgerybuddy. The reason that we are saying you to follow our Instagram and YouTube channel is that because we are sharing a lot of revision contents over there. So, in your pull up to the AIIMS exam, every day in form of short reels or images, 5 to 10 seconds revision would have a great impact in your main exam. So, we'll meet tomorrow now for the next class. Thank you. Hi friends, so welcome to day 2 of discussion of your Inicet for surgery. So day 2 is dedicated to your abdomen, as it's a very important topic. In the last session you had almost around 8 to 9 questions from GIT, and every year we have a tendency of getting around 5 to 6 questions. So let's discuss the important points and topics from your abdomen. So we have our first question over here, which is not true for gallbladder carcinoma. Now, before we begin our discussion on gallbladder carcinoma, it is a favorite topic of your examiners. The last session had around 2 to 3 questions from gallbladder carcinoma itself, and gallbladder in general is a very important section in the hepatobiliary for your INI exam. So let's look at this question. Not true for gallbladder carcinoma. Palpable abdominal lump can be seen. So the answer is true. This is a true statement. You might find a palpable abdominal lump in case of your gallbladder carcinoma. Median age survival is 6 months. Again, this is a true statement. Then clinical presentation of gallstones can't be distinguished initially from gallbladder carcinoma. This is also a true statement, and the earliest sign is jaundice. This is a false statement. Now, why this is a false statement? Because jaundice is often a late sign. This is not an early sign, right? Now, there is another question in from gallbladder carcinoma, which is an early feature of gallbladder carcinoma. We just discussed right now jaundice. No, it is a late sign. So is ascites, and so is a palpable mark. So earliest feature is actually your cholecystitis. Now if you look at this particular option over here, clinical presentation of the gallstones can't be distinguished initially from gallbladder carcinoma. This would have given you a hint to solve the next question itself, because cholecystitis would be the common presentation and hence it would be an early feature of your gallbladder carcinoma. Now before we proceed to the further discussion of the other question, let's look at some of the important points of your gallbladder carcinoma. So the few important points from gallbladder carcinoma, the risk factors. So what are the risk factors? Gallstones, porcelain gallbladder, chronic infection. So these are some of your common risk factors, and a very important risk factor is your polyp size. Please remember, a polyp size of more than 1 centimeter. So they often ask you a question in form of the polyp size. Which polyp size is a risk factor for your gallbladder carcinoma? So a polyp size of more than 1 centimeter would be a risk factor for gallbladder carcinoma. Then the next common question asked is, what is your most common histology? So the most common histology is adenocarcinoma, which is seen in approximately 90% of the patient. Then it has a poor prognosis. It usually has a late presentation, right? What do you mean by late presentation? That is, you will not be able to detect your gallbladder carcinoma early until you are very vigilant and have a dedicated investigation approach towards a gallbladder carcinoma, because as we had discussed in our questions, it might actually present with the features of cholecystitis and you might confuse it with being a normal cholecystitis feature. Then you have your CA99 elevated, which is more than seen in more than around 90% of the cases. Then you have usually minimum of 6 lymph nodes involved. Then an important question that can actually be asked right now from your gallbladder carcinoma is with respect to your T staging. So please remember, T1A is when it is involving lamina propria, and over here a lap chole would be a sufficient treatment. So normally when you come across a situation, now if you have a patient who has gone under laparoscopic cholecystectomy and the histology report is suggestive of your carcinoma, so please remember, if it is T1A, you can actually do just a lap chole. If it is a T1B involving the muscular layer, it is T2A when it has the invasion of the perimuscular connective tissue on the peritoneal side, and T2B is your invasion of the perimuscular connective tissue on the hepatic side without extension into the lumen. Now T3 when it is breaches serosa, and T3 is when it extends into the liver, and T4 is your hepatic artery or the main portal vein or the extra hepatic structures involved. So over here we can anticipate at your level for INI, T1A you would be requiring a lap chole, whereas if it is a 1B, 2A, 2B, you might be requiring to do a radical cholecystectomy. So these are your few additional points from your gallbladder carcinoma that you should be prepared for. Rest, they can just form a clinical based scenario questions like we had discussed in our question, where you need to know that yes, the gallbladder carcinoma is usually a late presentation and the early features would be like cholecystitis. It is not that they would be initially presenting with jaundice. So this is all about your gallbladder carcinoma. So now let's move on to the next question. So our next question is this. So we have this gross image of gallbladder specimen. Now, so what is the diagnosis? Now you can see over here, this is an image of a gallbladder specimen, right? For your hint purpose, they have actually given you a stone. So yes, this is an image of a gallbladder stone. Now another question that can actually be framed from this is regarding your cholesterosis, gallbladder polyp and carcinoma gallbladder. So let's look at the image of your gallbladder carcinoma. So we just discussed about gallbladder carcinoma. So this would be an gross image of your gallbladder carcinoma. So you can look over here. We had also discussed the most common histology is your adenocarcinoma type. So this would be somewhat your appearance of your gallbladder carcinoma. Now looking at the other options that were in the option, so we have this gallbladder cholesterosis or your strawberry gallbladder. So what are this? Now these are your hyperplasia of your tissue elements. Now these are the submucous aggregate of your cholesterol crystals, right? So these are nothing but the submucous aggregate of your cholesterol crystals. Then there is increased absorption of cholesterol, and on USG you have an appearance which is known as your comet tail appearance. Now these are your pre-malignant conditions, and the treatment required would be cholecystectomy. Then we had your gallbladder polyposis. So this is your image of a gallbladder polyposis, and we discussed the important point in your carcinoma where risk of cancer is when the size is more than 1 centimeter. Then we have your adenomyomatosis of gallbladder. So what it is? It is a hyperplastic cholecystosis where there is a hyperplasia of the wall with the formation of another important line, that is your Rokitansky-Aschoff sinuses. Now what are this? These are intramural diverticular which are lined by your mucosal epithelium penetrating into the muscular wall of the gallbladder with or without gallbladder wall thickening. Now cholesterol accumulation in adenomyomatosis is intraluminal as cholesterol crystals precipitate in your bile trap, Rokitansky-Aschoff sinuses. So please remember, this is the most important one-liner that can be framed from your adenomyomatosis of the gallbladder. Then you have your another image which is given in your Bailey and Love, that is regarding your diverticulosis of the gallbladder, which usually manifests as your black pigment stone impacted in the outpouching of the lacunae of Luschka. Now how are they demonstrated? They are demonstrated by your cholecystography when your gallbladder contracts after meal. So this were your few other important one-liners from the options where the questions can be framed, right? So you can see the gallbladders from the hepatobiliary, specifically the gallbladder, it is a very important topic for your upcoming I9 exam. Now let's move down to the next question. So the next question over here is, a 40-year-old woman comes to the emergency with pain and jaundice. Cholangitis is suspected. Which of the following are part of Reynolds pentad seen in cholangitis? So it's a very straightforward question where they have given you enough hint and they're asking you a direct question, Reynolds pentad. So let's look at the option. Fever, yes. Jaundice, yes. Altered mental status, yes. Hypotension, yes. Hypertension, no. So if you look, 1, 2, 3, 4 are your correct options, and if you look over here, C is your correct option. So these are your basic straightforward questions. So this is a new pattern which has been upcoming in your I9 exam, where they would be giving a lot of options and then ask you to choose among the combinations of them, right? So please be prepared for practicing such questions. So now let's look at the discussion of the Reynolds pentad. Normally these questions are formed from your section of your CBD stones. So in the common bile duct, the first important question that is asked to you guys is regarding your primary, secondary, residual and the recurrent CBD stone. So please be very thorough with the definition. What are your primary CBD stones? Now if you look at the definition of primary CBD stone, these are the stones which are formed de novo in the bile duct. Then your secondary CBD stone, a stone in the CBD which have migrated from the gallbladder. Then you have your residual CBD stone, stones that are formed within 2 years. So the limit is over here 2 years. You are often confusing this with your recurrent CBD stones, which is also having a dimension of 2 years, but then this are formed after 2 years, right? So residual is within 2 years, recurrent is after 2 years. So what are your questions that are formed from here? Now if you look at this particular section, the questions that can be formed is like, a patient underwent a cholecystectomy around 10 months back and has presented to you with a CBD stone. What type of CBD stone it is? Please note down the word 10 months. It is within 2 years, so it would be a residual CBD stone. Now if the question had said after 2 years, then it would be a recurrent CBD stone. Now the clinical features. Before going to Reynolds pentad, you must be knowing Charcot triad. Charcot triad is pain, jaundice, fever. Now to it, if you add hypotension, which was the part of our option, it's not hypertension, and mental status changes, this forms your pentad, right? Now going down to the next, how do you investigate? You go for your ultrasonography and MRCP, right? And for your treatment purpose, you would go for an ERCP, a lap chole, or a lap surgery, or an open surgery, and a CBD exploration can be in form of a T-tube or a choledochoduodenostomy. An important concept to remember over here is regarding your MRCP and ERCP. Please remember, MRCP is for your diagnostic purpose. ERCP in today's era is mainly used where you have your therapeutic indication. Just for the sake of diagnosis, it is better that you go for a MRCP, right? So if you have a established CBD stone that you know it is a present in USG, in that case doing an ERCP would be beneficial, because at the same time you can do a therapeutic intervention by removal of the stone and placing a stent. Whereas if you are just finding a dilated CBD like on a USG and you're not pretty sure if there is a stone or not, before proceeding for ERCP, it is always advisable that you do a MRCP. This MRCP would be of diagnostic purpose, right? You do not do an ERCP because ERCP would be requiring a little amount of invasive procedure, right? Inserting an endoscope and other things. So MRCP is for diagnostic, whereas your ERCP for therapeutic as well as your diagnostic purpose. So please remember this important question. Now in your CBD, you have your few important questions regarding your tumors. So the most common benign tumor is your papilloma, and your most common symptom is your jaundice, and you have your coexisting gallstones, which is quite common. So these are your few important concepts that you need to remember from your common bile duct. So now moving down to the next question. So over here our answer would have been C. Now the next question is again on your hepatobiliary. So let's read out the question. A 56-year-old with a surgically obstructed jaundice has a distended gallbladder and a dilated CBD and IHBR on US is your ultrasound, IHBR is your intrahepatic biliary radicals, right? Now the CCT confirmed the same findings with no additional findings. Now which would be the most useful to localize the cause? So options are endoscopic ultrasound, MRI, percutaneous biliary cholangiography, and ERCP. So which is discussed in your common bile duct and a dilated CBD and IHBR. The best investigation next would be your MRI. So this is basically what we call your MRCP, that is your magnetic resonance cholangio pancreatography. So this is on the basis of the same concept that we discussed a while back in your question on your CBD. So I think this is all about your questions from your hepatobiliary system. Now an addition concept that I would like to discuss you all is with respect to your gallstone. If you remember, the specimen that we had a gallbladder specimen along with a stone. So that is one section where the questions can be framed from. So let's take a look at some of the important points of your gallstones. So for the gallstones, first regarding your formation of the gallstone, I'll just run through the formation part. The main factors responsible are your impaired gallbladder function, supersaturated bile, cholesterol nucleating factor, and your absorption of the interhepatic circulation of your bile salts, right? So basically the bile is lithogenic, that is increased cholesterol and decreased bile acid. Then you have another important concept, which is a potential question, that is your triangle of solubility. So what do you have in your triangle of solubility? It is your percentage of cholesterol, percentage of lecithin, and percentage of bile salt. Now when you have a triangle, you will be formed, there will be a question formed asking which of the following is not a part of your triangle of solubility, right? I'm not going into the detailed discussion of the pathogenesis of the gallstone formation, because they would be just asking you some basic questions regarding your formation, like your triangle of solubility, right? And then regarding your types of gallstone, you have three types, that is cholesterol, pigment, and mixed. Pigment can be further of two types, that is your black and brown. Black, hemolysis, hereditary spherocytosis, cirrhosis, sickle cell disease. So you could be again framed a question like a patient of sickle cell disease is present to you with a gallstone. Now which is the most common type of gallstone that you can expect? So it would be a pigment gallstone, and in pigment it would be a black gallstone, right? Then you have your brown, that is in bile duct, and parasites like Chloroniscus sinensis and Ascaris lumbricoides. Then your one-liners, most common type of gallstone in India is your pigment gallstone, and most common type of gallstone in western world is your cholesterol, that is broad or mixed. Then an important question is regarding your effect of gallstone. So when the stone is in the gallbladder, it can cause your acute cholecystitis, chronic cholecystitis, mucocele, pyocele, GB cancer and GB perforation. In CBD, it can cause your obstructive jaundice, cholangitis, pancreatitis, and it can also cause a gallstone ileus. So gallstone ileus, another important question that is asked from here is your regular striae. Now what happens in your regular striae? So again, this can be formed in your clinical scenario. The easy clue to your clinical scenario in a regular striae that is presenting as your gallstone ileus would be multiple air fluid levels, air in the biliary tree, and your stone in the ileum, right? Another important point with respect to your gallstone ileus is that we usually do not perform cholecystectomy in the same setting. So the patient is present with a gallstone ileus, we will just relieve the obstruction and perform a cholecystectomy at a later stage, because such patients would be usually presenting to you in a bad condition. Then you have another important syndrome, that is the Bower syndrome. What is the Bower syndrome? It is the impaction of the gallstone at the first part of your duodenum. Then you have another important syndrome, that is a Mirizi syndrome. So what happens in Mirizi syndrome? So the CHD, that is a common hepatic duct, is getting obstructed by the external compression of stone impacted at the neck of gallbladder. So I would just want you all to remember this definition of your Mirizi syndrome. So now if you have a clinical scenario where they mention that you have a USG done where you have a gallstone at the neck and impacting at the neck of the gallbladder and compressing your common hepatic duct, they are trying to ask you regarding your Mirizi syndrome. Then another important triad is your Sian's triad, which is a gallstone, diverticulosis of colon and hiatal hernia. Please remember, it is diverticulosis, it is not your diverticulitis, diverticulosis of colon. So this is one of the most common confusing options that are given in your exam. Now next, regarding your acute cholecystitis, so we have this Tokyo guidelines for acute cholecystitis. So I would want you all to remember at least the name the Tokyo guidelines is used for your acute cholecystitis. So if you look at this particular grades, grade 1 is that does not meet your criteria for grade 2 and 3, no organ dysfunction, mild gallbladder inflammation. Grade 2 is presence of one or more, elevated WBC, palpable right upper quadrant mass, duration of symptoms more than 72 hours, marked local inflammation that includes your biliary peritonitis, hepatic abscess, gangrenous cholecystitis, emphysematous cholecystitis and pericholecystic abscess. So these are your part of grade 2 of Tokyo guideline. And then you have your grade 3, which has the following features: presence of one or more of the following, which includes your CNS, decreased level of consciousness, CVS, which is your hypotension requiring dopamine more than 5 microgram per kg per minute, or dobutamine, respiratory, that is PaCO2 or FiO2 less than 300, right? And for your renal, you have your criteria: renal serum creatinine more than 2 gram per deciliter, or liver INA more than 1.5, and in hematology you have your platelet count that are less than 1 lakh. So these are your few important basic points for your Tokyo guidelines for your acute cholecystitis, right? So now let's move down to the next section of our questions. So we have the next two questions on the examiner favorite hotshot topic. This is one of the most common indications that you actually see in your emergency postings, and hence the AIIMS have this tendency to ask. This is probably one of the first major OTs done by almost all the first year residents, and I'm pretty sure all the interns must have assisted their first year residents in this OT, right? So which of the following is correct treatment for your peptic perforation? Options: laparotomy, resuscitation, USG, CT scan. Options being only 1, 1 and 2, 1, 2, 3, all. So what would be the answer for this? So those who have done your clinical postings, if you recall during your internship, your first year resident must be calling you, go prepare the patient and send it. What do you used to do in preparing the patient? You used to do a rise tube, you used to do a catheterization, you used to start the patient for fluids. What were you doing? You were actually resuscitating the patient. And after your resuscitation, what would you be doing? The first year used to ask you to send the patient to the OT, where he used to do the laparotomy. Please remember, peptic perforation usually would have been the first OT for almost all the first year residents, including myself. I still remember one of the first OTs was regarding your peptic perforation. So here our answer would be only 1 and 2. Right. Now we have the next question, which is again similarly based on this concept. Now, a 26-year-old male patient was brought to the emergency department with abdominal pain and obstipation for 3 days. He gives a history of bull. Go to the abdomen. His X-ray is given below. What is the probable diagnosis? Right. So I'll just show you the X-ray image. Right. So this is our image. Right. So if you look over here, you have your air under the diaphragm. So this is the second most common type of the question that can be framed from your topic of your peptic perforation. Either they give you a clinical scenario and ask you regarding the management, or they give you a clinical scenario with an X-ray image and ask you the diagnosis. Right. So peptic perforation is a very important topic. So these were the two important questions that we could expect again in your AIIMS exam, because as I said, these are your most common laparotomies that are actually done in emergency by the surgery residents. In fact, it was even one of my first OTs that I had done in my residency. So now let's just look at some of the other important points that we can get from your peptic perforation. So this peptic ulcer perforation is usually one of the complications of your peptic ulceration. So if you look at over here, this would be the X-ray image, a classical gas under the diaphragm. I'm pretty sure you guys must have even come across your Viva table. This is one of the mandatory X-rays that you get in your final MBBS year Viva. So you have your presentation in form of severe pain in abdomen, or they might present actual features of shock. Now in your abdominal findings, you usually find your guarding or a cardboard rigidity and rebound tenderness. So basically they have features of peritonitis, and your treatment would usually have your resuscitation and your exploratory laparotomy. And exploratory laparotomy, what do you do? Now this is the most important point where I have taken over here. So the next question they can ask you actually is, the operative procedure include what? A gram patch closure, peritoneal lavage, both, none. The answer would be both. So please remember, this peritoneal lavage is a very important component of your exploratory laparotomy that is done for your peptic perforation. Right. So I hope the concepts on the peptic perforation is clear, and the reason why we put this question over here is because it was asked in your FMG exam, it was asked in your NEET PG exam, and trust me, these are the questions which have the tendency to be repeated. Now this question can even be repeated in your INI exam, and such are the questions which are your high scoring questions where you are not supposed to make a mistake. Right. So now let's move down to the next concepts on the stomach. We'll be discussing the stomach tumors, specifically your GIST, that is your gastrointestinal stromal tumor, and your gastric cancer. So a 36-year-old female presents with the mass in the outer lining of the stomach with the IHC positive for CD117, negative for S100 and cytokeratin. Right. What is your diagnosis? So the answer is your gastrointestinal stromal tumor. Right. You had enough hints in your questions. Now from your gastrointestinal stromal tumor, this is one of the favorite topics for your examiner. Now if you have a option to revise gastrointestinal stromal tumor and a gastric carcinoma, I would suggest you to revise first your GIST, because they have a tendency to ask more from your GIST. So let's look at the important points of your gastrointestinal stromal tumor. The first question that is asked, most common site, stomach. Mutation, c-KIT gene mutation. Origin, it is mesenchymal. Whether it is more in male or female, it is equally male and female. What are the what are the drugs to which the tumor is sensitive? It is sensitive to imatinib. Then if there is a mutation in exon 11 of c-KIT, it will make it more sensitive. What are your predictors of metastasis for your gastrointestinal stromal tumor? So the predictors are size and mitotic index. Then mets are common to your peritoneum and liver. The important concept to remember from over here is that it is very rare that the metastasis happen to your lymph nodes. Then you have a criteria over here which you need to remember, which is your Fletcher criteria. Now what about the Fletcher criteria? Size is more than 5 cm. There is presence of metastasis. Mitotic index more than 5/50 high power field. Then they usually arise from your interstitial cells of Kajal. Now this is again a very important MCQ. So each line that I have been discussing in your gastrointestinal stromal tumor is a high yielding topic and a point which can be asked in your questions. They can be asked as your one liner, or they can be asked as your true or false statement. Then perioperative biopsy, it is usually not recommended. Why? Because it would increase the chances of perforation and bleeding. Then what are your tumor syndrome with which it is associated. It is associated with your familial gist, Carney's triad, Carney-Stratsky syndrome, and type 1 neurofibromatosis. An important question asked over here is regarding your Carney triad. What are the components of your Carney triad? Now, these are your gastric GIST, pulmonary chordoma, and your extra-adrenal paraganglioma. Now, what happens in your Carney-Stratsky syndrome? Please remember, there is no pulmonary chordoma. So this is the most important differentiating feature. Now, these questions have been asked previously in your other competitive exam, hence they have been mentioned over here. So please do revise regarding your Carney's triad. Now, another important entity is regarding your succinate dehydrogenase deficient GIST. So what happens in this? They are seen in pediatric population associated with your Carney's triad or your Carney-Stratsky syndrome, and they are KIT1 positive and DOG1 positive, right? So these are specific to your succinate dehydrogenase deficient GIST. Then regarding your IHC, you have your c-KIT and CD117, CD34 and DOG1 positive. So this was the most important clue that was given to you in your question. Now there is another criteria which is called your Choi criteria. Just remember the name for the time being, which is your CT scan criteria to evaluate the treatment response evaluation. Then what is your management of your GIST? So if it is on the initial diagnosis of GIST, you see whether it is resectable or unresectable. If it is resectable, then you go for surgery. Now you look for the recurrence risk. If it is a very low or a low recurrence risk, you will follow up the patient. If it is moderate or high, then you give the patient imatinib, which is your 400 milligram per day. And if there is recurrence, after stopping, then you start again imatinib 400 milligram per day, and you see if it is progressing. If it is progressing, then you escalate the dose to 800. Whereas if there is a recurrence while on imatinib, you actually escalate the dose from 400 to 800. Now if there is still progression, then you go for your sunitinib and regorafenib. So this is again your potential one-liners that can be asked as which of the following drug is used in your GIST. Now again, if you see the patient is unresectable or there is a metastatic disease, you see for your imatinib. Now imatinib you check 400 milligram. Now you repeat imaging 1 to 3 months. Now if it is a stable disease, you see if it is resectable, then you consider surgery. If it is unresectable, then you continue your treatment. Now if there is a progressive disease and if it is unifocal, then you actually consider doing surgery. Whereas if it is multifocal, you escalate the dose, and if it still does not work, you go for your sunitinib and regorafenib. So these are your few important points regarding your management of your GIST. So if you follow this flow chart, it is going to help you in the management. So now moving down to the next concept. So before going that, so these are your few images which I have taken from your Bailey and Love. So you can see this is the GIST on the greater curvature of the stomach with the ulceration. The reason why I am taking the images from your Bailey and Love, because this is one of the most standard textbooks and expect your examiners to frame questions from you directly from here. Then this is again an image of CT scan showing a GIST. So please remember, this could be again a part of your question where they frame a question clinically, give you a CT scan and ask you for the diagnosis or regarding the true or false statement regarding your diagnosis. So you need to form the diagnosis, remember those points and move. Now one of the options was the lymphoma, right? So I would want to discuss a few important points with your lymphoma. These are most common in your 6th decade, associated with your H. pylori. Diagnosis is via your endoscopic biopsy. Treatment is chemotherapy. And when would you do a surgery? When you have hemorrhage, obstruction, perforation, or a residual disease after CT, or you have lymphoma confined to one part of the bulb. So these are some of the indications of surgery for your lymphoma, right? Now let's move down to the next question. Now the next question that we will be discussing is on gastric carcinoma. So which of the following is true with respect to your gastric carcinoma? Mostly hereditary? No, it is a false statement. E-gathering defect is seen in diffuse type of gastric cancer? True. WNO signaling pathway is defect in intestinal type of gastric cancer? False. Depth of cancer has no role in prognosis? False. So your correct answer over here would have been your key gathering defect is seen in your diffuse type of gastric cancer. Right, now let's discuss the few other importance from your gastric carcinoma, as it's a very important topic. So the first important concept is regarding your etiology. Etiology includes your H. pylori, pernicious anemia, gastric atrophy, peptic ulcer, surgery with drainage, gastric adenoma polyp, which is the most common type of gastric polyp, metaplastic polyp, polyp which is associated with PPIU is fundic gastric polyp, and polyp associated with FAP is again your fundic gastric polyp. So this is a sideline topic which I wanted to discuss over here, because again you have some of your one-liners questions which are often asked from your gastric adenomatous polyp. Right, then cigarette smoking, excessive salt intake, and exposure to your N-nitroso compound. So these are your etiology for your gastric cancer. So you can be framed a question by giving the various options and ask which of the following are your risk factors for your gastric carcinoma. Now the clinical features would be your bleeding, early satiety presenting with your gastric outlet obstruction, and your non-metastatic effects like your Troche sign, which is your thrombophlebitis and deep venous thrombosis. Now what is most common site? Please remember, in West it is your proximal stomach cancer. Now we have very important classifications in your gastric cancer. First is your Laurin classification. So in Laurin classification we have two types: intestinal gastric cancer and your diffuse gastric cancer. So one of the questions that we had seen right now had the answer framed from this particular table which has been given in your Sabiston textbook. So what is your intestinal gastric cancer? It forms the polypoid tumor and also diffuse gastric cancer. It infiltrates deeply into the stomach without forming any obvious mass lesion. Now if you look at the various definitions or various important differences between your intestinal and diffuse. Intestinal, it is environmental, and diffuse is familial, and we had in the option most common type is hereditary. So now you are getting it why the answer was wrong. Then gastric atrophy and intestinal metaplasia. Now these are usually associated with your blood type A. Then it is much more common in men compared to women, whereas diffuse is much more common in women. Then it is again common in your increasing incidence with age, that is the intestinal type. The diffuse type is much more common in your younger age group. Then you have gland formation in your intestinal type, and you have your signet ring cells or poorly differentiated cells in your diffuse type. Then we have your intestinal type, which is again having a hematogenous spread. Diffuse is having a transmural or lymphatic spread. Then you have microsatellite instability in your intestinal type and decreased E-cadherin, the answer which is in your diffuse type. APC gene mutation, P53, P16 inactivation in your intestinal type, and again P53 and P16 inactivation in your diffuse type. So this is a high yield and a very important table for your exam. Now again some important points regarding your early gastric cancer. Now these are limited to mucosa or submucosa with or without lymph node involvement. So please remember this definition, because this definition can actually be directly asked to you as a question. Now the various type. Now this is your Japanese classification. So you have your type 1, which is your protruding type, type 2, which is your elevated type. Then you have type 3, which is your flat type, type 2b, sorry. Then you have your type 2c, which is your depressed type, and type 3 is your ulcerated type. Right, so this is an image again taken from your Bailey and Love. Now you can expect two sort of questions. One is the Japanese classification is used for, and the second question that they can frame for you is regarding giving you a particular image and asking trying to identify the type. Then you have your advanced gastric cancer, where it infiltrates your muscularis. So if you look at this classification, this is your Borman classification, right? Now in type 1 it is a polypoid, type 2 it is ulcerating, type 3 it is infiltrating, and type 4 is your Linitis plastica. Again, now the most important questions, do not get confused. Borman is for advanced and Japanese is for your early cancer. Now regarding your molecular pathology, you have usually 4 molecular subtype, which is EBV positive, microsatellite unstable, genomically stable, and chromosomal instability. The spread usually direct. Lymphatic would be Troche sign, that is the supraclavicular lymph node. Then you have your blood-borne metastasis, that is the first to your liver. Then transperitoneal spread over here, if you have it goes down to ovary, then it is it is known as the Krukenberg tumor. If it is at umbilicus, it is your Sister Mary Joseph nodule. And please remember, the transperitoneal metastases are best detected by your laparoscopy. Right. Then another important question in your gastric carcinoma comes from the staging. So TIS would be a carcinoma in situ. T1A is which invades your lamina propria, muscularis mucosa. T1B is submucosa. T2 is muscularis propria. T3 is subserosa, T4 is perforate serosa, and 4B is invading adjacent structures. Then you have your end staging, where you have N1, that is 1 or 2 regional lymph nodes, 3 or 6 regional lymph node would be your N2, N3A would be 7 to 15 regional lymph nodes, and 3B would be 16 or more regional lymph node. M0, M1 would be no distant metastasis, and M1 would be your distant mets. Now regarding your features of incurable disease, now another question that is formed is hematogenous mets, involvement of distal peritoneum, M1 nodal disease, and your fixation of structures that are not resectable. So what surgery do you do? Total gastrectomy. What it includes? Stomach en bloc tissues of greater plus lesser omentum, dissection margin, remember 5 centimeter. Then how do you establish your GI continuity? That is by your Roux-en-Y loop. Now important questions that are asked from your Roux-en-Y loop includes elementary limb. The length is around 50 centimeter. Why? To avoid your bile reflux esophagitis, right? Then regarding your lymph nodes, D1 is your removal of perigastric lymph nodes, and D2 is your lymph node removed along the major arterial vessels. So this is your image of a radical total gastrectomy. So I've just kept this image for you guys so that you just look at this image, right? Just look at these steps, the current trend. They might just put forward the image and ask this image, this surgery is done for which procedure, right? So please remember, look at the removal of the stomach and the establishment of the continuity. Right, now you have your subtotal gastrectomy, which is usually done for your distal tumors, and palliative surgery is needed when you are a patient having presenting with bleeding and obstruction and you gotta resect the entire tumor. So palliative radiotherapy is used in your painful bony mets, and you have your complications of the surgery, which includes vitamin B12 deficiency, anastomotic plaque, and duodenal stump blowout. Then your neoadjuvant chemotherapy is your platinum based triplet regimen, which is your epirubicin, cisplatin, and 5-fluorouracil. Then you have your FLOT, which is fluorouracil, leucovorin, oxaliplatin, doxycycline. Then the trials for perioperative, that is before and after surgery, is your MAGIC trial. Please remember the trial name, that is your MAGIC trial. So these are your few important questions that I think can be asked from the stomach section. Now let's move down to the next question. Now the next question that we have is, a patient presents with a partial bowel obstruction, weight loss, strictured end bowel, what will be the management? Now if you look at this question, the hints that have been given to you is your bowel obstruction, weight loss, stricture. Now if there is a stricture, what you would be needing to do is a laparotomy, and this particular features are suggestive of your bowel tuberculosis, so you would be requiring an antitubercular therapy following a laparotomy. So this was a straightforward question based on the concept of your abdomen TB. This is what we do regularly in a clinical practice. If there is a stricture and a partial bowel obstruction, in order to overcome that, you would be requiring a laparotomy, right, followed by your antitubercular therapy. Now moving down to the next question. Now it was a straightforward question, identify the image. So if you look over here, this particular bowel, right, this is the classical presentation of your sigmoid volvulus. Again, a favorite topic of your examiners, which have been asked innumerable time in your other exams also, like your FMG, NEET PG, and in your AIIMS. Again, this is again asked frequently because this is one of the most common surgeries that you often actually perform as a resident in your residential training at such institutes. Like even one of my first intestinal obstruction cases was on the sigmoid volvulus, right? So let's look at some of the important points of your sigmoid volvulus. So let's start our discussion with the definition of volvulus itself. What is volvulus? Volvulus is the twisting or the rotation of gut around its own axis. So as you can see over here, this is the twisting of the gut around its own axis, which results in a closed loop obstruction. Now some important one-liners from your volvulus. The most common type of volvulus is your sigmoid volvulus. The most common site is sigmoid colon. The most common type associated with pregnancy is your cecal volvulus. The most common type associated with your barotrauma is your cecal volvulus. Volvulus associated with your laxative abuse is your sigmoid volvulus. Anticlockwise volvulus is your sigmoid, and your clockwise volvulus is your cecal and midgut volvulus. So these are your treasures, which are one-liners which can be asked at any point of time, and you should not miss on them, right? Now the mainstay of diagnosis remains your CT scan. Now regarding cecal volvulus, it is much more common in female. Clockwise X-ray, where you have apex towards the left upper quadrant, single air fluid level, teardrop sign are the few important signs seen on X-ray, and your treatment would include your exploratory laparotomy and resection and anastomosis. Now the sigmoid volvulus in proper. Now what are your causative agents for your sigmoid volvulus? Because of the short attachment of the mesentery, loaded colon and the parietal attachment, then it has a tire like feel over the abdomen. So this is again an important clue to the clinical question that you might get. Now over here you have an apex towards the right upper quadrant, 2 air fluid level, omega sign, bent inner tube sign, coffee bean sign and Fromendahl sign. So these are your few important signs which are seen on X-ray. Right. Then you have signs seen on barium, which includes your bird beak, bird of prey, ace of spade. Then in CT scan you have your whirlpool sign. Now how do you diagnose the sigmoid volvulus? It is with the help of your clinical features, X-ray, and definitely the mainstay would remain your CT scan as we had discussed. Now after your diagnosis, you go for your fluid resuscitation and your electrolyte correction. Now if there is any evidence of perforation, peritonitis or gangrene, then what do? You take the patient to operating room, go for a primary anastomosis or a Hartmann procedure depending upon the clinical condition of the patient. Now if there is no evidence of perforation or peritonitis, you would go for an endoscopic detorsion with the placement of rectal tube for the ongoing decompression. If it is successful, then you go look for the reasonable risk operative candidate and your recurrent episodes. If so, then you go for a semi-selective sigmoid colectomy. If true, then you can continue with the expectant management. Now if there are reasonable risk operative recurrent episodes, if there is no successful endoscopic detorsion, then you need to take the patient back to the operating room for your primary anastomosis or a Hartmann procedure. Now in addition to sigmoid volvulus, I would actually add one more topic of discussion which is a very important topic, that is your gastric volvulus. So the first common question that is asked from your gastric volvulus is regarding your most common type of gastric volvulus. The most common type of gastric volvulus is your organoaxial. Now what happens over here? The stomach rotates around its longitudinal axis, that is a transverse line junction between your pylorus and GE junction. It is seen usually in 2/3 of the cases. So if you look over here, this is an image of your organoaxial. Now what happens in your mesenteroaxial? Now the stomach rotates around the short axis longitudinal line parallel to the gastric hepatic omentum. So look over here, this will be the parallel line to the gastrohepatic omentum where the stomach rotates. This is your mesenteroaxial. So the first important question that is usually asked and can be asked is the most common type of your gastric volvulus is your organoaxial. Now another important question that is framed from here is regarding your Bouchard's triad. So what is your Bouchard's triad? Severe epigastric pain and distension, vomiting followed by your retching with inability to vomit and difficulty or inability to pass your nasogastric tube. So two questions, components of Bouchard's triad, and Bouchard's triad is used for your gastric volvulus, and the most common procedure that is done over here is your gastropexy. So this were your few important parallel topics along with the sigmoid volvulus that can be asked in your upcoming exam, but volvulus is a very important topic for your INI exams. So now let's move down to the next question. Now moving down to the next question, identify the lesion in liver. Now these are a very straightforward question. So if you look over here, these are your cystic lesions, right? So this is a USG image showing a cystic lesion. So this is your hydatid cyst, right? Now the next important question that is again from your hydatid cyst is again this. Now 35-year-old presented to the OPD with your right flank pain. CD image is shown below. So if you look over here, again your cystic lesions in your liver. So this is again a diagnosis which is your hydatid disease, right? Hydatid liver disease. So this is a CT image. So there are two forms of questions that can be asked. One is via your USG image and one is your CT image. So albendazole should be given. Answer is true. Then caused by dog tapeworm, true. Leakage of cyst can cause anaphylaxis, yes, because of the daughter cyst. FNAC required before surgery, no, the answer is false, right? So please remember the USG and the CT image and the causative agent for your hydatid cyst, which is the echinocosis So we are discussing this, right? So the answer is FNAC. We do not require an FNAC before surgery. I was saying you regarding the causative agent. So the causative agent is your Echinococcus granulosus. So this is another important question that is asked from your hydrated cyst of your liver. So USG image and the CD image, you need to remember this would be your classical clinical features. You give albendazole, it is caused by dock tapeworm, leakage of cyst can cause anaphylaxis, and FNAC is usually not required before your surgery. Now moving down to the next question. So this is again as we are discussed in your day 1 also, this sort of questions are becoming very common. So which of the following is the correct match? Rat tail sign, football sign, string sign and inverted umbrella sign options were given, and you have your achalasia cardium, pneumoperitoneum, hypertrophic pyloric stenosis and your ileocecal TB. So what I'll do is I'll just discuss the particular signs right now, and I'll be coming with a detailed discussion of all the signs in one of the videos in the YouTube in the Game PG channel. Now what you need to remember, let's try to solve this. Right now, if you do not know any other sign, one of the most important signs that we know is the rat tail sign. Rat tail sign is seen in your achalasia. Now if you look at the options, A4 is cancelled, so we have an option between option A and option B. Now this football sign is seen in your pneumoperitoneum. Then you have your string sign, right, which is seen in your hypertrophic pyloric stenosis, and inverted umbrella sign is seen in your ileocecal tuberculosis, right. So if you look at the option A would have been your right answers. What I'll do is, these are the signs which you need to remember. Definitely rat tail sign was one of the most commonest sign which you would have not missed, and we often discuss it in the esophagus section also. So I agree, and the rest signs we need to keep revising, and football sign was discussed in your radiology section in your classes also. One of the important, not important, is actually rare signs seen in your pneumoperitoneum, but it is quite frequently asked in your exam. So please remember that this sign sort of questions can come. What I'll do is I will make a list for your signs and upload it in the Game PG YouTube channel. So just take a look over there. Now let's move down to the next question. Now, which of the following investigation is not done in achalasia? Time barium study, true, we do it. In endoscopy, yes, we do it. Esophageal manometry, yes, we do it. 24-hour pH monitoring, no, we do not do it. We do it in your GERD, right? So esophagus is again an important section where you have a lot of questions framed. So let's look at some of the important topics from the esophagus before we proceed down to the next question. And remember, achalasia we had just discussed in the previous question itself, the rat tail sign also, right? So let's look at some of the important topics of esophagus. So achalasia is one of the motility disorders. So please remember regarding your Chicago classification, and remember that we have a new updated Chicago classification for your motility disorders, where you have your step 1 where you perform the 10 wet swallows in your primary position. Now if there is an abnormal median IRP, then what do? You see for the 100% absent peristalsis, and whether all swallows are either failed or premature. Now if it is so, then if it is 100% failed peristalsis without POP, then it would be achalasia type 1. If it is a 100% failed peristalsis with POP in more than 20% of swallows, it would be achalasia type 2, and achalasia type 3 when it would be more than 20% swallows with premature contractions, failed peristalsis and POP may be present. Now why are we discussing this? This is a recent edition of your Chicago classification, so you might just be getting your basic questions from your Chicago classification. Type 1, 2, 3 definitions have a little bit of change, so you just need to know them, right? Now if there is abnormal median IRP is not present, then what do? You do a step 2, right? What is your step 2? That is wet swallows in your secondary position. Now I'm not going into a further detailed discussion of your Chicago classification. You have my video also of this Chicago classification which I discussed in your Game PG YouTube channel, or I shall put it up again over there. But for this class, why I wanted to mention this over here is that you need to know that we have moved down from the 3rd edition to the 4th. That is your Chicago classification 4 that we are recently doing, right? Now a few important points of achalasia. It is failure to relax. What happens over here? There is loss of inhibitory ganglion cells in the mesenteric plexus, which is basically due to the virus induced autoimmune effect. Now what happens is that during a normal swallow, the food bolus will trigger the primary peristalsis in the esophagus by the sequential activity of the excitatory lower motor neuron. Now at the same time, the relaxation of the LOS allows the esophageal emptying. Now this mismatch in the excitatory and the inhibitory activity results in the failure of your lower esophageal sphincter relaxation and absent peristalsis. Now what happens? With time, the esophagus would dilate and the contractions disappear. Now the esophagus empties mainly by the hydrostatic pressure of its content, which is nearly incomplete, leaving your residual food and fluid. Thus esophagus may become progressive dilated, more tortuous, and a megaesophagus may form, and a persistent retention esophagitis due to the fermentation of food residues may predispose to the increased incidence of the carcinoma of esophagus. Right. The most common age is 30 to 60 years of age. The classical triad is your dysphagia, weight loss, and regurgitation. Then you have an important score, which is your EGDAT score. Please remember the parameters, which includes your weight loss, dysphagia, retrosternal pain, and your regurgitation. Your diagnosis would include your barium contrast, which has a rat tail appearance of your achalasia. The definitive diagnosis would be with your high resolution manometry. Your treatment would include medical therapy in form of calcium channel blockers, nitrate, 5-phosphodiesterase inhibitors, botulinum toxin, pneumatic dilation, and Heller's myotomy. POEM is a recent treatment in your esophagus, where you have minimum of 6 cm esophagus and 2 cm in gastric cardia, and esophagectomy would be required in cases of your mega esophagus. Now a few important points regarding your hypercontractile motility disorder. So I'll be discussing the diffuse esophageal spasm. This is an incoordinate, premature, rapidly propagated contraction of esophagus, dysphagia, chest pain, and it is usually found in your distal 2/3. So there is a hypertrophy of circular muscles, and you have a classical presentation, which is your corkscrew esophagus. Right. So this is your example of a barium contrast study showing a corkscrew esophagus in a patient with your diffuse esophageal spasm. So now moving down to the next important topic from the esophagus is your Barrett's esophagus. So a few important points from your Barrett's esophagus. It is a known complication of your gastroesophageal reflux disease. Now what happens in your Barrett's esophagus? There is a proximal migration of your columnar epithelium in the lower esophagus, extending more than 1 cm above your esophagogastric junction. It is basically your columnar metaplasia, a very important MCQ. Goblet cells initially was considered to be diagnostic, but the recent addition of your Bailey and Love has said it to be controversial, right? So when you have in your option, just look at the options and then you frame your answer accordingly. Now the length of Barrett is the risk factor for neoplasia. Then there is another classification, which is your pre-classification. What I would want you all to remember is that it includes your circumferential and the maximum extent visualized on the endoscopy, right? Then the various risk factors for your Barrett's esophagus include chronic GORD symptoms. Now what would be your definition of your chronic GORD symptom? It would be for a duration more than 5 years. Then you have your advanced age, that is more than 50 years, smoking, central obesity, and a male gender. Cancer progression, in case of low grade you have a risk of around 0.7%, and a high grade you have a risk of around 7%. Then we have another biopsy protocol in your esophagus, which is your cetal biopsy protocol. Now what happens over here is we do a 4-quadrant biopsy every 2 cm in addition to the targeted biopsy. The treatment would include your same as your gastroesophageal reflux disease. So we have this new chart which is for management of Barrett's esophagus. So if you have your flat columnar mucosa, you do a systematic cold biopsy, then you have to confirm this dysplasia by 2 independent pathologists. Now if there is no dysplasia, what do? You look for your maximum length less than 3 cm, gastric metaplasia, you repeat a OGD, and then if it is length is less, then you just consider discharging. Now if the maximum is length is less than 3 intestinal metaplasia, you just repeat your esophagogastroduodenoscopy every 3 to 5 years, where if it is more than 3 cm, you repeat every 2 to 3 years. So here comes the difference, right? Please note this, if it is less than 3 centimeter, it would be done at 3 to 5 years. If it is more than 3 centimeters, it would be done at every 2 to 3 years. Now, if it is indefinite for dysplasia, what will you do? You will repeat with maximal acid suppression. Now, if it is no dysplasia, you would follow the plan for your no dysplasia. If it is a definite dysplasia, what will you do? You will either follow a LGD, that is your low grade dysplasia, or the high grade dysplasia flowchart. Now, what are those flowchart? Now, in case of low grade dysplasia, you check the OGD every 6 months until you have 2 consecutive evidence of non-dysplastic Barrett's esophagus. If so, you follow the non-dysplasia flowchart. Now, if you do and you find that there is a high grade dysplasia, you usually take the patient for your multidisciplinary team discussion and a therapeutic intervention, which would usually involve a endoscopic eradication therapy, right? So, this were the few important points with regards to your Barrett's esophagus. Now, another important short topic that I would want to discuss with you in esophagus is the esophageal diverticula. Esophageal diverticula are of 2 types, true and false. True is one which involves all the layers of esophagus. False are your mucosal outpouching. The most common symptoms include dysphagia, regurgitation, halitosis, and your recurrent aspiration. Now, pharyngeal diverticulum, which are your Zenker's diverticulum. What are they? They are your false Purkinje diverticulum. Now, there is usually dehiscence at the Killian point, which is a natural weak point. Now, this protrudes above the cricopharyngeal sphincter between the oblique and the horizontal fibers of your inferior constrictor. So, you might be having a question directly framed from this particular line, right? Now, this is an image showing a Zenker's diverticulum. What would be your treatment? Treatment would be your diverticulectomy, cricopharyngeal myotomy, transoral stapler, which would be to divide the septum. Then you have your mid-esophageal diverticulum, which is your Rokitansky diverticulum. Now, these are your small traction diverticulum, which are usually true diverticulum, and the cause is your granulomatous disease. Now, is your epiphrenic diverticulum. Now, these are your Purkinje diverticulum. Where does it occur? It usually occurs at your distal 10 centimeter of your esophagus. Now, these are associated with your esophageal motility disorders. Barium esophagogram is used for diagnosis. Now, in case of large diverticula, you would require an excision plus myotomy from the neck of the diverticulum to the cardia. So, this were the few important points from your section of the esophagus. Now, we will move down to the next section of discussion on the abdomen, which would include your some important concepts from the colon, appendix, and your spleen, and we'll end our discussion on the abdomen with the hernia discussion. So, let's move down to the next question from the section of colon. Before moving on to the discussion for your colonic part, we have one question on your hepatocellular carcinoma. So, the question is as follows: which of the following statements are correct regarding hepatocellular carcinoma? TACE is used for multiple lesions. Levatinib is used for treatment of hepatocellular carcinoma. Incidence of HCC is increasing. NASH and NFLD are risk factors for your hepatocellular carcinoma. So, you have the first statement, which is TACE is used for your multiple small lesion. So, this is a true statement. What is TACE? TACE stands for your transarterial chemoembolization. Now, the next statement is your levatinib is used for your treatment of HCC. This is again a true statement. Please remember, it is used for advanced, not early hepatocellular carcinoma. Then incidence of hepatocellular carcinoma is increasing. This is again a true statement. NASH and NFLD are risk factors for hepatocellular carcinoma, which is again a true statement. So, over here your answer would have been all. Now, let's take a look at the some of the important points of hepatocellular carcinoma along with some of the important points of other liver tumors. So, in your liver tumors, you have your 2 groups again, which is benign and malignant. Malignant includes your hepatocellular, hepatoblastoma and secondaries. Benign includes your hepatocellular adenoma, focal nodular hyperplasia, nodular degenerative hyperplasia, and your bile duct adenoma, cisadenoma, which are your epithelial components, and your mesenchymal components in form of hemangioma, lipoma, and leiomyoma. Now, let's look at the important points of your benign liver tumor. So, in case of hemangioma, it is the most common solid tumor. it is most common benign tumor, equal incidence in male and female. OCP use is not associated with it. This is a very important point, because when we are going to differentiate it with focal nodular hyperplasia, you will find that over there the OCP use is associated. So in your clinical scenarios, you might get this one-liners as the clinical clues. Now it is a soft bluish red spongy mass. Giant hemangiomas are one which are greater than 4 cm, usually asymptomatic, and the first line is USG, and MRI is found to be better than CT. The indication for surgery includes rupture, giant hemangioma, and if it is symptomatic, and they have a slow contrast enhancement due to the small vessel uptake in the hemangioma. Now in case of your focal nodular hyperplasia, you have your much more common in female compared to males. It contains the hepatocytes and Kupffer cells encapsulated. They have central stellate scar. The hallmark is your presence of bile duct elements, absence of portal venous structures, and central stellate scar. Diagnosis is on the basis of CT, MRI, or sulfur chloride scan. They do not have any malignant potential, and usually no treatment is required. Now we have your hepatic adenoma. So I think I made a mistake while saying you regarding the OCP use. OCP use is not associated with focal nodular hyperplasia. It is rather associated with your hepatic adenoma. Now it is much more common in female, strongly associated with your hepatic adenoma, associated with DM and type 1 collagen storage disorder. They usually have hepatocytes, but the Kupffer cells are absent. Now the portal venous structures are present and bile duct elements are absent. So these are few of the differentiating points when you are comparing it with the focal nodular hyperplasia. Diagnosis is on the basis of increased alpha fetoprotein. MRI and CT scan are your radiological tools for the diagnosis. Now on CT scan, it usually presents as your hypervascular heterogeneous arterial phase, and azodense and hypodense on the portal phase as a result of your AV shunting. Now the treatment in case of your acute hemorrhage, you would require an hepatic artery embolization and resection in case of a symptomatic mass, and resection before a planned surgery. So this were a few important points regarding your benign liver tumors. Now just a small overview and a quick overview regarding your hepatocellular carcinoma. This is the most common primary malignant tumor of the liver. You have your factors associated, which includes Hep B, C, alcohol, autoimmune hepatitis, alpha toxins, thorax and metabolic disorders, in addition to NASH and NAFLD, which we were in your options. Then the morphological types include your classic and your fibrolamellar. You need to know the differences between the classic and the fibrolamellar type. In your classic type, you have your male much more common, female usually in 55-year age group, invasive, less than 25% are resectable, 90% are associated with cirrhosis, 80% are associated with raised alpha fetoprotein, and 65% are associated with hepatitis B. Now in case of your fibrolamellar, you have male equals to female, 25-year, well circumscribed, more than 75%, less than 5% cirrhosis chance, less than 5% alpha fetoprotein elevation, and less than 5% are associated with your hepatitis B. Now coming down to the pathological type, we have three varieties of pathological type, which include your hanging, pushing, and infiltrating. Hanging type, which is tumor connected to your liver by pedicle. Pushing is well circumscribed interface between your tumor and your liver parenchyma, whereas in case of infiltrating, you have irregular infiltrating tumor mass into the liver parenchyma. Now what is the most common symptom? It is abdominal pain, and most common sign is your hepatomegaly, which is much more common than your ascites. Now paraneoplastic syndromes associated with it include your hypoglycemia, hypercholesteremia, hypertension, gynecomastia, osteoporosis, hirsutism, and carcinoid syndrome. Now the investigations include your CT scan and your biochemical markers, which are alpha fetoprotein, glycipan 3, and PIVK11. Now another very important table is your CTP classification, which is your Child-Turcotte-Purke classification of your hepatocellular function and cirrhosis. So this includes the 5 parameter, which includes the bilirubin, albumin, ascites, encephalopathy, INR, and the scoring is done on the basis of 1 point, 2 points, and 3 point H. So the question that have been asked is regarding what is your CTP classification and what are your parameters of classification, which of the following is not included. They usually use 3 options from here and a random option, which would be your answer. Now regarding your treatment in general, we can just follow this flow chart regarding deciding the treatment. HCC, if we see if it is a candidate for resection, how you decide whether it is a candidate for resection. If it is non-cirrhotic, childless, single lesion and no lymphovascular invasion, so these are usually your early hepatocellular carcinoma. Now if they are not for candidate for resection, you check whether it is for transplant. Now how do you check for transplant? On the basis of Millen criteria. What? Single lesion less than 5 cm, less than 3 lesion and less than 3 cm, and no lymphovascular invasion, and then on the basis of your MELD score, which includes your bilirubin, INR and serum creatinine. Please remember, albumin is not a part of MELD score. Why I am saying albumin is not part of a MELD score? Because most commonly they usually give albumin in your option, and we often tend to mark it, confusing it with the CTP component. So you need to remember that in MELD you have your bilirubin, INR and creatinine, and in case of your CTP you have your bilirubin, albumin, ascites, encephalopathy and INR. Right. Now if it is more than 18, you go for an orthotopic liver transplant. If it is less than 15, a liver transplant is contraindicated. Now if there is no METs and more than 4 lesion, you use radiofrequency ablation, you use sorafenib, or you can even use your lenvatinib, which are part of your immunotherapy. Then you also use transcatheter arterial embolization and systemic therapy. Right. So this is in general an overview regarding your hepatocellular carcinoma. Now let's move down to the next question. So our next question is on colon cancer. Which of the following is true about colon cancer? Colon cancer can be prevented by metformin. Yes, it is a true statement. It can be prevented by metformin and use of NSAIDs. Then right and left colonic aneurysms have different presentation. Then this is again a true statement. Colon cancers can be hereditary. Right. So again this is a true statement, and colon cancers are frequently metastasized to the liver. So even this is a true statement. So here our answer would be all are correct. Right. So this is a very important topic for your INI exam, where they have frequently asked questions from your colon cancer. So let's look at the colon cancer in general and overview, and then come back to the next question, or rather we can actually discuss the next question, because even this is with respect to your colon cancer. So which of the following vessels are ligated during surgery before carcinoma transverse proximal colon? So what would be the answer over here? The options are ileocolic and right branch of middle colic, ileocolic, right branch of middle colic and trunk of middle colic, middle colic and ileocolic, ileocolic, right branch of middle colic and trunk of middle colic. So you have both same options. I think there has been a mistake, so this would have been actually left branch. Irrespective, the answer over here would be this. It is ileocolic, right branch of your middle colic and your trunk of middle colic. This would be the answer. Right. So now let's go to the discussion of your carcinoma of transverse proximal colon and your carcinoma colon in general, and understand few other points that are very important for your exams. So the colorectal carcinoma, they mostly develop from your adenomatous polyp. Now this is a very important sequence, which is your adenocarcinoma sequence. So let me zoom it for you guys. So you have your following mutation. First is the 5q loss, 5q mutation or loss of FAP, which occurs and leads to the hyperproliferative epithelium. Now at the time of early adenoma, you have your DNA methylation. Now from early adenoma to intermediate adenoma, you have a 12p mutation or a KRAS mutation. Then from intermediate adenoma to late adenoma, you have your 18q loss, right? And then you have your late adenoma to carcinoma, which is a 17p loss of p53. Now this is your marker of invasion, and then your other alteration actually leads to metastasis. So one of the most frequently asked question from here is your marker of invasion, which is your 17p or loss of p53. Now regarding your evidence for adenocarcinoma sequence, the distribution of adenomas is similar to that of cancer, around which is 70% left sided. So large adenomas are more likely to be dysplastic than your small adenomas. The majority of early cancers have adjacent adenomatous tissue. Adenomas are usually found in 1/3 of the specimens resected for your colorectal cancer, and incidence of colorectal decreases with the screening program that involves colonoscopy and polypectomy. Now why I have given this important table from Bailey and Love? There are all high chances that they ask a true and false statement from this particular section. Now regarding your distribution, so this is your distribution of colorectal cancer, again an image taken from your Bailey and Love. So you have maximum at your rectum, which is followed by your 21% at your sigmoid colon. Right, now as we had read in our option, right sided colonic carcinoma and left sided colonic carcinoma have different presentation. So your right sided colonic carcinoma would usually present with right lower quadrant abdominal pain, abdominal mass, melena and diarrhea, whereas your left sided colonic carcinoma will present with alteration of bowel habit, passage of blood mucus with stool, and left sided abdominal pain and mass and acute or chronic obstruction. The spread is usually direct lymphatic, or it could be hematogenous, which is liver via portal vein, much more common than your lung. Now regarding your staging, the first important question that is asked is regarding your Duke. Duke staging is used for your colorectal carcinoma. Now regarding your stage A, B, C, A is invasion but does not breach the muscularis propria, B is muscularis propria breached, and C is your lymph node metastasis. Right. Now the next important point is regarding your T&M classification. So you have your T stage, which is T1, tumor invading into the submucosa, T2, tumor invading into the muscularis propria, T3, tumor invading into the non-peritonialized pericolic tissue or subserosa, T4A, where the tumor breaches visceral peritoneum, and T4B, where the tumor directly invades other organ or structure. Now regarding the nodal stage, you have N1, which is 1 to 3 nodes involved, N2 4 or more involves, N2A being your 4 to 6 regional lymph nodes, and N2B being your 7 or more regional lymph nodes. Now regarding your mets, M0 would be no mets and M1 would be presence of metastasis. Now M1 is confined to one organ, M1B is confined to more than one organ, whereas M1C is your metastasis to peritoneum. Now this would be actually your most important question that can be framed. What is M1C? M1C is to your peritoneum. Now the screening, the ideal age is of 50 years. Investigation of choice is your colonoscopy, pre-op preparation. So as per the new ERAS protocol, you do not need any more mechanical bowel preparation. Now the key elements of your ERAS program would include your pre-admission counseling, pre-operative carbohydrate loading, avoidance of pre-operative dehydration, then short acting anesthetic drugs, early laparoscopic surgery, short transverse incisions, avoidance of perioperative fluid or salt overload, avoidance of opiate analgesia, maintenance and perioperative temperature, prevention of your post-operative nausea and vomiting, early mobilization, early introduction of oral fluids, early removal of urinary catheters, and continual audit of outcome. So why is this table important? Because you might just get one question from here: which of the following is an element of ERAS, which of the following is not an element of ERAS. And this is a very hot shot topic, so you guys should be prepared to face this question. Right. Now the next important point is regarding the surgery. So if you look over here, now this is the cecum and the ascending colon surgery. So you can see over here, so these diagrams are actually representing you the question that was asked in the form of MCQ regarding which of the vessels were ligated. So if you read out what is given in Bailey and Love, this is a schematic showing a right hemicolectomy, basic base plane of dissection for a complete mesocolic, ICA, ileocolic artery, MCA, RCA and SMA and superior mesenteric artery. So if you look over here for a right hemicolectomy, ileocolic artery and the right colic artery are ligated. Then you have the schematic presentation for your left hemicolectomy, where you have your descending colon and your sigmoid colon, which is usually done for sigmoid and your descending colon. Then you have your extended right hemicolectomy, which is usually done for your cancer of transverse colon and your splenic flexure. So we need to remember the vessels that are ligated, that is your middle colic, ileocolic and the right colic. Now regarding your adjuvant CT, where you have your Duke C or stage 3, where we use your fluoropyrimidine agents and your oxaliplatin. So this were your few important points with respect to your colon carcinoma. Now in colon, I would also discuss one important small topic, which is a hypertension MCQ, because a lot of previous sessions have asked questions on diverticular disease, so which is a hollow outpouching of your GI tract. In acquired, there is no muscularis. It is usually associated with your western diet, most common in your left colon. Then there is a classification. I would want you all to remember the Hinchey's classification. So there have been some modification, but in order to simplify, I put this: 1 is your pericolic abscess, 2 is your pelvic abscess, 3 is your purulent peritonitis, and 4 is your fecal peritonitis. Then you have your Hartmann procedure, which is safest in your emergency setting, and then you have your primary anastomosis in your selected patients and elective resection for recurrent attacks and complications, right? So this is all about your colon, and apart from this we shall also discuss one more topic which I just remember right now, is regarding your polyps, right? So let's take a look at the polyps. So these are any protrusion of your mucosa. So this forms your first question. Now regarding the classification, it could be either inflammatory, hamartomous, serrated, adenoma, and malignant polyp. Now regarding a metaplastic polyp, it is benign. Few subtypes may have malignant potential associated with your KRAS and BRAF mutation. Now then your adenomatous polyp, it is the most common polyp with the malignant potential. Risk of malignancy is on the basis of histology, morphology, and size. Now the highest risk is seen in your villus adenoma. So this is your polyp follow-up protocol given in your Bailey and Love. So if it is a colorectal cancer, then you obviously do a colonoscopy at 1 year. Now if it is more than 2 cm non-pedunculate colorectal polyp with complete excision, then you site check at the 2-6 months, and then after a further of 12 months if it is not there. Now if so, then you go for one-off colonoscopy at 3 years. In case of high risk findings, what you do, a one-off colonoscopy at 3 years, and if no, then you participate in the bowel cancer screening when invited, right? So the question that can be formed is, in case of a colorectal cancer, colonoscopy at interval of 1 year. In case of high risk finding, at the interval of 3 years. This is the most common questions that can be anticipated from this section. Now you have here this British Society of Gastroenterology identified patients at high risk need for colonoscopy, that is 2 or more malignant pre-malignant polyp, including at least one advanced colorectal polyp, which is serrated polyp more than 1, any grade of dysplasia, and adenoma more than 1 cm containing high grade dysplasia, right? Then another important thing is Haggard classification. Remember, Haggard classification is used for the polyp. So if you look over here, you have your pedunculated adenoma, right? So for the first one, you remember that level 1. So level 1 is up till the invasion of the head. Then you have your level 2, which is invading the neck of the pedunculated polyp, and then you have your level 3, which is invading the stalk, and level 4, which is invading the base. In case of a sessile adenoma, all lesions are your level 4. So in short, what you need to, in a nutshell, that you need to remember that all sessile adenomas are actually your level 4, whereas your peduncle adenomas, level 1 is up till the head, level 2 is neck, level 3 is stalk, and level 4 is going up till the base. Now this was regarding the Haggart's classification, which is used for your colorectal polyps, right? So now let's move on to the next question. So in this we have a patient underwent appendectomy. There is profuse bleeding, ligation of which arteries needed. So this is a basically surgical anatomic correlation. You need to remember the blood supply to the appendix. If you know that, you will be able to answer this question, and the answer is straightforward and simple over here, which is your ileocolic, right? Your next is again on the basis of anatomical surgical correlation, that is a surgeon performs an appendectomy with a gridiron, that is mass splintic incision. I think there is an error over here. So basically over here, this is your muscle splitting incision, right? So the question is asking over here, which of the following muscles are cut? External oblique, internal oblique, transverse abdominis, and rectus abdominis. So the muscles which are usually cut are your external oblique, internal oblique, and transverse abdominis. Rectus abdominis is not cut. So your answer over here would have been your 1, 2, and 3. So this were your few important surgical questions that are that were related to your appendectomy. Now I would want to discuss some important points regarding your appendix surgery, specifically post surgery pathology, where you find out it to be an appendiceal tumor or an appendiceal carcinoid. So what happens if you have a tumor detected at the operation? Now the first thing, if the size of the tumor is more than 2 centimeter. If the answer is yes, then you proceed for a right hemicolectomy. If the answer is no, then you check for is the base involved. If the answer to is yes, then you again proceed for a right hemicolectomy. Now if the answer is no, then you check if a perforation is present or not. Now if the perforation is not present, then a simple appendectomy would be enough. Whereas if a perforation is present, then you check for mucin spillage or a mucinous ascites. If the answer is yes, then you would need an appendectomy, a peritoneal lavage along with a cytoreductive surgery or a HIPEC. Whereas if there is no spillage, then an appendectomy would suffice. Now what happens if a tumor is found after appendectomy? So if it is an adenocarcinoma, you would proceed for a right hemicolectomy. Now if it is a carcinoid and a tumor is less than 1 centimeter, you can actually just observe the tumor. If it is more than 2 centimeter, you would need to perform a right hemicolectomy. Now if the tumor has a size of between 1 to 2 centimeter, then you check for your lymphovascular invasion. Now if there is no lymphovascular invasion, you go for an observation, and if lymphovascular invasion is present, you will go for a right hemicolectomy. So whenever you get a tumor found after appendectomy, you need to follow this algorithm, and if you find at the time of operation, you need to follow the first one. Now apart from this, another clinical based scenario that is often asked from your appendix is regarding your appendicular lump. So the main management for your appendicular lump is your Oshner-Sharon regimen. Now for pain, you have your NSAIDs, vomiting you use antiemetics, IV fluids to maintain electrolyte balance, antibiotic which includes your second and third generation cephalosporins and your metronidazole, and then you have your monitoring which is symptomatic, which would include your pain and vomiting, and the objective monitoring which includes your pulse, blood pressure, respiration, temperature, 4-hourly measurement, tenderness in the right iliac fossa and the progress of the lump. And you need to do an interval appendectomy after around 6 to 8 weeks. The criteria to stop the conservative treatment for your treatment of appendix mass includes your rising pulse rate, increasing size of mass and increasing pain throughout the abdomen. So this were your few important questions that can be framed from your appendix. Since they have already asked the most important questions from your appendix surgery, the next potential question would be what happens if you detect a tumor at the operation, or what happens you detect the tumor after you have operated and the HP reports come. Now let's move on to the next question. So this is again a straightforward question. Patient present with microcytic anemia post bowel resection which is not involved. Options are stomach, jejunum, ileum and duodenum. So what would be the answer? The answer will be duodenum. Why duodenum? So there is no confusion between stomach and ileum, because ileum you have your terminal ileum where you have your maximum absorption of vitamin B12, right? You are dealing with the microcytic anemia, and stomach you have your intrinsic factor being released. Now why we are saying duodenum? Because duodenum is a place where you have your maximum iron absorption, and iron deficiency anemia is going to be a microcytic anemia. Hence your answer would be duodenum, because the question is asking your macrocytic anemia, right? So there has been confusion between duodenum and jejunum. So this question has also been discussed by our game faculty in the INI recall series which was asked last year, and where we have the quotes from the Harrison. So I would ask you all to stick to the answer of duodenum, right? So this is a combined answer from the surgery and the medicine faculty from the team game. Okay, so now let's move on to the next question. So we have a 25-year-old who goes to undergo splenectomy. So which of the following will not be used in your post-operative period? Now go splenectomy. So we are basically trying to deal over here with your opportunistic post-splenectomy infection. So what are the vaccines which are given in your post-operative period? Haemophilus influenza vaccine, true. Pneumococcal, meningococcal, yes. We do not give a typhoid vaccine, right? So this is a very important question that is often asked. right? Another important concept from here is when are these vaccines given. So please remember, in case of elective surgery, you usually give it 2 weeks before or usually after surgery, that is specifically in your emergency. After surgery, recovery is done, but make sure you give it before the discharge from the hospital, right? So with respect to splenectomy, OPSI is a very important topic, so please remember this is repeatedly asked in your INI exam, so you need to know regarding your vaccines that are given in your OPSI, right? Now let's move down to the next question. So we have this question: number of lymph nodes to be removed in each cancer surgery, A breast, B GB, colon, stomach. You have your options as 10, 6, 12, 16. So this is again a very straightforward question. In case of breast, we have your 10 lymph nodes, minimum 10 lymph nodes to be removed. In case of gallbladder, we have minimum of 6. In colon, we have 12, and stomach we have 16. So if you look at the options, you have your option A, which is the correct match. So please, if you see the trends in INI, in one question they're asking you a conglomerate knowledge of a lot of various concepts and factuals in one liner, right? So this one question, it's itself basically your 4 one-liners questions, so you need to be prepared for such sort of questions and make no mistake in them. Now moving down to the next question. So you are ICU in charge, patient is admitted with necrotizing pancreatitis with BP 90/50 on pressor supports. So what will be the management, right? So if you look at necrotizing pancreatitis, this is quite an unstable patient which is requiring pressure supports, right? You won't do an surgery, you won't do MRI, you won't do aspirations. You will best keep the patient currently on IV antibiotics right now and then move on to the next step, right? So let's take a look at the important points of your necrotizing pancreatitis. Now pancreatic necrosis, it refers to a diffuse or focal area of the non-viable parenchyma. Now this is identified by the absence of your parenchymal enhancement of CT with IV contrast. So this is one of the most important one-liners which you will find in your clinical scenarios to be given, where they will write that on CT you find an absence of parenchymal enhancement with IV contrast. These are associated with lysis of peripancreatic fat. Infected necrosis are associated with a mortality rate of as high as of 50%, right? Now if your necrotic material is sterile, then it is not drained. If there are signs of cespin, aspiration of fluid with fine needle under CT guidance to be determined if infected, and drainage of infected fluid is carried out, right? Now this is your image of your infected pancreatic necrosis. Now regarding your drainage, your internal drainage into the stomach under your endoscopic ultrasound guidance, if it fails, then you go for your percutaneous drainage. Aspirate should be sent for microbiological assessment and the antibiotic as per culture sensitivity. Now if it still worsens, right, then you go for your pancreatic necrosectomy, which is head involved. You go for a midline approach, and a body or tail, which is your retroperitoneal approach. And feeding jejunostomy is used an adjunct, and if it is a gallstone pancreatitis, then you would be needing a cholecystectomy, right? And the post complications of your necrosectomy, if further necrotic tissue may form, you need a close continuous lavage and a tube drain are left in and raw area are flushed. So I again revise this protocol of your pancreatic necrosis. So if you see necrotic material, if it is sterile, then it is not drained. If there is sign of sepsis, then you go for an aspiration of fluid with fine needle under CT guidance and USG to determine if infected. Now then drainage of infected fluid is carried out. Now internal drainage into the stomach under endoscopic ultrasound guidance, if fails, then your percutaneous drainage. Aspirate should be sent for microbiological assessment and antibiotic as per your culture sensitivity. If still worsens, then you would be requiring a pancreatic necrosectomy. Now if the head is involved, you go for a midline approach, and if it is body or tail, then you go for a retroperitoneal approach. And feeding jejunostomy would be used as an adjunct, and in case of gallstone pancreatitis, you would be requiring a cholecystectomy. So now the closed drainage, it is basically the incision is closed and the cavity is packed with gauge filled Penrose drain and closed suction. Open packing, it is incisional left open cavity packed with intention of returning to OR at regular interval and repacking until your clear granulation cavity is formed. Then you have your closure and relaptotomy, which is every 48 to 72 hours. Now, important point regarding the pancreatic abscess. It is a circumscribed intra-abdominal collection in the proximity of the pancreas. Right? It is usually your WOC or ANC. So, what is your ANC or WOC? Right. So, in order to understand this, let's go a little above first to understand the important concepts regarding your revised Atlanta classification. So, interstitial edematous pancreatitis. This is acute inflammation of your pancreatic parenchyma and peripancreatic tissues without your tissue necrosis. Then your necrotizing pancreatitis is your inflammation associated with your pancreatic parenchymal necrosis and or peripancreatic necrosis. Then your acute peripancreatic fluid collection is your peripancreatic fluid associated with your interstitial edematous pancreatitis with no associated peripancreatic necrosis, which applies to areas of peripancreatic fluid seen in the first 3 weeks after onset of interstitial edematous pancreatitis without the features of a pseudocyst. Then you have a pancreatic pseudocyst, which is an encapsulated collection of fluid with a well-defined inflammatory wall outside the pancreas with minimal or no necrosis, which usually occur more than 4 weeks after onset of interstitial edematous pancreatitis. Now your acute necrotizing collection, that is a collection containing variable amount of fluid and necrosis associated with your necrotizing pancreatitis, and this necrosis can involve your pancreatic parenchyma and or peripancreatic tissues. Then you have your Waldorf necrosis, which is a mature encapsulated collection of pancreatic and peripancreatic necrosis that has developed well defined inflammatory wall, usually occurring after 4 weeks, right, and after onset of your necrotizing pancreatitis, right. So ANC and WON, that was your Atlanta classification. So if acute necrotizing collection or Waldorf collection, that becomes infected, that is your pancreatic abscess. Now pancreatic ascites is usually associated with the pancreatic duct disruption, and paracentesis would reveal what? A high turbid fluid with the high amylase level, and the treatment would be your adequate drainage with your whiteboard drains. Now this is another important topic, which is the pancreatic pseudocyst. So you would be getting a clinical question where you will be having an attack of pancreatitis, and usually after 4 weeks with the CT scan image given, right. So this is usually a pancreatic pseudocyst, and this is your stomach which is being pushed upwards, right. So what are the fluid characteristics of your pancreatic pseudocyst? Which is low CE level, inflammatory cells and high amylase level. Now regarding the management of your pseudocyst, if it is more than 6 cm infected, it would requiring a percutaneous drainage. If it is symptomatic or enlarging, it would requiring your MRCP or ERCP. So if it is communication, endoscopic transpapillary drainage stricture, you would require an endoscopic internal drainage with followed by a surgical internal drainage plus resection. Your surgery would be cystogastristomy or a cystojejunostomy. Now if it is asymptomatic and not enlarging, you can actually just observe the patient, right. Now the complications of a pancreatic pseudocyst would include your abscess, sepsis, GI bleeding, internal fistula, peritonitis, bowel obstruction, hemorrhage into the cyst, and your hemoperitoneum. So these were your few important points with respect to your necrotizing pancreatitis, the management plan. So just try to stick to this management plan, and what fits into your criteria, try to mark that answer. Then your pseudocyst, and with pseudocyst I would also want to discuss over here with the cystic neoplasm of the pancreas, which is a very important topic when it comes down to the differentials along with the pseudocyst of pancreas. So I have this table over here for you for the characteristics of common cystic neoplasm of the pancreas. So you have your serous cyst, mucinous cyst, intraductal papillary mucinous cyst neoplasm. So what I'll do is I basically mainly focus on your cystic fluid contents, as that is one of the most commonly asked questions. Whereas you will just note it down from the screen while you will be seeing this video. Now, so with respect to the serous cyst, you have your low viscosity, low CA, low amylase, cuboidal cells and glycone-rich cytoplasm. In case of your mucinous cyst, you have your high viscosity, high CA, low amylase, columnar cell and KRAS mutation that may be present. In case of your intraductal papillary mucinous neoplasm, you have your high viscosity, high CA and high amylase. Now, when we look at the gross analysis, you can say cystic fluid with a low viscosity or a low CE. You check amylase. If it is low, it is serous, and if it is high, it is pseudocyst. In case of a high viscosity and high CA, if you check amylase and it is low, it is mucinous cyst, and if it is high, it is your intraductal papillary mucinous neoplasm. So I would actually want you all to remember this small shortcut, which would be able to solve most of the questions of the cystic neoplasm of the pancreas. And you can just take a look at the imaging features. I'll rather run through them. So serous cyst, it is microscopic and honeycomb pattern. In case of your mucinous cyst, they are usually macrocystic, peripheral calcifications, and there are no communication with the duct. And in case of your intraductal papillary, you have macrocytic and your ductal involvement. So another way is microcytic, macrocytic. Microcytic is serous cyst, macrocytic is you check duct involvement, yes, intraductal, no, it is mucinous cyst neoplasm, right? So this was a one sideline topic which I wanted to take you from your pancreas to your pancreatic necrosis to the pancreatic pseudocyst to the cystic neoplasms, right? So now let's move down to the next question. So the next question is a very straightforward question, which is the most common site of ileocolic TB. So the answer would be your IC junction. So a few important points regarding your tuberculosis. So this is increasingly being seen in non-endemic area, mostly among the immigrants from your endemic areas. Then there are two recognized types, which includes your ulcerative and hyperplastic type. Your ulcerative type occurs when the virulence of organism is greater than the host difference and form structure. The opposite occurs in a hyperplastic type and presents with a mass. Now, small bowel strictures are common in your ulcerative type, presenting with obstructive symptoms, while your hyperplastic type mainly affects your ileocecal area and presents with a right iliac fossa mass and obstructive symptom. Now, in peritoneal tuberculosis, you have your parietal and visceral peritoneum studded with tubercles, whereas your localized areas of ascites depicts your peritoneal involvement. Right. Next, your encasement of bowel in a fibrotic sac. The plastic type of your peritoneal tuberculosis presents with obstruction, and the lungs and the other organ, particularly the genitourinary system, may be involved simultaneously. So these are your few important points with respect to your intestinal tuberculosis, right? Now, next question, maximum malnutrition is caused by which of the following? So the basic funda to remember, the more proximal it is, the more malnutrition it would be causing. So your answer over here would have been your duodenal fistula, right? Now the next question, a 50-year-old alcoholic patient presents with a history of your waxing and waning jaundice for past 2 months. Now his CT examination reveals your dilation of common bile duct and your pancreatic duct. Now what is your most probable diagnosis in this patient, right? So this is a classical case which you have come across in your final year exams of your obstructive jaundice. So waxing and waning jaundice, so what are they trying to refer to? They are trying to refer to you the periampullary carcinoma, right? So the answer over here would have been periampullary carcinoma. And what would have been the investigation of choice? Your investigation of choice would have been your triphasic seed CT scan of your whole abdomen, right? Now coming down to the next question, this following procedure is performed for the management of which cancer? So if you look over here, they are trying to depict you regarding the Whipple's procedure. Now you would be doing a Whipple's procedure for which of the following? You would be doing it for a distal cholangiocarcinoma. Now having said this regarding your distal cholangiocarcinoma and the Whipple's procedure, pancreatic carcinoma is a important topic which may be asked in your upcoming recent INI exam. So let's take a look at the few of the important points of your pancreatic carcinoma. Now first, regarding the risk factors. So the risk factors includes your demographic factors, which are your age, male gender, black ethnicity, then your cigarette smoking, and the genetic factors, which include your family history, Lynch syndrome, ataxia telangiectasia, Purgover syndrome, hereditary pancreatitis, which has around 50 to 70-fold increase. Then you have your familial breast ovarian cancer, familial atypic multiple mole melanoma, diabetes mellitus, obesity. Now regarding your clinical features, if it is a right-sided pancreatic carcinoma, it will present to you with jaundice from your biliary obstruction, pruritus, epigastric pain radiating to back. Now if it is a left-sided, then the pain would be your most common presenting feature and jaundice would be rare, where if the non-specific features would include your anorexia, asthenia and loss of appetite, and metastatic disease would include your Virchow node, systematic Joseph nodule and Blummer shelf nodule. Now the investigation, as I said, it would be a triphasic CCT pancreatic protocol. Without contrast phase, you would be looking at your calcification and edema. At your early arterial phase, which you will usually done at 10 to 20 seconds, you will be looking at the adenocarcinoma, which usually has a poor uptake, whereas neuroendocrine will be tumors will be having a good uptake. Now in your late arterial phase, which is usually at 40 to 60 seconds, you have your enhancement of tumor in relation to gland and its relation with your SMA and SMV. In case of venous phase, you have rest of your parenchyma, splenic vein for any thrombus and portal vein for any thrombus. Now another important entity is your borderline resectable pancreatic carcinoma. Now what is your definition? The venous is your SMV or portal vein involvement, distortion or narrowing, but they have a suitable vein proximal and distal so that a reconstruction can be performed. In case of your arterial, you have your head, which is the abutment of SMA less than 180 degree and abutment of HA but no extension into the celiac artery. In case of body or tail, it is less than 180 degree involvement of your celiac axis. Now the treatment would include for your resectable diagnostic laparoscopy followed by your Whipple's procedure. Please remember, regarding a Whipple's procedure, your three important anastomosis that you do are pancreatic jejunostomy, hepatico-jejunostomy and gastrojejunostomy. Right. Then your endoscopic USG biopsy, if it is positive, then you go for a ERCP or a biliary drainage followed by your NACT, gemcitabine plus minus carboplatin, followed by your MDCT to check for the resectability. If it is resectable, you go for surgery, and if it is unresectable, you go for chemotherapy. Now you may also perform direct surgery where you have the option of your vein reconstruction. Now in case of a palliation, this is a beautiful table taken from your Bailey and Love. You relieve jaundice and treat biliary sepsis by surgical bypass. Now triple bypass would include your hepatico-jejunostomy, gastrojejunostomy and jejunostomy. The stent is placed at your ERCP or percutaneous transhepatic cholangiography. Then you improve gastric emptying by your duodenal stent or surgical gastroenterostomy. Pain relief by your transthoracic splanchectomy, plexus block and stepwise escalation of analgesia, and symptomatic relief and quality of life by encouraging normal activities, enzyme replacement for steatohormone, pre-diabetes and considering chemotherapy. Right. So this were your few important points regarding your palliation of pancreatic cancer. Now let's move down to the next question. So we have this question on your inflammatory bowel disease. So all of the following statements are true for your inflammatory bowel disease except Crohn's disease has kept lesions. Yes, it is a true statement. Childhood IBD is genetic. Okay, it is a true statement. Crohn's disease is mucosal and ulcerative colitis is transmural. Again, this is a true statement. Crohn's is fully curable. This is a false statement. So your answer would have been A, option 1, 2 and 3. Now let's take a look at your important points from your inflammatory bowel disease. So firstly, regarding Crohn's disease, you need to remember that it can occur anywhere in the GI tract, which includes from mouth to anus, but typically occurring at your distal ileum, anal canal and large bowel. In case of your ulcerative colitis, it is usually confined to your large intestine. Now the most important point that I need to remember in your Crohn's colitis versus ulcerative colitis is this particular table. Now in case of Crohn's colitis, on the basis of your symptom and sign, diarrhea is common actually in both. Rectal bleeding is almost always present in your ulcerative colitis. A palpable abdominal pain, first is moderate to severe in case of Crohn's and mild to moderate in case of ulcerative colitis, and a palpable mass is present at times in your Crohn's colitis, whereas it is usually not present in your ulcerative colitis. Now, the anal complaints are frequent in your Crohn's and infrequent in your ulcerative colitis. Now, on the basis of your radiological findings, ileal disease is common in your Crohn's and rare in your ulcerative colitis, and you have your backwash ileitis, which is a feature of ulcerative colitis. Now, nodularity is present in your ulcerative colitis. Now, again, distribution, they have skip lesions in Crohn's, whereas in rectum it extends proximally and continuously. Ulcers are collar button ulcers classically described in your ulcerative colitis, and linear cobblestone fissures in your Crohn's colitis. Now, toxic dilation is rare in case of Crohn's, whereas it is uncommon in ulcerative colitis. So, what does this basically statement say? If you're asked in which your toxic dilation is much more common, it would be basically ulcerative colitis more than Crohn's colitis. Now, regarding your proctoscopic findings, you have your anal fissure, fistula abscess much more common in your Crohn's compared to your ulcerative. Then you have your rectal sparing, which is much more common in your Crohn's, definitely, because ulcerative colitis it is rare that you have a rectal sparing because the rectum is usually involved. Then you have your granular mucosa, which is present in your ulcerative colitis, and your ulceration, which is your linear deep scattered in case of Crohn and superficial in case of ulcerative colitis. Now, these are your few photographic images of your Crohn's disease, and this is again a mucosal biopsy in your ulcerative colitis. Now, regarding your severity classification of colitis, which is given by Trewald-Witts. So, you have your mild disease, which is your less than 4 stools daily, bleeding may be present or absent, no systemic signs of toxicity. Moderate disease having more than 4 stools daily with few signs of systemic illness, mild anemia, abdominal pain, raised ESR and CRP. Then you have your severe disease, which is more than 6 bloody stools, systemic illness and hypoalbuminemia. Then a fulminant disease is your more than 10 bowel movements with systemic illness and toxic megacolon. Now, there is a scoring system for your assessment of your ulcerative colitis activity. So, what are your things that are included? You just need to remember that at least stool frequency, rectal bleeding, disease activity on flexible sigmoidoscopy, and your global assessment. So, at least remember this scoring assessment of your ulcerative colitis activity. Now, regarding your ulcerative colitis and your colorectal cancer, the risk of cancer increases with the duration of the disease. So, you need to know this point. Then the risk of colorectal cancer is around 10 to 20 times that of general population. Lesion may be multifocal. Patients with your pancreatitis, that is defined as the presence of inflammation proximal to the splenic flexure. Then you have your endoscopic screening program to detect the dysplasia, which are the predictor of your cancer risk. Now, the factors increasing the risk are disease duration. What duration? More than 10 years, patients with pancreatitis, onset before 15 years old, unremitting disease and poor compliance to treatment. Another important point that is asked from your inflammatory bowel disease is regarding your extraintestinal manifestation. So, you have your arthritis, which is asymmetrical large joint polyarthropathy, sacroiliitis, ankylosing spondylitis, sclerosing cholangitis, erythema nodosum, pyoderma, gangreosum. Now, what are your indications of surgery in ulcerative colitis? So, the various indications include your severe or fulminating disease failing to respond to medical therapy, chronic disease with anemia, frequent stool urgency or tenesmus, steroid dependent disease where remission cannot be maintained without substantial dose of steroid with harmful side effects, intolerance or side effects of medical therapy required to control the disease, example steroid psychosis and azathioprine induced pancreatitis. Then you have your growth retardation in children or adolescents, neoplastic change, patient who have severe dysplasia or carcinoma, associated sclerosing cholangitis, extraintestinal manifestation, and your rarely severe hemorrhage or stenosis causing obstruction. The medical management would include your anti-inflammatory, corticosteroids, steroid sparing, monoclonal antibody in form of infliximab, adalimumab and vedolizumab. The surgical management, in case of emergency, it would include a subtotal colectomy and an ileostomy plus minus mucous fistula, which is usually taken a decision on the basis of your intraoperative findings. And your elective surgeries would include your subtotal colectomy and ileostomy, proctocolectomy, permanent endileostomy, restorative proctocolectomy with ileoanal pouch anastomosis, subtotal colectomy and ileorectal anastomosis, and segmental colectomy. Right, so these are your few important points via your inflammatory bowel disease. I know I'm rushing through them because it is meant for your revision, so I'm just trying to emphasize what are the important points that you should know, and you just take a glance and look at it and make sure that you are updated with it. Right, now regarding your Crohn's disease, now this is another hot topic, this which is being frequently asked by your examiners regarding your Montrell classification. So the first question itself, Montrell classification is for Crohn's disease. Second, Montrell classification, what are the parameters, includes age at diagnosis, behavior and location. The third would be, they would give you a clinical scenario which is quite rare at your level, but still be prepared. A 17-year-old presenting with a stricturing colonic Crohn's disease, please tell the Montrell classification. So 17A2, stricturing B2, colonic L2, it would be A2, B2, L2. So you might be getting a lot of variance as per this. So please remember, A1 is less than 16, A2 is 17 to 40, A3 is more than 40, B1 is non-stricturing, B2 is stricturing, B3 is penetrating, and P stands for perianal disease. And your location would be L1 ileal, L2 colonic, L3 ileocolonic, L4 isolated upper GI tract. Right, now the Crohn's disease activity index, which includes your number of liquid or soft stools, general well-being, abdominal pain, use of diphenoxylate or loperamide, abdominal mass, hematocrit and body weight. Now regarding your extraintestinal manifestation, so the important question that is asked from this is what are related to your disease activity, which includes erythema nodosum, pyoderma gangrenosum, arthritis, eye complications, aphthous ulcer and amyloidosis. Now what are unrelated to disease activity includes gallstone, renal calculus, primary sclerosing cholangitis, chronic active hepatitis and sacroiliitis. Alright, so we end this topic of discussion on your IBD on the basis of your surgery. So the indications are your recurrent or intestinal obstruction, persistent or massive active bleeding, free perforation of bowel, failure of medical therapy, steroid dependent disease, intestinal fistula, perianal disease or the malignant chain. So these are your indication. And what are your surgical options? Surgical options include ileocecal resection, segmental resection, colectomy and ileorectal anastomosis, temporary loop ileostomy, subtotal colectomy and ileostomy, protectomy, proctocolectomy and structuroplasty. So what is the importance of the surgical option? So you might actually get a series of this, which of the following are used in your surgery for Crohn's disease. So you might be having such options and you might need to select them. Right. So now let's move on to the next question, which would be the last question for this session on the abdomen, and the question is on hernia. Right. So we have a very straightforward question from the hernia surgery. Patient underwent loss of sensation over the root of penis. So again you have your anatomy surgical correlation. Following laparoscopic hernia surgery, which of the following nerves would be you implicate? Iliohypogastric, ilioinguinal, genitofemoral, medial cutaneous nerve of thigh. So the answer over here is a straightforward question answer, which is your ilioinguinal nerve. Now let's look at some of the important points of discussion from your hernia. Right, I'll try to discuss this a little in detail, but I'll again run through it because hernia is a very important topic, a basic topic, a case which each one of the MBBS students must be knowing. So you can expect one question from even the basics of the hernia. So let's take a look at the important concepts of your hernia discussion. So a few important points on inguinal hernia, much more common in male. And now regarding your anatomy of inguinal canal, this is a very important topic. So the deep inguinal ring, this is a defect in your transversalis fascia. This usually lies deep to the abdominal muscle, midway between your ASIS, which is the anterior superior iliac spine, and pubic tubercle. That is 2 to 3 centimeter above and marginally lateral to your femoral artery pulsation. So if you look at this, these are your close relationship of your direct inguinal, indirect inguinal hernia, and femoral hernia. Please remember inferior epigastric vessel, which are medial to the deep inguinal ring and passes from your iliacus to your rectus abdominis. Now again, this are your anatomy of your important area. So if you look over here, this is shown your area of your direct hernia and area of your indirect hernia. So if you look over here, this is your inferior epigastric vessel. So medially is your direct hernia, laterally is your indirect hernia, right? Now what is the roof formed by? Roof is formed by the conjoint tendon. Conjoint tendon again is another question, fusion of your transversus muscle and your internal oblique muscle. Then you have your posterior wall, which is your transversalis fascia, anterior wall, which is by your external oblique aponeurosis, and floor, which is by your free inferior edge of your external oblique aponeurosis, which is rolled inwards to thicken to become your inguinal ligament. Now regarding the contents, you have in male the testicular artery, veins, lymphatics, vas deferens, all covered in your cremasteric muscles, and in female you have your round ligament, right? Now the types, you have your indirect and direct. Indirect is lateral to the inferior epigastric vessels, medial is your medial to the inferior epigastric vessel. Please remember, this is one of the most important points in order to identify your hernia intraoperatively, right? Now indirect enters through DIR, which is the deep inguinal ring, and direct enters through your Hasselbalch triangle. Now again, this is a very important MCQ. The boundaries, which are laterally by your inferior epigastric artery, medially by the lateral border of rectus abdominis, and inferiorly by your inguinal ligament. So indirect usually occurs young patients and elderly. Unilateral, bilateral is your direct hernia. Direct hernia usually incomplete, and deep ring occlusion test is usually negative. Now where is the deep ring? 1.25 centimeter above the mid inguinal point. What is your mid inguinal point? Point midline between point in the line, midline between the ASIs and the pubic symphysis. Now regarding your classification, I would want all of you to remember your EHS classification, as you can have a clinical scenario formed on the basis of EHS. So you have your P for primary, R for recurrent, L for lateral, M for medial, F for femoral, and defect in the finger size is on the basis of 1.5 centimeter. So an example, a primary indirect inguinal hernia of a 3 centimeter defect would be PL2. Now you have another classifications for hernia, which are your Nihas classification and a Gilbert classification. You might just take a look, but do remember the names as they can be asked. Now regarding your operations for inguinal hernia, you have your herniatomy, which is open suture repair, Bassini shoulders, Desarden, Maloney Don. Then you have your flat mesh repair, which is your Liechtenstein repair, and then you have your laparoscopic repair. So we'll just discuss in nutshell about the repairs. So you have your herniatomy, which is your excise and close the sac, and is usually done in the congenital hernia. Now I won't discuss this Bassini repair, or let's discuss, actually there's no harm in discussing. It is an open suture repair. So what happens over here is the surgeon enters the inguinal canal by opening this anterior wall. An anterior wall is formed by the external oblique aponeurosis. Now the spermatic cord is dissected free. The presence of lateral medial is confirmed. How? By inferior epigastric artery pulsation. Now the sac of lateral hernia is separated from the cord and open, and contents reduced. The sac is then sutured close at its neck, and excessive sac is removed. Now if there is a medial hernia, then sac is inverted and the transversalis fascia is sutured plicated. Now sutures are now placed between the conjoint tendon above and the inguinal ligament below, extending from the pubic tubercle to the deep inguinal ring. Now the posterior wall of the inguinal canal is strengthened. Now the shoulders modification over here is the transversalis fascia is opened by a central incision from the deep inguinal ring to the pubic tubercle. Now closed to create a double breasting, that is two-layered posterior wall. Now external oblique is further closed in a similar fashion. Now disorder, what happens in disorder? You have your EOA, that is your external oblique aponeurosis, 1 to 2 centimeter strip isolated from the main muscle but left attached medially and laterally. Now this is sutured to the conjoint tendon and the inguinal ligament, reinforcing your posterior wall. Now Liechtenstein repair is your tension free simple flat repair, which is your polypropylene mesh repair. So another question that can be asked is regarding actually the mesh that is used. Then it is usually similar to Bassini, that is, but over here after the removal of hernia sac and the closure of medial defect, a mesh is placed in the posterior wall, usually which is 8 into 15 centimeter behind, and slit to wrap around the spermatic cord at the deep inguinal ring. So this is your surgical presentation of your Liechtenstein tension free hernia repair. Now regarding the laparoscopic, this is one of the most common hot topics that is being asked. So what I have done is I've just taken the nutshell regarding the most important points that you guys are supposed to know. So first is the types. There are two types: total extraperitoneal and transabdominal preperitoneal repair. Now in laparoscopic, I would want you to remember two important triangles. One is triangle of doom. So triangle of doom is bounded medially by your vas deferens, laterally by the vessels of your spermatic cord, and inferiorly by the peritoneal reflection. Why doom? Because you have your major vessels, that is your external iliac vessels. Apart from that, you have your femoral nerve and genital branch of your genitofemoral nerve. Now you have another triangle, as you can see over here, which is triangle of pain. Now what are your boundaries of triangle of pain? Now triangle of pain is bounded medially by your gonadal vessels, laterally by your peritoneum, and superiorly by your iliopubic tract. Now the contents include your lateral femoral cutaneous nerve, femoral branch of genitofemoral nerve, and your femoral branch of genitofemoral and your femoral nerve. So if you look over here, this is your triangle of pain and triangle of doom. So please remember the important contents. So you can actually remember as triangle of doom being vessel, external iliac vessel, triangle of pain as your nerve, which is quite commonly asked and actually the most frequently asked section from your laparoscopic hernia surgery. So what are your benefit of your laparoscopic surgery? It is in bilateral hernia repair and recurrence after open. So you have your early complications of hernia surgery, early, which includes your pain, bleeding, hematoma, urinary retention, then your medium, which is seroma, wound infection, and late chronic pain and testicular atrophy. So this was all about in GIT. So I feel I have covered almost all the important topics with respect to your INI exam. If you have any doubt, you may actually mail them down to me at the following email ID. Right, sskmakesingle@gmail.com, or you may mail them at ayushkeshav99@gmail.com. So the key to success is, as we have discussed so many times, it is revision. So keep revising. The main purpose over here of this INI series is not to give you new stuff, it is to re-emphasize the most important topics. So if you, those who have guys who have gone through the previous year question, you might have noticed that most of my questions are actually the previous year questions, and what I have done is that from those topics I have discussed the more important one-liners and the sideline topics which can be further asked. Now as you can see in the screen, a topic on femoral hernia. So let me not skip on that and actually discuss the femoral hernia also. So femoral hernia, important is again the important anatomical part which comes over here is the femoral canal. It is laterally bounded by your femoral vein, anteriorly by the inguinal ligament, posteriorly by your iliopectineal ligament, and medially by the lacunar ligament. Now femoral canal is the place which is exploited by your femoral hernia, much more common in women because female pelvis has a different shape and it is less common than inguinal. Now diagnosis, it is below and lateral to the pubic tubercle, upper leg rather than in the lower abdomen, usually early missed on examination, 50% presents at emergency, and they have a high risk of strangulation. Now the differential includes your inguinal hernia, lymph nodes, saphenous veins, femoral artery aneurysm, psoas abscess, rupture of adductor longus with hematoma. Now there is no specific investigation in your routine cases. Uncertainty, you might need a ultrasonography or a CT scan. Now you need to know the surgery for your femoral hernia. You have your low approach, which is your lock code. You can remember L for L. You have a transverse incision which is made over the hernia. The sac is open and the contents reduced. The sac is also reduced, and the non-absorbable sutures are placed between the inguinal ligament above and the pectinate ligament overlying the pubic bone below. Now a small incision can also be made in the medial lacunar ligament to aid the reduction, but there you find an abnormal obturator artery, right? Abnormal branch of the obturator artery which can bleed, and the femoral vein lateral to the hernia needs to be protected. Then you have an inguinal approach which is known as Lothisen approach. So the important question that can be asked of femoral hernia is regarding the surgery. L for Lockwood, Lothisen, and the third which we will be discussing soon is your McVitie approach. Now the initial incision is similar to your Bassini or Liechtenstein repair. So you have your spermatic cord mobilized, transversalis fascia open and the deep inguinal ring to the pubic tubercle, avoiding the injury to the inferior epigastric vessels. Now this gain entry into the extraperitoneal space. So femoral hernia line immediately below this incision can be reduced by combination of pulling from above and pushing from below. Right, now if necessary, the peritoneum needs to be open to deal with the contents. Once reduced, the neck of hernia sac is closed with the sutures or a mesh plug, protecting the external iliac vein throughout. Alternatively, what you can do is a sheet of flat mesh can be laid over the defect in the extraperitoneal plate. Now the layers are closed as it's done in inguinal hernia, and a mesh may be done to protect the prevention of your future inguinal hernia. Now the high approach is the McAvity approach, which is one of the most important approaches that you need to remember because it is ideal in your emergency operation. Now what happens over here, a paramedian incision is used, which is now to use the Nehas modification, transverse incision just above the inguinal canal centered on the lateral border of the rectus muscle. Now this anterior rectus sheet is incised and the rectus muscle retracted. Now surgeon proceeds deep to the muscle in the preperitoneal space. Femoral hernia is reduced and the sac is allowed for the careful inspection of the hernia content. Now where you have doubt in such dubious cases, what you do is you place the bowel into the peritoneal cavity for 5 minutes and then re-examine. The femoral defect is then closed with sutures or mesh. Now the preperitoneal approach may be extended to gain the access of the bilateral femoral hernia through a single incision, and this is called your Henry technique. So guys, this was all about your session on your GIT, where we have also covered hernia. So if case you have any doubts, as I had shared prior, you guys can share your doubts on your this email ID. You can keep following this Instagram channel of mine, which is your surgery buddy, where we are posting each day specific pattern. So on Monday we have your MCQ days, and then we have one-liners days, important tables day. So until you go for your exam in this month of April, you would be having some important one-liners, tables, clinics, image based questions, images from your Bailey and Love. You can also follow the channel AK Surgery. At the same time, I'll be posting some important high yield videos for your INI exam, as I promised you in the session, specifically on the signs and some more important topics which I could not cover in this class, but then those are not the most important. Please do remember the most important points I think I have covered in this class. In case I have missed or I want to cover something more like signs and all, I shall be uploading this in your Game PG app YouTube channel. So please do follow Game PG app. Keep revising, keep learning. If you have any doubts, please do remember Team Game is always with you. So I'll take an off from this session. So now in next session we'll be discussing your endocrine, urology, and few important questions that have come from say a plastic surgery and here and there topics, right? But our main session would be focused primarily on your endocrine and your urology part. So thank you. Hi friends, so welcome to the day 3 discussion of the INI surgery series. So today we'll be discussing in this session important previous year questions and core topics from the section of endocrine surgery, urology, and some miscellaneous topics. So we'll start a discussion with the endocrine section, where we'll be discussing in details regarding your breast specifically, as these chapters have been retained by the faculties from AIM. So we can expect actually a few questions coming from the breast section this time specifically. So let's begin with our first question. Which of the following is not used to diagnose breast cancer? Now for diagnosis of breast cancer, we all do a triple assessment. Now what are the parts of your triple assessment? Now triple assessment includes your first part being your history and clinical examination. Then we have your radiological assessment, which is usually in form of your USG and mammography, and third is your pathological examination, which is in form of your core biopsy, right? So this radiology is usually USG and mammography. So over here your answer would have been PET CT, but yes, there is a role of PET CT in your breast cancer, which we shall discuss subsequently. Now before going into the detailed understanding of this triple assessment, let's again discuss one more question, which is your question number 52, that is BI-RADS 3. So what is your BI-RADS 3? It is probably benign. So there could be a clinical scenario formed at this, where they give you a clinical case history of a woman presenting to you with a breast lump. You do a core biopsy and you find to have a BI-RADS 3. So what is BI-RADS 3 suggestive of, and what would be your management plan? So now let's discuss in some details regarding some of the important points regarding your triple assessment of breast cancer. Now in triple assessment, first we'll read about the ultrasonography. So this is your primary imaging in your young woman with intense breast. It distinguishes your solid from your cystic lesion. Now the simple cyst would be requiring a reassurance and follow-up, and the cyst causing pain would be requiring a therapeutic aspiration. Now on ultrasonography, if you find this well circumscribed mobile solid mass in a young woman, it would be suggestive of your fibroadenoma. So this forms another part of the clinical spectrum of the questions. Then if you have a solid mass which is irregular shape or ill-defined margin as specified in this image, it would be suggestive of your carcinoma. So you might be getting a USG image of the lesion and ask for a diagnosis. Then you have your role of USG in the axilla assessment and the percutaneous guided biopsy from your lymph node. Then you have your mammography. So these are your normal views, which is your mediolateral oblique and your craniocaudal views. Then you have your features that are suggestive of malignancy. This is your spiculated mass, fine pleomorphic calcification, and your architectural distortion as shown in your image is suggestive of malignancy. So what is your classical feature that you see in your mammography that is suggestive of fibroadenoma? Right, it is or a benign tumor, that is your popcorn calcification. Now this is suggestive in your benign tumors. Right, now we have this BI-RADS, which is your breast imaging reporting and database system on the basis of your ultrasonography and the mammography finding. So first we have your category 1, which is negative. Now what is negative? That is, you do not have any report, so the probability of malignancy is usually 0. Now what would you be requiring in this patient? So you will be requiring a routine annual screen mammography for women over the age of 40 years. Then you have your breast imaging category 2, that is your benign finding. Now again the probability of malignancy over here is 0%. So this would again be requiring a routine annual screening for women over the age of 40 years. Then you have BI-RADS 3, which was asked you in your question, that is your probably benign finding. So the risk of malignancy is more than 0, but it is usually less than 2%. So you have a follow-up period, which is your 6-month examination. Now in category 4, it is a suspicious abnormality. So a 4A would be findings needing intervention with a low suspicious of malignancy, that is 2 to 10%. Then for 4B, it should be intermediate suspicious of malignancy, that is 10 to 15% of malignancy risk. And findings 4C is moderate concern with high suspicion of malignancy. So over here the risk of malignancy varies from 50 to 95%. So over here biopsy should be considered. Now in category 5, you have your highly suggestive of malignancy, that is more than 95% chances of malignancy. So it usually requires a biopsy and a surgical treatment. Now category 6 is your biopsy proven malignancy, right? So it is a biopsy proven malignancy, so you do not discuss the risk over here, and this is a category reserved for lesions identified on imaging study with biopsy proof of malignancy prior to any definitive therapy. So what are the sort of questions that can be formed from here? So the first is a direct question that can be asked regarding the category. The another question is itself the full form that can be asked, which is breast imaging reporting and database system. Third, it is used for what? It is used for the assessment of the breast biopsy reports. Then the next question that can be asked is regarding your follow-up recommendation, that you are given a BI-RADS score and you are asked what would be your next treatment plan with respect to it. So these are your few important questions that can be asked from your BI-RADS scoring. Now moving down to the MRI. So what is the role of your MRI? It is usually done in women with dense breast or discordant or equivocal finding in your mammogram and USG. It is helpful to distinguish scar from recurrence. Then they assess the multicentricity and the multifocality of the tumor, high-grade DCIs and lobular carcinoma, and have your BRCA gene or other genetic mutations with strong family history, and in women with breast implants. And there is also role of the MRI guided biopsy. So on the left hand side you can see the image of the MRI showing the carcinoma of the breast. So first is your pre-contrast, then you have your post-ganglion contrast, and then you have your subtraction image. So please remember the ganglion contrast is used, and these are the conditions where there would be a role of MRI. Now the next we have your positron emission tomography. So this is a staging investigation. Please remember, not a diagnostic investigation as it was mentioned in your question. In patients with your T3, T4, N2, N3 breast cancer, and in patients with T1, T2, N0, N1 in presence of symptoms and signs suggestive of metastasis. Now there may be a false positive results, usually in your mediastinal lymphadenopathy, pleuropulmonary lesion due to your pleuropulmonary TB. Now the third part of your triple assessment is your needle biopsy, usually under your image guidance, 14G for breast tissues and 18G for axillary nodes. So you do a histopathology and you get an IHC, which is the molecular classification of breast cancer. Now before going to the molecular classification of breast cancer, please remember this image. Now what is the significance of using the image over here? They might just give you this image and ask you what is the procedure being done, and on the basis of this they can actually ask you questions on the histopathological or on the IHC. So IHC is your molecular classification of breast cancer. So you have your following types, which luminal A, which is positive hormone receptor, negative for HER2 new, and Ki67 is low. In case of luminal B, you have your positive hormone receptor, HER2 is negative, and you have your Ki67, which is your proliferation index, high. Basal type or your triple negative type. Now this is your triple negative. So triple negative is your hormone receptor negative, and then your HER2 receptor negative, and it usually has a Ki67 high. Then you have your HER2 new enriched, which is your hormone receptor negative and HER2 positive. Then you have another variety which has been mentioned recently in your recent edition of your Bailey and Love, which is your Claudin low. That is your negative hormone receptor and negative HER2 new with low Claudin. So please remember this molecular classification of breast cancer, specifically your triple breast cancer, where triple negative breast cancer, which has been most frequently asked in your exam. So this were the few important points from the investigations of breast disease. Now let's move on to the next question. So this question that we have is a 37-year-old nulliparous lady on OCP since last 3 years, history of breast carcinoma in mother and ovarian cancer in sister. So what will be your advice as the next step? Stop taking OCPs, genetic counseling and BRCA testing, prophylactic mastectomy and annual mammogram. So as a next step, if you see over here, we are actually maybe dealing with a hereditary breast cancer. Now a nulliparous lady is a risk factor, lady on OCP. Now OCP use in today's world in the Indian population is actually not considered a risk factor because of the low dose of your estrogens and progesterone. However, contrast, the previous OCPs which had high dose were considered a risk factor. So it is unlikely that the OCPs would be a risk factor. Then you have your history of breast cancer in mother and ovarian cancer in sister. So what would you do? So over here you would be advising the patient genetic counseling and your BRCA testing. Right. Now in detailed discussion of breast cancer we shall do once we complete the section on the section of questions on the breast. So for now let's move on to the next question. So a 48-year-old lady with central invasive breast cancer underwent a mastectomy and axillary clearance of level 1 and 2 nodes. On the post-operative wound round, she complained of numbness in your medial aspect of the upper arm. Which nerve is most likely to have been damaged to describe the symptom? So what is the answer over here? Now if your long thoracic nerve would have been damaged, that is your nerve 2 serratus anterior, that would have led to your winging of scapula. So this is a most important question, right? Then so the answer over here would be your intercostobrachial nerves, right, which are usually and commonly sacrificed during the breast surgery if needed, but then if possible they should be preserved. Now thoracodorsal nerve, this is the nerve supply to your latimus dorsi. So if this is injured, patient might have difficulty in painting and climbing. So this could be your some of the clinical clues that can be given in your clinical based scenarios. Now moving on to the next question, which is not a contraindication to breast cancer. I'm pretty sure they were saying over here BCS, breast conservation surgery. So the answer over here will be axillary lymph node. The axillary lymph node is not a contraindication to your breast conservation surgery. Again, I'll be discussing your important points of contraindications to breast conservation surgery in your discussion for your breast cancer, which I would want to take it as a whole. Now value scoring is used for a straightforward question, DCIS. So DCIS is an important topic, so let's just discuss a few important points with respect to your DCIS. So for the DCIS we have this management flow chart. So we have the bilateral diagnostic mammography which is done, followed by a pathology review, ultrasonography and the genetics based on the age and the family history. Now on the basis of this we decide whether the patient is a breast conservation candidate or not a breast conservation candidate. So if she is not a breast conservation candidate, we will go for a total mastectomy plus minus sentinel lymph node dissection and reconstruction. Now if that comes out to be an invasive disease, then we treat it as a breast cancer. If does not come as an invasive disease, what we do is a physical examination with your clinical breast examination annually and diagnostic mammography annually. Now in case of a breast conservation candidate, now who are your breast conservation candidate? Unicentric disease, attempt margin possible more than 2 mm, no contraindication of radiation, no evidence of diffuse microcalcification, tumor to breast size allows acceptable cosmetic results. So the resect to obtain your negative margins. Now if margins are more than 2 mm, then we go for a hypofractionation whole breast schedule for patient more than 40 years, and if there is no adequate margin, then you re-excise or total mastectomy or radiation therapy boost. So now this also gives us a minimum margin that is needed in your DCIS. So if it is ER/PR positive, then we go for an endocrine therapy with tamoxifen for 5 years, and then we do keep the patient on surveillance and follow up. And as we just discussed in the question, the value scoring is used for your DCIS, right? So now let's move on to the next question. So here our answer would be DCIS. So the next question is on thyroid. So before going to the thyroid, let's have a detailed discussion on the breast cancer, which is a very important topic, right? So we begin our discussion on the breast cancer with the risk factor. So I'll be just running through the important points of the breast cancer so that it helps you to give a good revision before you go for your exam. The first important topic that we discuss is your risk factors, which are your modifiable risk factors. So what are your modifiable risk factors? Obesity, parity, breastfeeding, age at first childbirth, use of hormone replacement therapy for more than 10 years, right? Then tobacco use, alcohol consumption and radiation exposure. The non-modifiable risk factors includes the age, sex, ethnicity, family history of breast cancer, genetic predisposition. So you cannot forget the two important genes, which are your BRCA1 and your BRCA2 gene. Then early menarche, late menopause and high risk breast lesion. So what are your high risk breast lesions? They include your proliferative conditions without atypia, complex fibroadenoma, papillomatosis, proliferative diseases with atypia, and lobular carcinoma in situ. Please remember this important point as per the latest edition of AJCC guidelines, where they have removed the lobular carcinoma in situ from the carcinoma in situ category and have placed it into the category of high risk breast lesions. So the most important point that you need to remember definitely from here is regarding your high risk breast lesions and specifically your lobular carcinoma in situ. Now another important table is your histological risk factor for development of breast cancer, as we had discussed. So the maximum risk is with your 4 to 9, that is your proliferative disease with atypia and strong family history. Lobular carcinoma is more than 7, non-proliferative disease is 1 and proliferative disease without atypia is 1.3 to 1.9. Now regarding the pathology, 90% arise from your milk ducts, 10% arise from the lobules. Now the tumor grading, there is a score which is your Bloom-Richardson score, now which includes your percentage of tumor cells with tubules formation, then it includes your nuclear pleomorphism and size and number of mitosis per 10 high power field. So you have your grade 1, which has a scoring of 3 to 5, grade 2 a scoring of 6 to 7 and grade 3 a score of 8 to 9. Now the most common variety of your breast cancer is your invasive breast cancer, non-specific type. Colloid or mucinous cancer have your abundant of mucin. Then your medullary carcinoma have your marked lymphocytic reaction, and your papillary carcinoma has your better prognosis, lymph node and blood mets are rare. So these are some of the important points with respect to your various histological types of your breast cancer. Now regarding the spread, local spread includes the skin, satellite nodules, pectoris major, serratus anterior. Now tumor cells secrete a number of growth factors, which includes your fibroblast growth factor, mesoendothelial growth factor and TGF alpha and TGF beta. So this fibroblast growth factor causes mitosis of the adjacent fibrocyte, which convert to fibroblasts, lay down the collagen, which is your desmoplastic reaction. Now this contraction of collagen and the shortening of Cooper ligament is responsible for the dimpling, which is your shortened single Cooper ligament. Now what is tethering? If there are many Cooper ligament shrunken. So please note this importance of different. So you can just have a shortened single Cooper ligament is referred to as dimpling, whereas many Cooper ligament shrunken is referred to as tethering. Now lymphatic metastasis. So axillary lymph node involvement of contralateral lymph node in absence of contralateral primary is metastasis. So what are the causes of contralateral axillary lymph node mets? It includes the hematogenous spreads via subdermal lymphatics or via ipsilateral internal mammary nodes, and tumor developing in your epithelial embryonic cells rest trapped in the lymph node during your embryonic development. So this can come as your all of the above or except one of the options as a question. Now regarding your hematogenesis, at a tumor size of 1 to 2 mm, a new angenesis occur, which causes a rapid growth, invasion and your metastatic potential. Now the skeletal system, it is much more common in your lumbar vertebrae, followed by your neck of femur and thoracic vertebra. Now bony mets, it's in osteolytic, mainly Now it may also occur to your liver, lung, brain, adrenal gland and ovaries. Then you have another term which is your leukoerythroblastic anemia, that is your tumor cell invade and replace the bone marrow, now which causes your immature blood cells to be seen in your peripheral seam. Now the clinical presentation would be usually the most common presentation being a discrete lump, and they also might present with a nipple discharge or a pain in the breast. The most common tumor site is your upper outer quadrant. And then you have your Purdy orange, which is your involvement of your subdermal lymphatic. So this is your breast. Why Purdy orange? Because it looks like a peel of the orange. What is the cause? Because of your involvement of subdermal lymphatics. Now another important term is your cancer en cuirasse, which is your excessive tumor infiltration of the skin, breast of upper limb and abdomen. So this is your diagram showing your cancer en cuirasse. So please remember this diagram, as it is very important and we can anticipate such sort of question, because this has been recently added in your Bailey and Love, and more importantly this Bailey and Love chapter on breast cancer has been written by your faculties of AIIMS. Now then you have your nipple discharge, skin ulceration, swelling in neck or in armpit, and distant mets may occur in the form of the following symptom like bony pain, cough, breathlessness, headache, visual disturbances, anorexia, weakness, weight loss and hypercalcemia. Now the next important point is regarding your staging. So as you can see over here, I have crossed out the LCIS, that is LCIS has been removed as per the current AGC guideline. Now T1 is less than 2 cm in size, T2 is 2 to 5, T3 is more than 5. Now T1 is subclassified into 1A, B, C. 1 is 1 mm to 5 mm, 5 mm to 10 mm and 1 to 2 cm. Now T4. Now T4 is your chest wall involvement. Please remember it does not include your pectoralis major involvement. T4B is your skin ulceration, satellite nodules or Purdy orange, and TC is A plus B, and TD is inflammatory, that is your Purdy orange and redness more than 1/3 breast associated with or without lump. Right. Now regarding your nodal metastasis, so N1 is to your ipsilateral movable level 1 and 2 axillary lymph node. N2A is to ipsilateral fixed or mated lymph node. 2B is to the ipsilateral internal mammary lymph node, but there is absence of your axillary lymph node. Then you have your 3A, which is to your infraclavicular lymph node, and then in 3B is your ipsilateral internal mammary plus in the presence of your axillary lymph nodes. Then you have N3C, which is your metastasis to your supraclavicular lymph node. So this were your few important points with respect to your staging of breast cancer. Now the key points in the 8th edition is lobular carcinoma is a high risk benign lesion and not a cancer. Please remember this point, as it has all the potential to be asked you in your recent coming exam. Then the T categorization of the multiple synchronous tumor is documented using the M modifier. Prefix Y is used to denote your post-neoadjuvant therapy status. Satellite nodules in the skin must be separate from the primary tumor or it to be characterized as T4B. Then you have your pathological complete response denotes the absence of tumor cells in the breast and axillary lymph nodes in your surgical specimens. Your inflammatory carcinoma remain classified as your inflammatory carcinoma after NCD even after your complete remission. So this is a very important table, and each line is a potential one-liner or a potential question in itself. Now the microinvasive carcinomas are defined as invasive tumor foci less than 1 cm and tumor more than 1 mm and less than 2 mm should be reported as rounded to 2 mm, and tumor size should be measured to the nearest millimeter. Now regarding your metastatic workup, so for your LABC you will do a CCT whole abdomen, pelvis and chest and bone scan, and early breast cancer usually do not require any metastatic workup only if symptoms of metastasis present. A few points regarding your neoadjuvant systemic therapy. It consists of your neoadjuvant chemotherapy, targeted therapy and your hormonal therapy. Why do we give neoadjuvant chemotherapy? Because I would want to shrink my tumor and also to assess the in vivo response of the tumor. What are your indication? locally advanced breast cancer, and some selected cases of early breast cancer. So what are those selected cases of early breast cancer? To downsize your breast tumors to facilitate breast conservation, triple negative breast cancer, HER2 positive breast cancer, premenopausal women aged less than 50 years, and patients with axillary lymph node metastasis. Right. Now response assessment when 3 weeks after administration of second CT. So this is your most important point that you need to remember. How? By response evaluation criteria in solid tumor. Now what is RECIST? CR, that is your complete response or lesion not detectable either clinically or imaging. Then you have your pathological response, not pathological, partial response, that is a more than 30% reduction in your maximal diameter. Then you have your SD, which is your stable disease, that is less than 30% reduction in maximal diameter. And then you have your progressive disease, that is more than 20% increase in your maximal diameter. So this were your few important points regarding your neoadjuvant systemic therapy. So the management would be for stable disease or progressive disease, surgery after initial 2 cycles of chemotherapy, and in case of your complete response or your partial response, an anti-CT drug regimen can be given prior to the surgery. Right, over here a radio opaque magnetic clip, that is your MAC-C, right, is placed at the epicenter of the tumor so that it can be identified at the time of surgery. A 0.5 centimeter silicone catheter tip may also be used. So please remember which of the following are used during to locate the epicenter of tumor at the time of surgery. Now regarding surgery margins, so DCIs we have just discussed, that is 2 mm margin, and invasive would be a no ink margin. Now MRM, that is a modified radical mastectomy. When would you do it? In large tumors, multicentricity, diffuse microcalcification, BRCA positive cancer, and patient preference. Then skin and nipple sparing mastectomy when DCI is early breast cancer, tumor more than 1 centimeter from the skin and more than 2 centimeter away from the nipple. So what is BCS? That is removing your tumor with 1 centimeter margin. What is BCT? BCS plus radiation therapy. Now what are your contraindications of your BCS? So they are your multicentricity, large tumor to breast ratio, 2 times positive margin after re-excision, chest wall radiation, collagen vascular disease, ankylosing spondylitis, severe orthopnea. Right. Now wide local excision, that is up to 20% of your breast volume can be excised with adequate margins and closure of defect by approximation of breast tissue. So the oncoplastic procedure now is for more than 20% of the breast volume, level 1 which is your volume displacement and level 2 which is your volume replacement. So this were your few important points with respect to the surgery for the breast cancer. Now moving down to the next important topic in your breast cancer is regarding your prognosis of breast cancer. So for prognosis of breast cancer, I would want you all to remember this table, which is your disease factor, that is size of tumor, stage of disease, axillary lymph node involvement, grade of tumor, histopathological variant, that is your HER2 positive and triple assessment, presence of lymphovascular invasion, extensive DCI component, and high Ki67 index. Now in case of patient factors, you have younger age, premenopausal woman, BRCA associated tumor, family history of breast cancer, prior history of breast cancer, obesity and sedentary lifestyle, and failure to complete independent treatment. So if asked most common prognostic fact, most important is definitely your lymph node, and in case of a metastatic breast cancer, it comes your hormone status. Right. Now another important point is regarding your genetics in breast cancer. So the genetic risk includes your BRCA1, which is located in 17q21, that is a 40% risk of ovarian cancer and your 50 to 85% of lifetime risk. BRCA2 is your 20% risk of ovarian cancer and located on 13q12.3. So please remember, the higher risk of ovarian cancer is with BRCA1 compared to BRCA2, and it has a 50 to 60% lifetime risk. Now indications of genetic risk evaluation. So this is a beautiful table given in your Bailey and Love. So any individual at any age with a known pathogenic or likely pathogenic variant in a cancer susceptibility gene within the family, breast cancer diagnosed age less than 50 years, triple negative breast cancer diagnosed age less than 60 years, 2 breast cancer primaries, breast cancer at any age with one or more relative with breast cancer diagnosed less than 50 years, having invasive ovarian cancer, male breast cancer, pancreatic cancer or high grade or metastatic prostate cancer. Then you have your breast cancer at any age with 2 or more affected relatives. Then you have your male breast cancer, an individual with a personal family history of 3 of the following, that is breast cancer, sarcoma, adenocortical carcinoma, brain tumor, leukemia, colon cancer, lobular breast cancer, diffuse breast cancer. So I would want you all to remember at least this 2 particular cancers. Right, so this is all with respect to your genetic risk evaluation. This is a very important table recently added in your Bayesian law, and we can expect a question out from here. Now our next small topic with respect to your breast cancer in pregnancy. So they are associated with your triple negative breast cancer. In suspected meds, MRI without gadolinium contrast is preferred. In first and second trimester, MRM is preferred. Sentinel lymph node biopsy with low dose technetium target sulfur safe for fetus. There is no CT in your first trimester. 5-fluorouracil should be avoided, and your preferred agents include your anthracyclines and taxanes. So this were your few important points with respect to your breast cancer. Another important point that was added in your breast cancer section is regarding your reconstruction. So what I'll do is, if possible, I'll try to share a YouTube video in your GamePG YouTube channel. So just check out that GamePG YouTube channel for the video on the reconstructions part, the various images. But apart from that, this were the most anticipated questions that we can expect from your breast cancer section. So now move on to the discussion for the thyroid questions. So a woman came to the OPD with complaints of palpitation. So a woman comes to the OPD with complaints of palpitation, heat intolerance, weight loss. On examination, there is diffuse thyroid enlargement and exophthalmos is also noted. So which of the following investigations would you order in such a patient? So if we make a diagnosis over here, we are dealing with Graves' disease. So now keeping this in mind, let's look at the options. USG neck, yes, I will be doing a USG neck in such a condition of Graves' disease. Thyroid function test, yes, this will often be rather my first investigation that I do in my thyroid disorder. So for a thyroid disorder, you usually do like a triple assessment, a quadruple assessment. So what would be your quadruple assessment over here? It would be an history clinical examination, a radiological examination, a histopathological examination by doing a FNAC, and addition is your thyroid function test. FNAC, no. For a diffuse, now in case of a diffuse thyroid goiter, we do not do an FNAC. Then a thyroid antibodies and a thyroid scan, yes, these are done. So your answer over here would have been 1, 3, 4 and 5. Right, it's not all, as we don't do FNAC in your diffuse thyroid enlargement. So this is with respect to your Graves' disease. One more question that is important is, if you are planning a Graves' disease surgery, which medicine do you give before surgery in order to reduce the vascularity? So the answer to this is your Lucols iodine. Now this has also been asked in your AIMS exam. So this Lucols iodine, it reduces your vascularity of thyroid gland, which is going to help in surgery. Let's move on to the next question now. So 24-year-old patient presents with a swelling in the neck. FNAC was done and image is given below. So what is your diagnosis? So I think I have just placed an image giving you a very good hint over here in form of orphan Annie nuclei. So yes, this is seen in your papillary thyroid carcinoma. So what we'll do right now is discuss the important one-liner points from the following carcinomas, as it's a very important topic for your exams. So first, regarding your papillary carcinoma, it is the most common, much more common in females compared to males. The peak incidence being in 3rd to 5th decade. Propensity for lymph nodes. Distant mets is uncommon, high rate of occult micromets. Papillary microcarcinoma is less than 1 centimeter in size. It has an excellent prognosis and the complex branching papillae with your pseudonic inclusion, nuclear grooving and psammoma bodies. So these are some of the clinical clues or the histopathological clues that you might be finding in your questions in order to diagnose papillary thyroid carcinoma. So you have this image over here depicting your papillary thyroid carcinoma. So you can see over here this particular image, the second image, showing an increased height to width ratio in single row of cell. This is called the tall cell variant of your papillary thyroid carcinoma, which is associated with a poor prognosis than your well differentiated papillary thyroid carcinoma. Now this is your orphan Annie nuclei or your open phase nuclei and the closed phase nuclei. So this orphan Annie nuclei is your classical description of the histopathological features in your papillary thyroid carcinoma. Now moving down to the follicular carcinoma, much more common in elderly, differentiated only on histopathology, has a propensity for your blood-borne metastasis. There is a history of long-standing goiter. So if you have a clinical clue in your question in the form of a long-standing goiter, that would be your follicular carcinoma. Then they have the Hurtle cell variant, which is the oxyphilic cells and the poor prognosis. The anaplastic, that is the dedifferentiation of the papillary or the poorly differentiated carcinoma. They have rapid growth, visceral invasion and distant mets. Now they have giant and multinucleate cells in your histopathology, sheet of cells marked with heterogeneity. Now there is limited role of radiotherapy and chemotherapy, and the tracheostomy is done on airway signs of obstruction. Right. Now regarding your medullary part, so you have your parafollicular cyst, which is parafollicular cells from which it arises. Then you have your amyloid stroma, and then you have your calcitonin and C levels elevated. Diarrhea is present in 30% due to 5-hydroxytryptamine. Familial in around 10 to 20% of cases. It is associated with your Men's syndrome. Lymph nodes is present in around 50 to 60% of the cases, and hence you usually require a total thyroidectomy with your bilateral neck dissection in your medullary thyroid carcinoma. Now a few important points regarding your differentiated thyroid carcinoma management. So you do a total thyroidectomy, and then in cases of high risk you would be requiring a radioiodine therapy, and in cases of low risk you would be not requiring a radioiodine therapy. Now what is your rationale for radioiodine therapy? It eliminates any normal thyroid tissue left after surgery, simplifying your subsequent detection of residual recurrent tumor tissue. It will destroy the occult microscopic foci of your neoplastic cells with the thyroid remnant, and it treats the residual tissues. Then what is the timing for ablation? You make the thyroid depleted for 6 weeks, then the ablation is done. Earlier, if you want to do, then you need to use the recombinant TSH. Now the prognostic factors include your age, metastasis, extrathyroidal spread, size, lymph node, molecular or tumor marker, VEGF and P53. Now as per the ATA risk classification, it is classified into low, intermediate and high risk on the basis of your local invasion, cervical node, distant mets, post-optic scan, completeness of excision and histology, and thyroglobulinemia after ablation. So if you look at the various parameters, in case of low risk, it will be no invasion, no lymph node involvement, no distant mets, no post-op uptake scan, complete excision, non-aggressive histology, and there is no thyroglobulinemia after ablation. Whereas in case of high, it is macroscopic invasions, positive lymph node, distant mets, the uptake scan is outside the thyroid bed, incomplete excision, aggressive histology and thyroglobulinemia after ablation. Now the follow-up regimen in case of differentiated thyroid carcinoma includes your uptake scan, which is twice in 5 years, clinical examination, that is 3 monthly for 3 years, thyroid function test, that is 3 months, 6 months and annually, and thyroglobulin assay, that is 6 months, 12 months, 24, 36, 48 and 60 months. Now regarding your recurrence, so it is your raised serum thyroglobulin assay more than 5 nanogram per ml with T4 supplementation and more than 10 nanogram per ml without T4 supplementation, followed by your radioactive iodine uptake scan. Now if there is a radioactive uptake negative recurrence, it is due to the dedifferentiation of cancer into the more anaplastic form. So we will be requiring a redifferentiation therapy, that is your retinoid, Paxate PPR agonist and selumetinib. Now the molecular targets includes your sorafenib, which is a tyrosine kinase inhibitor, and levatinib. So this were your few important points with respect to your thyroid cancer. Now one more important point that we discussed from thyroid is regarding your approach to your thyroid nodule, which would help you to solve another set of questions that may come from your thyroid. So in case of your approach to thyroid nodule, you have your history and clinical examination followed by your serum TSH. Now if serum TSH is high or normal, then we do an ultrasound. Now on this basis of ultrasound, what do is you check for the margin whether it's ill-defined or not, shape, irregular shape, hypoechoic microcalcification, hypovascularity, elastography, lymph node and architectural distortion. Usually require a 7 to 13 megahertz and a high resolution ultrasonography. So if the features on the ultrasound are whether suggestive of high intermediate, which I'll be discussing right now, and the size is more than 1 centimeter, then you would do FNA. If it is a low risk, then you would do FNA when it is more than 1.5 centimeter. If it is very low, you would do more than 2 centimeter. If it is benign, they would not be requiring of FNA. Now if on this side, if the serum TSH would have been low, you would need to do a radioisotope scan. If it is suggestive of a cold nodule, then you would again need to go for an ultrasound. If no isotope and no isotope uptake is what is your definition of your cold nodule, whereas in case of hot nodule, it is your overactive. So in this case, you would be requiring your iodine or surgery. Now one more important thing is regarding the assessment of the lymph nodes. So regarding the assessment of lymph node, you have your loss of fatty hilum, DDD more than 7 mm, heterogeneity and microcalcification. So as I was telling over here regarding your high, intermediate, low, very low, so how do you assess that? So these are your features on the basis of which you are going to check for high suspicious, intermediate suspicious, low suspicious or very low suspicious. So high suspicious is your microcalcification, hypoechoic nodule with irregular margin, hypoechoic irregular margin, hypoechoic taller than white. Then you have a hypoechoic irregular margin with extrathyroidal extension. Then you have your hypoechoic interrupted microcalcification with soft tissue extrusion and nodule with irregular margin, suspicious left lateral lymph node. Then you have your intermediate suspicion, that is hypoechoic solid regular margin and hypoechoic solid regular margin. And your low suspicious would be hyperechoic solid regular margin, isoechoic solid regular margin, partially cystic with eccentric solid area and partially cystic with eccentric solid areas. And very low suspicious would be spongiform, partially cystic with no suspicious features. Benign would be like a cyst. So this would be on the basis of the ultrasonography that you would be needing to categorize. Now over here, another important classification is your Thai classification. So they have actually asked you direct questions regarding what is thyroid 2 suggestive of or Thai 3 suggestive of. So Thai 1 is non-diagnostic, Thai 1C is non-diagnostic cystic, Thai 2 is non-neoplastic, Thai 3 is follicular, Thai 4 is suspicious of malignancy and Thai 5 is malignant. Now regarding your Bethesda classification, another important classification, the name itself can be asked or the components can be asked, which is 1 is non-diagnostic or inadequate, 2 is benign, 3 is atypia or follicular lesion of undetermined significance, 4 is follicular neoplasm, 5 is suspicious of malignancy, and 6 is your malignant. So these were your few important points with respect to your solitary thyroid nodule, the approach that can be asked. Now apart from this, a few additional points in your solitary thyroid nodule is, so this we had discussed. Now what is the management? If it is non-diagnostic, what you do repeat. If it is benign, you will follow up the patient. If it is your a TP of undetermined significance or a follicular neoplasia, what you will do is you will repeat with the molecular testing. Now importantly, what I want to discuss is the presence of these mutations are strongly suggestive of cancer, that is RET PTC, PPR gamma, Paxil, BRAF and ROS. Right. Now if it is suspicious of malignancy or malignant, then you would be definitely requiring a surgery. Right. So this were your important points with respect to your thyroid carcinoma and an approach to a solitary thyroid nodule. Please remember the THI classification, as it has some direct questions that have been asked in your previous sessions of your INI. So let's move on to the next question. So this question is from the localization of parathyroid, which is a very important topic. So the first thing is USG is hyperechoic. Then your Sesame scan localizes ectopic better. Miami criteria after 1 hour of surgery. So what is the answer? So let me tell you, no, it is not hypoechoic, it is rather hypoechoic. So option A and option D are cancelled. Then you have your Sesame scan, which localizes ectopic better. The answer is true. Right, so this is a true statement. And then we have the Miami criteria, which is not 1 hour, rather 10 minutes of surgery. So let's take a look at the important points regarding the localization of your parathyroid. So the preoperative localization of your parathyroid glands, you have your Sesame scanning, which is your 2-methoxy 2-methyl propyl isonitrile, most accurate and reliable method, has same sensitivity and specificity like your USG, but it better images your ectopic glands. Here you have 3 different methods. One is your single isotope dual phase scan, then is your dual isotopic subtraction imaging, and your single photon emission CT. Your ultrasonography, so over here your parathyroid adenomas are hypoechoic. Now giant adenomas are which are more than 3 cm in size. Now 4D CT, which you have your anatomical plus the 4th dimension is your functional part. MRI is for your reoperation and adenoma in your mediastinum. Parathyroid angiography is usually for your reoperative cases and not used these days. Then you have your selective venous sampling, which is localization following your 2-fold drop in your parathyroid sample and your serum PTH. Then you have your in-drop criteria, which is fall in your PTH level, that is more than 50 minutes. Or not 50 minutes, sorry, it's more than 50% at the baseline value after 10 minutes of successful removal of your suspected parathyroid gland. So these are your few important points with respect to your preoperative localization of your parathyroid glands. Now let's move on to the next question. So we have this question over here, which states a 56-year-old male presents to his GP with a 3-week history of sweating, headaches, constipation and itchy lesions over his back. On examination, his blood pressure is 166/94 and his pulse rate is 104. 24-hour urinary catecholamines, metanephrines and valine metallic acid are found to be elevated. A CT scan and iodine 131 meta-iodobenzyl guanine scan confirm the presence of a pheochromocytoma. The patient is subsequently also found to have a medullary carcinoma of thyroid. Which one of the following is most likely diagnosis? So you have a combination of a pheochromocytoma and a MTC. So It makes our answer multiple endocrine neoplasia type 2A. It would have been type 2B had it been a Marfanoid features, and type 1 if you have your 3P. So this question was from your MEN syndrome, which is your multiple endocrine neoplasia. So let's take a look at some of the other important points from your MEN syndrome. So over here I'll be just discussing a few important points. Those who want to watch the detailed explanation can actually check out the video on the Game PG YouTube channel. So we have two types of MEN, MEN 1 and MEN 2. MEN 1 is seen in your tumor suppressor gene, which encodes for menin, whereas your MEN 2 is seen in your proto-oncogene, which encodes for your tyrosine kinase. So in tyrosine kinase there is a gain of function of mutation causing the activation of TKR and initiating of the cancer process. Now MEN 1 is located in chromosome 11 and MEN 2 is in chromosome 10. Another important difference between MEN 2 and MEN 1 is your strong genotypic and phenotypic association in case of your MEN 2. Now MEN type 1 is your 3 P's. So you have your parathyroid, pituitary and pancreas. Parathyroid, remember, it is hyperplasia, more common than adenoma. In pituitary it is the anterior pituitary which is involved, and most common lesion is your prolactinoma. And in pancreas you have most common being gastrinoma compared to your insulinoma, and the most common cause of death is your pancreatic neuroendocrine tumors. Now the other tumors that includes are bronchial, thymic, gastric carcinoid, lipoma, facial angiofibroma, benign thyroid neoplasm, and your adrenocortical tumors. Now the diagnosis would involve involvement of around 2 to 3 organs, and the familial MEN is involvement of any organ in the first degree relative. Now screening, genetic test at the birth, followed at the 5 year for the pituitary, at 8 years for your parathyroid, and at 20 years for your pancreatic neuroendocrine tumors. So this were your few important points regarding the screening, and the treatment would involve, in case of parathyroid, 3.5 gland parathyroidectomy, total parathyroidectomy with auto implantation and brachioradialis muscle in the non-dominant hand. Now for pancreatic neuroendocrine tumor, gastrinoma, you would require a resection. Insulinoma, enucleation, and non-functional, again you would be requiring a resection. Now for pituitary tumors, medical management would be your cabergoline followed by surgery. Now MEN 2 syndrome, you have your two form. So you can actually be asked a direct question, which of the following is a component of MEN 2A, which of the following is component of MEN 2B. So MEN 2A is medullary thyroid carcinoma, pheochromo, hyperparathyroidism, Hirschsprung, cutaneous light chain amyloidosis. MEN 2B is MTC, pheochromo, mucosal neuromas, most common site being your lips. You have your GI neuromatosis, Marfanoid habitus, megacolon, and constipation. Now familial MTC is your MTC in isolation. Now simple is your MTC plus pheochromocytoma. So the screening would include your red proto-oncogene mutation, pentagastrin stimulated calcitonin. Diagnosis of MTC is with the help of increased calcitonin, CA and red mutation. Pheochromocytoma, you have your plasma free metanephrine and 24-hour urine free metanephrine. Then you have your hyperparathyroidism, where you have increased serum calcium, PTH, and sesatimabi scan. So this is your diagram showing your ganglion neuromatosis of the oral mucosa, which is one of the classical features in your MEN type 2B. So the treatment would include your total thyroidectomy with central lymph node dissection. If you have lymph nodes positive, you will go for a bilateral neck dissection. And pheochromocytoma, you would be requiring either a lap or a open adrenalectomy. Now regarding your genotype and phenotypic association, what I would want you all to remember is prophylactic thyroidotomy in case of 2A will be less than 5 years, and in case of 2B less than 1 year. Now for MEN 4, another type of MEN syndrome is extremely rare, parathyroid pituitary associated with your CDNK1B gene. So these are your few important points which I would want you all to remember regarding your MEN syndrome. So let's move on to the next question. So an examiner's favorite question, a favorite topic, a 40-year-old lady, intermittent headache, palpitations, excessive sweating has recently been diagnosed with a pheochromocytoma. So which one of the following is your ideal initial management of a condition? Alpha blockade initially followed by beta blocker. Once alpha blocker is sufficiently established, alpha and beta blocker simultaneously, no. Beta blockade initially, no. We always give the alpha blockade first, so the first statement is actually true. Alpha blockade alone, again no, this is a false statement. So the best answer would have been your alpha blockade initially followed by a beta blockade once your alpha blockade is sufficiently established, right? So pheochromocytoma is your examiner's favorite topic, so we will discuss a few important points and the questions that have been asked or that can be asked from your pheochromocytoma. So regarding pheochromocytoma, these are your neuroectodermal tissue of your adrenal medulla. Extraadrenal parasympathetic and sympathetic ganglioma are referred to as your paraganglioma. Now 90% of the patients present to you with headache, palpitation and sweating. Now the most common symptom being your hypertension. Hypertension is your paroxysmal, that is around 50 to 60%, continuous being in 30%, then headache that is seen in 60 to 90%, sweating in 50 to 70% and palpitation 50 to 70%. Now this particular table is absolutely taken from your Bailey and Love. So the investigation of choice for pheochromocytoma is your urine 24 hours free metanephrine, and the radiological investigation of choice for your pheochromocytoma is MRI. Now the pre-op conditioning requires your alpha blockers followed by your beta blockers, and never first alpha or beta blockers, because the unopposed of action of your alpha adrenergic receptors will occur. Now the treatment would be your lap and open adrenalectomy. Now there is one flow chart which is given in your textbook of Sabiston, which I would like to discuss with you people right now. So you have your plasma free metanephrine, which is positive, you go for your 24-hour urinary metanephrine and catecholamines. Now if this is negative, then you actually again repeat your 24-hour urinary catecholamine and metanephrine. So when you ask what is your next step, you would actually repeat it. Now if there is a mild to moderate elevation, then you will do a clonidine suppression test. Now if this 24-hour urine elevation is positive or this clonidine suppression test is positive, then you go for a CT or MRI. Now if this age is more than 50 years or a single site, then you go for a pre-op conditioning surgery, whereas if it is age less than 50 years and multifocality, you would go for an MIBG scan. Now why are we doing actually this pre-op conditioning? Target is for your intra-op hypertension and to maintain your post-op hypotension. Right, so please remember this important flowchart, as they can ask you what would be the next step. And one important point over here is regarding your management in pregnancy. So first and second trimester you usually do a lap adrenalectomy, third trimester cesarean section followed by your adrenalectomy. Now your hereditary pheochromocytoma is associated with your MEN2, familial paragangliomas, von Hippel-Lindau syndrome, neurofibromatosis type 1, tuberous sclerosis and your Sturge-Weber syndrome. Right, so these are your few of the important points with respect to your pheochromocytoma in pregnancy. So the next question that we have is a very important topic which I have not taken from Bailey and Love but calcify from your textbook of Sabiston, because I feel it has a potential to be asked in your INI. So which of the following is true for the image shown below? So firstly we need to understand that this is an image of your calciphylaxis. Right, so let's discuss regarding your calciphylaxis and then come back to this question. So calciphylaxis, it is seen in 4% of the patients who undergo surgery for your secondary hyperparathyroidism. It is a calcific uremic arteriopathy which is associated with the disseminated calcification, causing your vascular calcification and your skin necrosis. So they appear as your painful cutaneous pruritic lesions predominant on your extremities. Now the underlying tissue calcification within the arterial and the small vascular wall causes ischemic necrosis, leading to gangrene and eventually sepsis. Now they have your elevated GXP but not associated with your high PTH levels. So PTH levels are not elevated in your calciphylaxis. Now there is a reduction in your alpha-2 Hermann-Schmidt glycoprotein, which is abnormal in smooth muscle cell biology in uremic patients. Now an urgent parathyroidectomy is usually required as it decreases pain, improves wound healing and reduces the risk of amputation and is associated with your increased median survival. So moving down to the question that we had. So this was an image of your calciphylaxis. So yes, it is seen in patients undergoing surgery, that is around 4%. Vascular calcification is again true. Surgery is advocated as it reduces pain, true. So the answer over here would be all of the above. So let's move on to the next question. A 52-year-old estate agent presents to his general practitioner with a 4-week history of upper abdominal pain and diarrhea. He also describes a few episodes of your dark colored vomiters during this period. Now, general examination is unremarkable. Esophagogastroduodenoscopy reveals the multiple ulcers in stomach and duodenum. So, what is your most likely diagnosis? Insulinoma, gastrinoma, somatostatinoma, and carcinoid tumor. So, first we need to make the diagnosis. So, over here our diagnosis is Zolliker-Ellison syndrome. So, the answer would have been gastrinoma. Now, these are examples of insulinoma, gastrinoma, and somatostatinoma are examples of your pancreatic, endocrine tumors, and these are a very important topic for your exam. So just let's take a look at the important points from your pancreatic neuroendocrine tumors. So for pancreatic neuroendocrine tumors, I would want you all to remember this important table, which is going to help you solve almost all the questions that may come from pancreatic neuroendocrine tumors. So the first is your insulinoma, which has an incidence of 70 to 80%. Now, how would it present? So, what would be the clinical clues to you in the question? Weakness, sweating, tremor, tachycardia, anxiety, fatigue, dizziness, disorientation, seizures. Right, and the chance of malignancy is less than 10%. Then you have your gastrinoma, which has an incidence of 20 to 25%, and the presentation would be intractable or recurrent peptic ulcer disease, hemorrhage, perforation. Now the hemorrhage basically presents to you with a dark color vomitus, which was given as a clinical to you in the question that we discussed. Then complications of peptic ulcer disease and diarrhea, and risk of malignancy is around 60 to 90%. Then you have your non-functional tumors presenting to you with obstructive jaundice, pancreatitis, epigastric pain, duodenal obstruction, weight loss and fatigue. Then you have your vipoma, which is again presenting to you with profuse watery diarrhea, hypotension and abdominal pain. And then you have your glucagonoma, which is presenting to you with your characteristics migrated necrolytic skin rash, glossitis, stomatitis, angular cheilitis, diabetes, severe weight loss and diarrhea. Then we have your somatostatinoma presenting to you with cholelithiasis, diarrhea and neurofibromatosis. Now, carcinoid would be presenting to you with flushing, sweating, diarrhea and edema. ACTH-oma would be presenting with Cushing syndrome, and GRF-oma will be presenting to you with acromegaly. So on the basis of this, we will be able to form the type of the diagnosis of your various pancreatic neuroendocrine tumors. Now there is another important table, which is your WHO neuroendocrine tumor classification of tumor grade. So grade 1 is which is less than 2 mitosis per 10 high power field and less than 3 Ki67 index. Grade 2 is around 2 to 20 mitosis per 10 high power field with 3 to 20 Ki67 index. Then we have grade 3, which is more than 20 mitosis per 10 high power field and more than 20 Ki67 index. And your poorly differentiated neuroendocrine tumor is again more than 20 mitosis on your more than 20 Ki67 index. Now regarding your gastrinoma, which is also your Zolliger-Ellison syndrome, now it includes, now these are the important three criteria of your Zolliger-Ellison syndrome: fulminating ulcer, diathesis in your stomach and duodenum, the clinical clue that was given to you in the question that we were discussing. Then recurrent ulceration despite adequate therapy and gastrinoma. So you have your association with Men-1 syndrome, and which we had discussed that gastrinoma is much more common than insuloma. The most common location is your duodenum, and then gastrinoma triangle is known as your Passeur's triangle. So if you see over here at this particular image, this is the site where the gastrinoma occurs most frequently, which is bounded by medially by your junction of the neck and the body of pancreas. Superiorly, it is bounded by your junction of the cystic duct and the common bile duct. Then your inferiorly, it is bounded by your second and the third part of the duodenum. Now gastric pH is usually less than 2.5 and your serum gastrin concentrations are more than 1000 picogram per milliliter. Now if it is in the range of 100 to 500, then we need to do a secreting test. Now pre-op localization is done with the help of your endoscopic USG, and for your pancreatic gastrinoma, enucleation needs to be done and duodenotomy needs to be done in case of Men-1 syndrome. Now your duodenal gastrinoma, if it is less than 5 mm, it is enucleated with overlying mucosa, whereas more than 5 mm are excised with full thickness excision of your duodenal wall. Now a few important points with respect to your insulinoma. Now this is the commonest endocrine tumor of the pancreas, having a high incidence in the 4th to the 6th decade. Now 90% are benign and solitary. Now they have symptoms of neuroglycopenia, that is during fasting or exercise. Now it is important to differentiate this from your late dumping syndrome. Now your late dumping syndrome is from your hypoglycemia that occurs after meal. Now an important triad associated with your insulinoma is your Whipple's triad. Now what are your components of Whipple's triad? Symptoms induced by fasting, hypoglycemia at the time of symptoms, and symptoms relieved by the administration of glucose. Imaging is by your endoscopic ultrasound, which has a positive detection rate of around 90%, and then we do a CT or MRI. Visceral angiography with arterial stimulation and venous sampling in case of a negative endoscopic ultrasound and more than one lesion. Now surgery would be enucleation, which can be done laparoscopically, and your medical treatment includes your diazoxide, which suppress your insulin secretion by your direct action. Now in case of metastatic disease, what you need to do is you use a somatostatin analog, everolimus, chemotherapy and chemoembolization. Right. So this were a few important points with respect to your pancreatic neuroendocrine tumors that you need to remember. Now let's move on to the next question. So this is a one-liner question which is getting very predominantly asked in your entrance examinations, right? So it is regarding your V's criteria. So what is your V's criteria used for? So the answer is straightforward, that is your adrenal cancer. Right, so the questions from various criteria can be again asked you in a tabular format, but of which the V's criteria is very important, and hence I have included this in your test paper. Now let's look at the components of your V's criteria and some important points of your adrenal cancer. Now adrenocortical carcinoma, it is a rare tumor. It is much more common in female compared to male. Now the most important prognostic factor is your size. It has a bimodal age distribution, first in the less than first decade and then much more common in your more than 5 decades. Now, regarding your V's criteria, the various components includes are your mitotic rate, then you have your cytoplasmic, that is your clear cell components of 25% or less of tumors, abnormal mitosis, necrosis and your capsular invasion. So these are your V components of your V's criteria. Now the question that can, again, if they want to ask an advanced question, they could actually ask you which of the following are not the components or is the component of your V's criteria. Then another important one-liner that is asked from your adenocortical carcinoma is regarding your McFarlane staging. Now stage 1 is less than 5 centimeter tumor, stage 2 is more than 5 centimeter tumor, stage 3 is invasion into the local structure, and stage 4 is your distant metastasis. Your treatment would include your radical dissection plus para-aortic or the renal lymph node dissection. So this were your few important points with respect to your adenocortical carcinoma. And in the options you had your Cushing syndrome. Now Cushing syndrome is also a very important topic, so let's take a look at some of the important points of your Cushing syndrome. So Cushing syndrome is your hypersecretion of cortisol, which can be ACTH independent and ACTH dependent. In ACTH independent, it would be a unilateral adenocortical adenoma, an adenocortical carcinoma, or a bilateral macronodular hyperplasia. Whereas if it is at ACTH dependent, it could be a Cushing disease from your pituitary gland, ectopic ACTH dependent producing tumors, example being your small cell lung carcinoma and a foregut carcinoid, and then it could be CRH tumors that are your neuroendocrine or your medullary tumors, and because of your excess cortisol administration. Now what would be the clinical presentation? Such patients would usually present with your facial plethora, buffalo hump, moon facies, central obesity, and your weight gain. Apart from that, the patients may have hypertension and diabetes. So how do you plan to investigate or manage this case? First, you need to do a 24-hour urine free cortisol levels. Now if it is threefold elevated, then it is a probable Cushing syndrome. However, if it is 1 to 3 times elevated, then you would need to do a late evening free cortisol. Now if it is more than 550, that is a Cushing syndrome. However, if it is less than your 550 nanogram per deciliter, then you need to think of your alternative cause. Now similarly, if your 24-hour free urine cortisol levels were less than 1-fold, you need to think of an alternative cause because Cushing syndrome is unlikely. Now this is a beautiful image that has been taken from your textbook of Sabiston, showing your clinical manifestation of your Cushing syndrome. So if you look at the first image, it is the appearance of man before the Cushing syndrome has developed, and this image is after your Cushing syndrome, right? And you can also look at the abdomen over here, right? So this are your purple abdominal axillary striae in the man of Cushing syndrome. So once you have established the diagnosis of a Cushing syndrome, you look for the ACTH. Now if ACTH is detectable, right, that is ACTH dependent, then you do a pituitary MRI. Now in pituitary MRI, if you have a mass, you might have to go for a pituitary surgery. If there is no mass, then you would do a bilateral inferior petrocell sinus sampling. Now on the basis of this, if a gradient is present, then you would do a transsphenoidal pituitary surgery. If fails, then you would need to go for a bilateral adrenalectomy. Now if on the bilateral inferior petrocell sinus sampling there is no gradient, then you need to do a chest CT or abdominal CT and a somatostatin study. Now if it is positive, then you need to go for a resection, as it would be a case of ectopic ACTH. Now if you found that the ACTH was non-detectable, that is ACTH independent tumors, so you do a thin cut adrenal CT, and then on the basis of it you would require your adrenalectomy, right? So this were your few important points with respect to your Cushing syndrome. Now this is a new question which I have taken from your Bailey and Love. So this has been recently added in your Bailey and Love regarding your IgM. So what is IgM? IgM is your idiopathic granulomatous mastitis, right? So the question they are asking is, which of the following is true for your IgM? Benign, yes, it is true. Not self-limiting, false, it is generally self-limiting. Most common in elderly, no, it is much more common in young population. So the answer over here definitely will not be all of the above, and the answer would be A. Now let's take a look at the important some important points regarding your IgM and your other inflammatory and the non-inflammatory conditions of the breast. So the acute inflammations of the breast, that is mastitis, it is the inflammation of the breast tissue plus minus infection. Now it is much more common in lactating versus non-lactating breast. Now the lactational mastitis, it is usually present in 3% to 20%, the most common cause being the Staphylococcus aureus. Now how is the mode of the presentation? First, it is usually a generalized cellulitis. So antibiotics such as cloxacillin, flucloxacillin or erythromycin can be used. Breastfeeding is encouraged 2 hourly, followed by emptying of breast. Breast support garment, cold compression and analgesic aid. If this generalized cellulitis does not resolve, then it forms an abscess. Now for the abscess, the treatment would be a USG guided drainage. Why? Because of osmosis, and it does not hamper your breastfeeding. Now if it is more than 3 cm or more than 30 ml of pus, then you would require a vacuum suction catheter inserted on your USG guided. Now the patients are reviewed on alternate days with the help of your ultrasonography and your clinical examination. Now the residual collection should be aspirated and catheter is irrigated with your normal saline on each visit until complete resolution, and antibiotics are usually given for 14 days. So this is your clinical presentation of your breast abscess, and this is your closed suction drainage which is being done. So the important point is that breastfeeding is encouraged during your breast abscess. Then you have your subacute and chronic inflammations of the breast. So they are like lactational mastitis. So inflammation in your nulliparous woman and minimum 6 months after cessation of lactation. So the question that is often asked is, what is the duration that you need to consider after cessation of lactation for it to call a non-lactational mastitis? So the answer over here would be minimum 6 months. Then your the examples of a subacute or chronic inflammation includes your periductal mastitis, idiopathic granulomatous mastitis or tubercular mastitis. Now first, your periductal mastitis. So periductal mastitis is your autoimmune, and it may progress to subareolar inflammatory mass, separate and form the subareolar abscess. Now the thick areolar muscle do not allow the abscess to perforate, as a result of which what happens is that the pus follow the path of least resistance, rupturing the skin at your areolar edge and forming your mammary or milk duct fistula. Now this chronic indurated mass beneath the areola may actually mimic like your carcinoma, and the fibrosis of in and around the major duct causes a nipple retraction. So this is an example of your retracted nipple and your milk duct fistula that is formed in your periductal mastitis. So the presentation would be a non-cyclical pain, pus discharge, subareolar tender mass or mammary duct fistula, and on examination you will usually have a tender firm subareolar lump or abscess, purulent nipple discharge, thickened major nipple ducts, transverse slit-like nipple retraction looking like fish mouth. USG would have your thickened major milk ducts with surrounding inflammation or abscess, and lump should be biopsied, and the pus discharge for culture sensitivity with gene expert to check for the tuberculosis complex and resistance to rifampicin. The most common organism isolated are your staphylococci, enterococci, anaerobic streptococci and bacteroids. The treatment includes your antibiotics and the needle aspiration of the abscess, and surgical treatment is required for your surgical treatment would be required specifically, right? for your mammary duct fistula or a subareolar abscess, or if the patient is having sepsis, that is a major middle duct excision. 1.5 to 2 centimeter ductal cone should be excised, right? And smoking cessation should be encouraged to prevent recurrence. And then we have your IgM that was asked in your question. So it is benign, it is self-limiting, young Paris woman within the first few years after pregnancy. Now it is associated with your Corynebacterium croppenstedii. Please remember this name, even I do not know how to pronounce it. It's Croppenstedt T, right? Now it presents as a single or multiple central or peripheral inflammatory breast mass with or without abscess formation. Now they are associated with your skin ulceration, nipple retraction, sinus formation, pearly orange, or axillary lymphadenopathy. So you can see that it actually mimics a carcinoma. Needle biopsy for the diagnosis of your IgM. Tissue aspirate should be sent for your gram stain, AFB, and fungal stain. Histologically, it is a non-caseating granuloma, and your differential diagnosis includes the tuberculosis, foreign body reaction, and sarcoidosis. Now the treatment would be symptomatic, and in those with infection you would need to give antibiotics and NSAIDs, and in TB endemic countries you need to actually avoid your anti-tubercular as a blanket therapy, and it should only be given in cases which are confirmed by your gene expert. Now if there are persistent symptoms, then you would require treatment with prednisolone or a methotrexate. And a major middle duct excision in case of a mammary gland fistula, and excision of chronic abscess cavity performed in patients with recurrence. Now the next non-inflammatory acute or the chronic inflammatory disease is a tuberculosis of breast, which is uncommon, and it spread from the axillary or the internal mammary lymph nodes or the pleural cavity, cracked nipple, or the hematogenous root. Now multiple chronic abscess or sinus with typical bluish discoloration of the surrounding skin. So this would be your clinical or the classical presentation of your tuberculosis of breast. Now the diagnosis would be bacteriological or histological, and the treatment would be your anti-tubercular therapy, that is around 6 to 9 months. So this is your some of the images demonstrating your tuberculosis of the breast. So this were your few important conditions of the inflammatory and conditions of the breast that we had to discuss, and a few other important conditions from the breast apart from the breast carcinoma that we had already discussed is your benign tumors, specifically being your fibroadenoma and phylloid. So just let's take a look at the few of the important points of your fibroadenoma and phylloids. So it is the most common cause of lump in women aged 15 to 25 years, that is fibroadenoma. Then it arises from the hyperplasia of epithelium. It has a well-defined capsule. Its regression with anti-estrogen drug has been observed with your tamoxifen and ormeloxifene. Now giant fibroadenoma are defined as size more than 5 centimeter. Then we have this image showing a giant fibroadenoma. Now if you look at this submammary incision, so this can be actually asked as a question. This is known as your Gallard-Thomas incision. Now the relative risk of fibroadenoma 1.5 to 1.7 if simple, 3.4 to 3.7 if epithelial hyperplasia, and 3 to 4 for complex. So with family history, particularly lobular carcinoma. Now what are your indications for your surgical excision? That is age over 30 years, suspicious feature of imaging microlobulation, a TP on histology, size more than 5 centimeter, family history of breast cancer, and patient's preference. So these are the indications where you would offer the patient surgery in case of fibroadenoma. Now excision in elderly should include a rim of normal tissue as it may contain malignancy or phylloids. So let's take a look at some of the important points of the phylloid. Now this phylloid is known as your cystosarcoma phylloids. It is usually in the age over 30 years, overlying skin ulcerated. Why? Because of the pressure necrosis. Now they are mobile on chest wall and rarely infiltrate skin until late. Now it is a true mixed neoplasm containing epithelial and mesenchymal components. Now classification according to the histological behavior is on benign, borderline, and malignant. So Benign are those which have the mitotic rate less than 4, tumor margin pushing, mild pleomorphism and low stromal cellularity. Then you have your borderline, which is 5 to 9 per 10 high power field mitotic rate, moderate tumor margins, moderate pleomorphism and moderate stroma cellularity. And then malignant is more than 10 high power field, infiltrative tumor margin, severe pleomorphism and high stroma cellularity. The treatment would be your wide local excision, which is including a 2 cm margin, and you have your systemic chemotherapy that is reserved for your malignant phylloids. Now post-op radiotherapy, that is for your recurrent and your malignant phylloid tumor. And if you look at this image, this is your image of your phylloid tumor, right? Please remember the skin necrosis that happens is because of the pressure, that is skin ulceration, that is because of the pressure necrosis. Now a few important points of the for galactosele. These are solitary subaerial milk filled cyst during or just after lactational, disappear completely, single aspiration or reappear on reaspiration. Then you would be required to do reaspiration, and breastfeeding encouraged or continued. Then nylon 20 must be passed to clear your blocked ducts. So these are your few important points with respect to your galactosele. Now let's move on to the next question. So now we move on to the discussion for the questions that were asked from your urology section. So urology is also not a very important, but it's an important topic, as you can get around 2 to 3 questions in each paper, and the questions are usually mainly focused on your pediatric urology and your renal tumors. So let's take a look at the questions that we have. So the first question that we have is, which of the following is a part of hypospadias operation? Orthoplasty, yes. Glanuloplasty, it's not glamular, it is granuloplasty, yes. Myotoplasty, yes. So the answer would be all. So let's take a look at the important points of your hypospadias. So hypospadias is your most common congenital malformation of the urethra. It occurs 1 in 300 male live births. It is the condition where your urethral meatus opens on the underside of the penis or the perineum, that is your ventral side, proximal to the tip of glans penis. The characteristic features include your external meatus opens on undersurface of penis or perineum. Ventral aspect of prepuce is your poorly developed, that is your hooded prepuce, and your ventral deformity of the erect penis, that is chordee. And the most common type of your hypospadias is your glandular type. So you can look over here the various type of hypospadias. You need to remember the most common type, that is your glandular, and the most severe, that is your perineal. Then this hypospadias may be associated with your undescended testes or your inguinal hernia. The patients usually have your difficulty in urinary stream or the painful erection, and may be associated with your infertility. So obviously this painful erection and infertility would be specifically for your elderly populations, which are usually missed in your childhood. Now regarding the principles of operation, so this would be the correct order. There have been questions that have been asked in your, what is your order of your hypospadias correction. So first you have your correction of chordee, that is orthoplasty, then construction of the urethra, myotoplasty, meatal stenosis dilation, and glanduloplasty, that is construction of your glans penis. Then apart from hypospadias, you need to know and differentiate it from your epispadias, which is your dorsal penile defect. So hypospadias is your ventral defect and your epispadias is your dorsal defect, and it is a part of extrophy epispadias complex, and the most severe variety is your ileocecal extrophy. So if you can see over here in this image, this is an example of your epispadias, right? So this were your few important points that you need to remember with respect to your hypospadias and epispadias. So let's move on to the next question. So this question is on your renal stones. Which one of the following is correctly matched? Coffin lead crystals to white stone, hexagonal cystine stone, envelope calcium oxalate, all of the above. So the correct answer over here is all of the above. Right, so let's take a look at the important concepts of your renal stone. So the various type of renal stones are your calcium stone, which is your most common stone, and this calcium oxalate stones are either monohydrate, which is dumbbell shaped, or dihydrate, which are tetrahedral shaped. The most common metabolic abnormality associated is your hypercalciuria. The most common disease associated with hypercalcemia and stone disease is your primary hyperparathyroidism. So please do not make a mistake in this. The most common metabolic abnormality is your hypercalciuria, and the most common disease associated with your hypercalcemic and stone disease is your primary hyperparathyroidism. Then you have your calcium phosphate, which are your brustite or brush brittles, usually seen in distal RTA, and they are your needle shape. RTA over here is your renal tubular acidosis, and calcium phosphate apatite is seen in your infection. Then you have your uric acid stones, which are amorphous shaped, low urine volume, acidic, pH less than 5.5, usually associated with your diabetes mellitus, and hyperuricosuriia is seen in gout and your myeloproliferative disorders after cytotoxic treatment. Then you have your cystine stones, which are hexagonal in shape. Now they are associated with your genetic abnormalities. They have defect in your dibasic amino acid transporter. Now examples are cola, cysteine, ornithine, lysine and arginine. They are very hard because of the disulfide bond. Now what is the important significance of it? They do not fragment with your shock wave lithotripsy. Then we have your infection stones, which are your triple phosphate struvite, and they are your coffin lid shaped stones. Now they urea producing organism which produces ammonium, hence makes it alkaline, and important organisms associated are your Klebsiella and Proteus. Then we have your xanthine stones, which are associated with your xanthine oxidase deficiency, generally associated with increased allopurinol. And then you have your drug induced. The most important drug that you need to remember is your indinavir. So this were your few important points with respect to your renal stones. Now the types of renal stone. Now regarding the etiology of renal stone, so you have a hypercalciuric. In GIT it is due to the increased reabsorption. In case of the kidneys, it is because of the increased calcium excretion in kidneys, that is seen in your renal tubular acidosis, Barton syndrome, Dent syndrome. Then you have your hypercalcemia, and that is because of prolonged immobilization, milk alkali syndrome and hyperparathyroidism. Then hyperoxaluria, that is because of bowel resection, fat malabsorption, increased oxalates in gut, which causes increased load at kidney. Then you have your primary hyperoxaluria, which is autosomal recessive, type 1 being because of alanine glyoxylate deficiency, and type 2 being your D-glycerate dehydrogenase deficiency. Then you have your dietary hyperoxaluria, and the non-modifiable factors includes your age, gender, ethnic group and your family history. The modifiable factors are your environmental factors and drugs. So the clinical features would be, in case of a renal calculus, they might be asymptomatic dull aching pain, hematuria or a non-functioning kidney. In case of a ureteric calculus, it is basically an acute intermittent loin to groin pain associated with your nausea. Then there may be dysuria, hematuria, fever, and patient may also present with sepsis. So the investigation of choice is your NCCT, and you also need to do the metabolic evaluation, specifically your calcium levels. Then the non-surgical management includes your watchful waiting, specifically for your less than 5 mm stones and have intact renal function, non-obstructive and lower port renal calculi. Now medical expulsive therapies with the help of tamsulosin. Now end shock wave, extracorporeal shock wave lithotripsy. So it is an outpatient basis procedure. The stone is localized using a fluoroscopy. Then the acoustic pulse waves are generated and focused on the stones. Now the stone fragmentation occurs as a result of mechanical stress caused directly by the energy transmitted by the incident shock wave and indirectly by the collapse of the bubbles. Now the efficacy of shock wave lithotripsy reduces with an increasing number of stones and the volume of stone burden. Now you need to remember another important point over here, that is regarding your stentresse, which means the streak of stones closely gather stored fragment at the distal end of the ureter. So this occur when the stone burden is high or when the stones are hard, so they may cause obstruction requiring surgical intervention. And now clinically insignificant residual fragments are residual stones, fragments of 4 mm in size or less after treatment that are expected to pass spontaneously. Around 20 to 40% of these fragments may not clear and form a nidus for stone regrowth. Now the surgical management includes your indications for your failure of medical management, impaired renal function, chronic infection, patient preference and high risk occupation or your geographical location. Now another important point over here is regarding your endourology. So you have your ureterorhinoscopy. So your ureterorhinoscopes are long thin scopes that are used to remove ureteric and renal stones. They have working channels that allow for the introduction of energy sources, graspers and basket. Now the current models are using your semi-rigid or flexible scopes. So URS can also be patient with bleeding disorders with a moderate increase in complication. Now regarding your retrograde intrarenal surgery, now the indications include renal stones less than 2 cm, lower pole calculi, obesity, musculoskeletal deformities and your bleeding diathesis. With respect to your percutaneous nephrolithotomy, this involves the removal of renal stones by creating a tract between the skin and the pelvic-calcial system. Now typically this procedure is done in your prone position. Fluoroscopy or ultrasound is used for localization. The most common site chosen for entry is your posterior lateral calyx, and ultrasound in conjunction with pneumatic or laser lithotripsy is the most common energy source used. Complications include your bleeding and pleural dilation, and the indications are renal stones more than 2 cm, lower pole renal stones that are unfavorable for shockwave lithotripsy, a failed RIRS or SWL and a staghorn calculi. The contraindications include your pregnancy, untreated UTI, bleeding diathesis and current anticoagulation. Then you have your miniaturized percutaneous nephrolithotomy that involves the use of smaller SS tract. The standard PSNL tract is more than 28 FR compared with your miniature, which is less than 22 FR tracts. Now this miniature is mainly useful in patients with smaller stone burden and in children, and your lateral and supine PSNL are associated with fewer anesthetic complications. And you have some non-endourological surgical management, which includes your pyelolithotomy and anatropic nephrolithotomy. In case of pregnancy, we have most common stone being the calcium phosphate, the primary mode investigation being an USG, absolute contraindication to shockwave lithotripsy, and URS for distal ureteric stone and PSN for as an interim procedure. Now in case urolithiasis in children, it is much more common in male, the most common being your calcium oxalate and genetic disorder in 17% of children with stones. So this were your few important points with respect to your renal stones. Now moving on to the next question, we have the most common cause of bladder outlet obstruction in male child. So it is a straightforward question. The answer is PUV, which is your posterior urethral valve. So let's take a look at the bladder outlet obstruction in general and a few important points of your posterior urethral valve. So first, regarding your bladder outlet flow obstruction, now this is your low flow rates in presence of your high voiding pressure, right? So if you look over here in this diagram, which is showing your normal flow rate, and this below diagram, that is your figure 84.5. Now these images have been taken from your Bailey and Love. It is showing a low flow rate with a low voided volume of about 200 ml, but with a marked decreased flow rate. So this is your bladder outflow obstruction, low flow rate in presence of your high voiding pressure. Now your causes include your benign prostatic hyperplasia, bladder neck stenosis, bladder neck dyssynergia, bladder neck hypertrophy, prostate cancer, urethral stricture, and in case of a male child, it is posterior urethral valve. So what happens on bladder? The flow rate normal is more than 200 ml of voided urine with peak flow rate of 15 milliliter per second. Now low is your less than 10 ml and equivocal is your 10 to 15 ml. Now voiding pressure is normal is less than 60 centimeter of water, equivocal would be 16 to 80, and high would be more than 80 centimeter of water. So the long term effects include the bladder may decompensate, detrusor contraction becomes less efficient, as a result of which your residual urine volume develops, leading to your chronic retention. Now the bladder may become more irritable during your filling with a decrease in your functional capacity, partly caused by your detrusor overactivity. So the complications include acute retention of urine, chronic retention of urine, impaired bladder emptying, hematuria. Right. So how are the patients of LUTS assessed? So the investigations of men with LUTS includes the essential investigation, which are urine analysis by dipstick for blood, leukocyte esterase, glucose and protein, urine culture and infection, serum creatinine, urine flow rate and residual volume measurement. And your additional investigations include PSA and your pressure flow studies. Also included are your pressure flow, urodynamics, flow rate measurement, upper tract imaging and cystourethropy. Now for bladder outlet obstruction, the most common causes in adult is your benign prostatic hyperplasia. So the causes are your increased estrogens, intermediate peptide growth factor, metabolic syndrome and hereditary factors. The pathology includes affects the both glandular as well as the connective tissue stroma. Now they affect the transitional zone of the prostate. Now compression of the peripheral zone causes the false capsule, which is your lateral lobe. And when it affects your central land, the middle lobe develops that project into the bladder within the internal sphincter. So this is your diagram of a late stage of bladder outlet flow obstruction. Now what is important is to know the consequences of the BPI. So they may have no symptoms and no BO, no symptoms but urodynamic evidence of BO, LUTS with no evidence of BO, LUTS or BO, others that include your acute or chronic retention, hematuria, urinary infection and stone formation. So LUS is your lower urinary tract symptoms and BO is your bladder outlet obstruction. Now anatomic effects include your on the urethra, the prostatic urethra is lengthened sometimes to twice the normal length. The normal posterior curve may be so exaggerated that it requires a curved catheter to negotiate it. Then in case of bladder, the musculature of the bladder hypertrophies to overcome the obstruction and appears trabeculated. Now the significant BPH is associated with increased blood flow and the resultant veins at the base of bladder are apt to cause hematuria. So you can see at this image, this is the trabeculae, this is a trabeculae formed case of a bladder outlet obstruction. The management includes indications for treatment, that is acute retention, chronic retention, complications of BO, hemorrhage and severe symptoms. Now the drugs are your alpha adrenergic blocking agents and your 5-alpha reductase inhibitors. And your surgery would include your prostatectomy. The various route includes your retropubic, through bladder and your transurethral and perineum. Now TURP remains the most commonly performed surgical procedure for the correction of your bladder outlet obstruction. So what happens over here is that the strips of tissue are cut from the bladder neck down to the level of perimontanum. Now this cutting is performed by a high frequency diathermy current which is applied across the loop mounted on the handheld trigger of rectoscope. Now the coagulation of bleeding points are achieved and the chef or prostate are then removed from the bladder using an Ehrlich evacuator. Now this resection proceeds at 1 gram per minute in your experienced hand. The duration of resection for the monopolar TURP is limited to 1 hour. Why? Because of the risk of resorption of water if 1% glycine is used as an irrigant. So the advent of this bipolar TURP where normal saline is used as irrigate permits the resection of your larger prostates. So following TURP, careful hemostasis is performed and a 3-way self-retaining catheter is irrigated with isotonic saline introduced into the bladder to prevent any further bleeding from forming blood clots. So the irrigation is continued until when the outflow is pale pink and the catheter is removed on the second or your third postoperative day. Now in men with small prostates or bladder neck dysgenesia or stenosis, it is better to divide the bladder neck or the prostatic urethra with a Colonic knife or a laser. Right, so laser prostatectomy what do we use is your holmium laser enucleation of prostate, and the complications include hemorrhages, sepsis, incontinence, retrograde ejaculation, bladder neck contracture, water intoxication. So this is one of the most important complications of your prostatectomy, that is water intoxication. So what happens over here is absorption of water into the circulation at the time of transurethral resection give rise to congestive cardiac failure, hyponatremia and hemolysis. So important thing to remember is your hyponatremia. So what happens over here, confusion and other cerebral events often mimicking stroke. So the incidence of this condition has been reduced since the introduction of your isotonic glycine for your irrigation during section, and further still will with the development of your bipolar TRP where saline is used as irrigant. So the treatment consists of your fluid restriction. Now the next important point that we'll discuss is regarding your posterior urethral valves. So it is the congenital symmetric valve in your posterior urethra below verumontanum. So if you look over here, this is your lateral view showing a dilated posterior urethra, which is A, with a trabeculated bladder, right, and the C is your posterior urethral valve. Now what are the features? Obstructed flow of urine, cricket wall bladder, and they may be associated with your vesico-urethral reflex, and the treatment includes your fulguration of your posterior urethral valves and your endoscopic destruction. So this were your few important points with respect to your posterior urethral valve, bladder outlet obstruction and your benign prostatic hyperplasia. So let's move on to the next question. A 50-year-old male patient came to the outpatient department with complaints of hematuria. A 22 centimeter bladder mass was seen which has a high-grade transitional cell carcinoma. Which among the following is the ideal management? So here the answer would be your transurethral resection of the mass. So bladder carcinoma is an important topic. So let's take a look at the important points from your bladder carcinoma. So the most common type of bladder carcinoma is your transitional cell carcinoma. Squamous cell carcinoma occurs secondary to chronic inflammation, and adenocarcinoma in urachus or bowel in urinary tracts, like the bladder extrophy repair. The risk factors include your smoking, occupational exposure, environmental carcinogen, specifically arsenic, chronic inflammation of the bladder. So you have your indwelling catheters, stones such as stomatosis which predisposes to the squamous cell carcinoma, and your recurrent infection leading to keratinizing squamous metaplasia. Then your drugs include your phenacetin and your cyclophosphamide. Then your staging. So for staging, this is a beautiful diagram taken from your Bailey and Love. You have TIS, which is your urothelial carcinoma in situ. Then you have your TA, which is your non-invasive papillary urothelial carcinoma. T1 is invasive into your lamina propria. So you look over here, this is your T1 invasive into lamina propria. T2A is invasion into your inner half of your muscularis propria. So you can see over here this particular part, that is invasion into the inner half of the muscularis propria. Then we have your T3A, which is your microscopic invasion, T2B invasion into the outer half of the muscularis propria. Then you have your T3A, which is your microscopic invasion into the perivesical tissue, right. Then T3B is your microscopic invasion in your perivesical soft tissue, and T4 is your invasion into your adjacent organs, right. Now the investigation includes your urine, CT urography, MRI and cystourethropy, which is your mainstay of a diagnosis. Now in case of your non-muscle invasive, you would require a transurethral resection, mitomycin C installation and your intravesical BCG. Whereas if it is a muscle invasive tumor, then you would be requiring to do a radical cystectomy with urinary diversion or your chemoradiotherapy. So apart from bladder tumors, next important tumor in that is often asked is with respect to your testicular tumor. So we'll take a look at the important points from your testicular tumors also now. So tumors of testes, the predominant histology is germ cell tumor. Seminoma is seen in the fourth decade. The pathognomic of your adult GCT or germ cell neoplasia in situ is your isochrome or short arm of chromosome 12. The risk factors include your cryptorchidism, male factor infertility, and family history of testicular tumor. So the classification includes your GCTs, which are your seminoma, embryonal cell carcinomas, York sac, teratoma, and choriocarcinoma, and the sex cord stromal tumor, which is your Leydig, and others are your lymphoma. Then some important points regarding your seminoma. So this are your oval cells with clear cytoplasm and large rounded nuclei with prominent acidophilic nuclei. So the sheets of cell resembling your spermatocytes separated by your fine fibrous stroma. Active lymphocyte infiltration of the tumor, which has a good host response and a better prognosis. It's spread via the lymphatics to the para-aortic lymph node. The first line investigation is your ultrasonography. Now, in case of a non-seminomatous germ cell tumor, you have your embryonal carcinoma, which is highly malignant, invading the cord structure. York sac tumor is your single tumor type in children, mixed in adults, and secrete alpha fetoprotein. Teratoma, you have your immature contents, which could be neuroectodermal or mesenchymal, and mature contents are your cystic with epithelial differentiation or consist of your smooth muscle, connective tissue, cartilage. Now all of them can metastasize. Now choriocarcinoma is never seen in childhood, produces your HCG and metastasis involved to the lymph node and the bloodstream. Then you have your Leydig cell tumors, which are your most common type of your sex cord stromal tumor, constituting your 1 to 3% of your testicular tumors in the adult and 3% of the testicular tumors in infants and children. These tumors are around 8% of your patient with Klinefelter syndrome, and they are well defined on histology and usually 5 centimeter diameter. Most of these tumors are benign, and the malignant transformation occurs in around 10% and is related to increased size, increased cellular atopia, increased cell proliferation, necrosis, vessel invasion, and DNA aneuploidy. So this is an example of the image of the teratoma of the testis. Then a few important points regarding your Sertoli cell tumors. The mean age is around 45 years and it is in patients with Creutzfeldt syndrome and androgen insensitivity syndrome. So the clinical features include your painless testicular lump. It may present as a solid mass or a secondary hydrocele may be present. Investigations are your USG and your blood markers, which are alpha fetoprotein, HCG, and your LDH. So alpha fetoprotein is elevated in around 50 to 70% of non-seminomatous germ cell tumors, HCG around 40 to 60% of non-seminomatous germ cell tumor and 30% of seminomas, and LDH is expressed on 12p amplifying in testis cancer cell. So the elevated levels are high tumor burden in seminoma and your recurrence in your non-seminal germ cell tumor, that is for your LDH, that is your lactate dehydrogenase. Now chest x-ray may have your cannonball metastasis. Now why I have marked biopsy, FNAC and cancel? Please remember, if you have a case of testicular tumor, do not go for a biopsy or a FNAC from the tumor mark. The treatment would be an orchidectomy, doing an orchidectomy, and that would be actually your biopsy. So men should be offered semen analysis and sperm banking, and the treatment would be include your radical orchidectomy. And then we have your staging of your testicular cancer. So at least remember guys the T staging. So you have your T1, which is tumor limited to your testes and epidermis without lymphovascular invasion, and they may invade tunica albuginea but not to be tunica vaginalis. PT2, that is a tumor limited to testes and epididymis with your lymphovascular invasion or tumor involving your tunica vaginalis. Then you have PT3, that is tumor invades the spermatic cord with or without lymphovascular invasion, and PT4, that is tumor invades the scrotum with or without lymphovascular invasion. Right. So in case of non-metastatic stage 1 seminoma, you can go for a radiotherapy. In case of non-seminoma, you go for a chemotherapy that includes bleomycin, etoposide, and cisplatin. And then for metastatic, you would go for a chemotherapy, that is 3 cycles of BP or 4 cycles of etoposide or cisplatin. So these are your few important points with respect to your testicular tumor. And the next important urological cancer that I would want you all to remember is regarding your renal cell carcinoma. So I think the next question that I have is on renal cell carcinoma. So let's discuss that, and then we discuss the important points with respect to your renal cell carcinoma. So over here we have, which of the following is true about clear cell renal carcinoma. So now these are sort of your surgical pathological correlation which you guys need to know. So option contains glycogen and lipid. Option 2 mostly sporadic due to deletion of chromosome 3q arises from DCT. Okay, so the first statement is true, it contains glycogen and lipid. Mostly sporadic is true. Due to deletion of 3q, no, it is due to deletion of 3p. Then arises from DCT, no, it arises from your PCT. So the answer over here will have been 1 and 2. Right, now let's take a look at the some of the important points from your renal cell carcinoma. So it is the most common solid neoplasm of the kidney. The classical or the salient features of the various subtypes. Clear cell, it is the most common subtype, usually sporadic, may be associated with loss of chromosome 3p and mutated non-Whipple-Lindau gene. Then papillary type 1 and type 2. So it is the second most common. Type 1 tumor has a better prognosis compared to your type 2. Then you have your chromophobe renal cell carcinoma, which is usually sporadic but may be familial and have good prognosis. Then you have your collecting duct carcinoma, which is aggressive tumor, arises from the renal medulloma, and hence it is a centrally located tumor. Then you have your renal medullary carcinoma, which is rare, very aggressive, associated with your younger age and sickle cell trait, and it is also a centrally located tumor. The risk factors include smoking, obesity, hypertension, diuretics, occasional exposure to dyes and petrochemicals. Then your classical triad is your flank pain, hematuria and palpable mass, and the most common presenting symptom is your hematuria. Now paraneoplastic syndromes are present in almost 1/3, the most common being your increased ESR, and the most common site of metastasis is your lungs, which is presenting as your cannonball mets. So diagnosis would include your blood investigation, but the investigation of choice is your triphasic CCT. Then for your staging, you have your stage 1 tumors, which is tumor less than 7 cm but limited to kidney. Stage 2 is tumor more than 7 cm but limited to kidney. Then stage 3 is your tumor in major veins or adrenal glands with intact Gerota's fascia. Please remember, in stage 3 your Gerota's fascia is intact, whereas in stage 4 there is breach of your Gerota's fascia. Now the prognosis would depend upon your tumor size, venous invasion, renal capsular invasion, and your adrenal involvement. So gold standard for your localized disease is your radical nephrectomy. For tumor less than 4 cm, you would go for a nephron sparing surgery. That is for less than 4 cm, and in selected cases you might do in the range between the tumor size of 4 to 7 cm. Now nephron sparing surgery would be required in case of a bilateral tumor and tumor in solitary kidney and pre-existing renal dysfunction. Right, in case of IVC thrombus, now renal tumors are associated with IVC thrombus in how many cases? 5 to 10% of cases. Now this tumor thrombus may extend as far as well up till the right atrium. Now tumors extending into the retrohepatic or the suprahepatic segment of IVC require full mobilization of the liver, and the thrombus extending into the right atrium may require cardiopulmonary bypass and circulatory arrest. Now you have your metastatic renal cell carcinoma. That is, up to 1/3 of the patient will have your disseminated disease. Tyrosine kinase inhibitors that inhibit the vascular endothelial growth factor like sunitinib and pazopanib, and these drugs have improved survival in your metastatic renal cell carcinoma. So renal cell carcinoma is an immunogenic tumor that responds to immunotherapy. So the first generation of agents are your interleukins and interferons. So cytoreductive nephrectomy may be beneficial in your good and intermediate risk patients, and palliative nephrectomy may be considered for your intractable hematuria, pain and symptomatic PNS. So embolization of your renal tumor can be performed in medically unfit patients with intractable hematuria. Right, so this were your few important points of your renal cell carcinoma. So the questions are usually framed from this particular point. Now another important tumor in with respect to your renal system is your Wilms tumor. So that is the most common tumor of the childhood. Around 5% of childhood cancer, bilateral in 5%, familial in 1% between 1 to 4 years. Pain is uncommon. Large palpable mass that cross midline. Most common site of distant metastasis is lung. So cross sign, that is your tumor infiltrate kidney. Normal renal parenchyma compressed at your periphery. So it has mixed elements which include your blastomal, epithelial tube and stoma. And treatment is nephrectomy with pre or post-op chemotherapy. Now apart from this, some benign tumors of kidney have also been asked in your INI exam. So let's take a look at the renal oncocytoma and renal angiomyolipoma. So renal oncocytoma, this is 5% of the renal tumor, high abundance of oncocyte in 7 decade, much more common in male compared to female. It may coexist with your renal cell carcinoma approximately around 10%, and in radiology you have your central stellate scarring and a spoke wheel appearance in angiographic phase, and your treatment would be a partial nephrectomy. So now renal angiomyolipoma, so this is often asked you with an image of a CT scan given, right? So they are usually detected incidentally, much more common in female, associated with tuberous sclerosis, maybe sporadic in nature. So in USG they usually have a bright echogenic marks or a fat content, and in CT you have your -15 to -20 Housefull unit within the mass. So that is the hallmark, and you might actually get a CT image for the diagnosis of your angiomyolipoma. So if you look at this image over here, you have your renal angiomyolipoma, which is your -15 to -20 Housefull unit on your CT scan. So treatment would be your less than 4 cm requiring follow-up, 4 cm requiring nephron sparing surgery, and if there is acute hemorrhage you would require your angioembolization. Now drugs that inhibit mTOR has good effect in tuberous sclerosis, that is because of your activation of your mTOR pathway, right? So this were your few important questions regarding your renal tumor. So let's move on to the next question. The next question that we have is a very straightforward question. Bosnack classification is used for, it is used for renal cyst. So let's take a look at the Bosnack classification. So Bosnack classification says about the malignant potential of your cystic lesion. So the category 1 or the class 1 is your no septa, no calcification, no solid component, no enhancement. So around 0% are malignant in this. Then you have type 2 again, which are 0% malignant. So they have few hairline, thin, less than 1 mm septa, thin calcification and well marginated. Then 2F, that in which around 5% are around malignant. So they have well marginated, no enhancement, high attenuation lesion more than 3 cm, totally intrarenal, and they require follow-up at 6 months, 12 months and 5 years. Now type 3, which is around 50% malignant, so they are thick, irregular or smooth walls or septa. Measurable enhancement treatment includes a partial nephrectomy or radiofrequency ablation in your post-surgical candidates. Now type 4 are your 100% malignant, that is type 3, plus your enhancing soft tissue component adjacent to but independent of wall or septum. Now the treatment over here is your surgery. So this is your Bosnack classification. So they might just ask you directly and give you an image and ask what is the type of your Bosnack class, the type of Bosnack classification from the image, or they may actually give you a CT scan image, which would where you need to just look at the particular tumor and see if there are well marginated, presence of calcification, or if there are components which are enhancing in your CT scan image to form your diagnosis of the type of Bosnack cyst. So this were your few important questions from the urology section. Now let's move on to the 2 to 3 miscellaneous questions that we have. So the first miscellaneous question from the miscellaneous section that we have is, from the plastic surgery. So we have the next two questions from your plastic surgery. So what we'll do is we'll like first solve the questions and then discuss in details about them. So first is you identify the true statement regarding your split skin and your full thickness skin graft. So primary contracture is more in split skin graft. No, it is more in your full thickness skin graft. Then secondary contracture is more in split skin grafts. So this is a true statement. Then primary contracture is more in full thickness graft. This is again a true statement. And secondary contracture is more in your full thickness graft. This is a false statement, right? So the answer over here will be option A, that is 2 and 3. So let's look at the next question, then we will discuss regarding your skin grafts and your flap. So which of the following is correctly matched? Cormack-Lamberti classification for muscle flap, Mattheis-Nehais classification for your fasciocutaneous flap. So the answer is none. Now for fasciocutaneous flap you have your Cormack-Lamberti classification, and for your Mattheis-Nehais classification you have your muscle flap. So these are your recent additions of your in your Bailey and Love 20th edition, and hence they have been included in your this test paper. So let's take a look at a discussion of your grafts and flaps in a nutshell. So skin grafts, so they are transferred without their blood supply. Now split thickness includes your epidermis and variable amount of dermis. They are also known as Thiersch graft. They are simple to harvest and large areas of skin to reconstruct sizable defect following significant burn injury. Then you have your full thickness, which includes your epidermis plus dermis. As it contains dermis, they retain elasticity and less prone to secondary contracture. Now also known as Wolf's graft. Harvest site include a supraclavicular region, groin crease and your post-auricular region. Now they are used for your syndactyly release, contracture release and reconstruction of your facial defect. Now composite skin graft is your skin plus another tissue. Example, helical root of tear to construct your eyelet of nose. Now stages of skin graft is your imbibition, where your plasma from the wound, which is your imbibition of the plasma from the wound bed. Then is your inosculation, that is your capillary ingrowth and your fibroblast maturation and your new vascularization. So this is an example of your powered dermatome to harvest your skin graft. And this is your typical appearance of your split thickness skin graft. Now let's take an important look at some of the important flaps. So flaps are your block of tissue that contain innate blood supply. The pedicle, that is the base of the flap that contains your blood supply. So you have various flaps. Random flap, so there are the three sides of a rectangle with no specific relationship to the blood supply. Length to breadth ratio no more than 1.5:1. Axial, it is based on a known blood vessel. Pedicle, that is swung around the stalk. So if you look over here, this is an island or a pedicle flap, and then you have a free flap that is isolated, reconnected with your microsurgery. Then the chimeric flap, that is a multiple spatially independent flaps which have independent vascular supply and all pedicles linked to your common vessel. So this is an example of your chimeric flap, that is your anterolateral thigh flap comprising your spatially independent skin and muscle flaps with all pedicles linked to a common source of vessel. Right. Now regarding your local flaps, I would want you all to just remember this particular diagrams which have been taken from your Bailey and Love, as you might just be asked from the image like identify the type of the flap. So first we have your transposition flap, then you have your Z-plasty, which are true triangular transposition flaps interposed. So you have your bilobe flaps, which is used to close the convex defect. Then you have a bipedical flap, which is a bucket handle flap supplied from the both ends, used to rebuild the lower eyelid. So please remember this particular type, this particular example, as bipedical flap is often confused with bilobe flap. So bipedical flap is used to rebuild your lower eyelid. Then you have an example of rhomboid flap and a rotational flap as shown in the figure. Then what we were discussing is regarding your Mattheis-Nehais classification. So first we have your fasciocutaneous flap, which is your Cormack and Lamberti's flap. So if you look over here, these are your various types of your Cormac-Lambert. So first one that we have is your multiple large perforators, example being a Pontin flap. Then we have a single large perforator, that is your scapular or your parascapular flap. Then we have your small segmental perforators, which is your radial forearm flap. And then we have your osteomyofascial perforators, which is your free fibular type or the type 4 of your Cormac-Lambert's classification. Now the muscle flap, that is your Matthias-Nihai classification. So we have your type 1, where we have your single vascular pedicle, example being a tensor fascia lata. Then type 2, which is your one dominant with one or more minor segmental pedicles, that is your gracilis. Then you have type 3, that is your dual dominant, example being your gluteus maximus. Then you have your type 4, which is via segmental pedicles, right, that is your sartorius. And type 5, that is your dominant with several small or segment pedicles, right, so that is your latimus dorsi. Now, so this were your few important examples of your flaps and your types of flaps. Please remember the new classification of Cormac-Lambert and your Matthias-Nihai classification. They might ask you just the names or the examples from it. Now, one thing that we skipped while we were going, now these are your advancement flaps or a V2Y flap, which are usually used at your fingertip cuts, right. So let's move on to the next question. So this is with respect to your vascular surgery. In CEP classification, varicose vein is C2. So this is a straightforward question where we do not have any confusion. So just let's take a look at the CEP classification of the varicose vein. So for the CEP classification, etiological, congenital, primary, secondary and non-specified. Then you have your anatomical, that is a superficial vein, perforating vein, deep vein and non-specified. Pathological includes your reflux, obstructive and non-specified. And your clinical is your Z0, where you have no visible signs of venous disease. C1 is your spider vein, telangiectasia and your reticular vein. C2 is your varicose vein. Then you have your C3, which is your varicose vein with edema. C4 is your varicose vein with trophic changes, that is your 4A having your eczema, pigmentation, purpura. 4B is your lipodermatosclerosis and atrophic blanchet, and 4C, which is a new addition, that is your corona phylbacteria. C5 is a healed venous ulcer and C6 is your active venous ulcer. Now for corona phylbacteria, you might be asked a definition. So they are your malleolar flares which are fan-shaped pattern of telangiectasia on the ankle of foot. Now another sort of question that can be framed over here is regarding from your images. So if you look over here, this is your telangiectasia or your reticular veins. So telangiectasia are your thread veins, spider veins, which are tiny intradermal venules less than 1 mm. Reticular veins are in your range 1 to 2.9 mm. So if you look over here, these are your skin changes showing your lipodermatosclerosis. Now lipodermatosclerosis is your chronic inflammation and fibrosis of your skin and the subcutaneous tissue. Then your atrophic blanchet. Now these are your localized areas of your atrophic white skin. Now another important thing that is asked is your saphenous varix, that is your painless groin swelling apparent on standing. Then this is example of a pigmentation over here, which is your hemosiderosis, and this image showing your eczema. So they might just give you a particular image and ask to identify the type of clinical classification. So you need to remember this 4A, which shows your pigmentation, 4B like lipodermatosclerosis and atrophic blanchet, 4C that is a corona phylbacteria. Now varicose veins are more than 3 mm. So this is your image for your varicose vein. Now with respect to your varicose vein, you need to know that the investigation is your duplex ultrasound scanning, and your treatment would be your endothermal ablation, that is your gold standard, right. So various technologies that are used are your laser and your radio frequency. So apart from this in vascular, please do revise your aortic dissection, right. So now let's move on to the last question for our session. So again a very straightforward question. Masoka classification is used for, the answer would be thymoma. So let's take a quick look at the few important points of the thymoma. So this is the most common mediastinal tumor related to myasthenia gravis. It is the only reliable indicator of malignancy, that is a capsular invasion. Thymectomy is done for more than 5 centimeter tumors, and median sternotomy if tumor invasion, and if small you might treat it with your videoscopic assisted thoracoscopic surgery. Now Masoka's statement classification is used to stage the disease, and the more recently classification is your TNM. Right, now this is your mediastinal pathology, where you need to remember the type of tumor. So in anterior mediastinum you have thymoma, lymphoma, germ cell tumor. Superior mediastinum you have your lymphoma, thyroid, parathyroid. Mediastinum you have your cystic lesions, lymphoma, mesenchymal tumors, and posterior mediastinum you have your neurogenic tumors, cystic lesions, and mesenchymal tumors. Right, so this were the questions that I had for you guys in your this 3 days of your INI surgery classes. Now we'll be coming up with a lot of videos at your Game PG app. What I've tried to do in this 3 classes, as you must have seen, that I've just tried to focus on the important topics and not try to give you some new point. So just keep revising your important core topics, as revision is only the key to success. And in your quest for your final lap at your INI, I'll make sure that I'll come up with a few more important videos, which would be a clinical integrated videos of your anatomy, surgery, anatomy, pathology, so that it helps you. So all the best, keep revising. Any doubt, please drop a mail at ayushkeshav99@gmail.com. You might also post it in your Game PG website, where they'll get in connect with me, and I'll be happy to solve your doubts. So keep revising, have fun studying, and I'm pretty sure you guys will crack your INI exams. All the best.